Hello, good morning. Hello. Hello. Hi, good morning. You're doing well. You're holding up pretty well. It's the fourth day of the drill. Before I introduce you to Chip, I want to have you know that if you want.
Our house died. Our house audio. The house died. Okay. You can hear me though? Can everyone hear me? Okay. No. No.
Good morning. Good morning. Good morning. Good morning. Good morning. Good morning. There we go. There we go. There's a problem with this Ganavish. Couple of things. You should know that you will get are entitled to a 50%, oh my God, 50% discount on the video that is being taken of this, the edited video, which will be done maybe in a month. So that's one thing to know. And Advanced Boot Camp is available to you at 20% off the home study program for those two. This is Dr. Chip Lang. You met him yesterday. He went up the EMT PA ladder and has an ultrasound course that is really widely known. He's understood the value of ultrasound in the emergency department. He works in central Missouri at a town called Rawlins, and he's going to be doing the issue that we often talk about in terms of supervision, collaboration, those kinds of things. So, Chip, take it away.
Thank you. So just make sure that my mic's working okay. Okay, I can hear everything there. So as Rick was talking about, I practice in a rural part of Missouri, which is actually great for this kind of conversation because as we're going to talk about some of the statistics and what happens when you're practicing in emergency medicine, this is a lot of my life as far as what I see and what I can do because my practice is quite broad in what I can or can do, and same is true for most of the colleagues that I work with too. One of the nice things about being in emergency medicine versus some of your other specialties, including primary care, is the fact that no matter what, there's always someone that you can easily reach out to. Now, some of you may or may already be practicing in a situation where you don't have a physician right there. In fact, when I work on the ambulance, because I still do EMS as well as working in the emergency department, is I don't have a physician with me, but I have someone I can contact, or we have certain protocols or guidelines in place for me to be able to work off of if need be. One of the great things about being a PA is we're not like stuck with any particular set of guidelines or protocols most of the time. We have outlines that we use and we have department policies and those kind of things. But we do have flexibility in our clinical role and practice. And one of those things is the fact that if we get to a point where maybe this is a situation we haven't seen before, we feel less comfortable with it, anything like that, well, I can at least reach out to someone who might be more knowledgeable than me. And that doesn't include just the emergency department physician. We're talking about also our specialists. We usually have ease of access to that too. So, this is a very unique environment in that we have someone who is immediately able to help us, whether it's in person or at least with some kind of online direction, whether that's by a phone call or telehealth or those kind of things. Now, We work with different physicians, though, constantly as a result. So in my setting, I'm in a community-sized emergency department. I did work in a critical access hospital before that. And one of the challenges is that it's not like when you're in a surgery specialty where you're with one surgeon, you know how that surgeon acts, you know what they like, what they don't like. I can have one physician one day who absolutely loves and does things similar clinically to what I do, and then the following day, if I have that same kind of question, I might get a totally different response. And so there's a certain amount of collegial interaction there that can be really, really challenging, even on the best days, because of the fact that there are going to be differences in opinion. So it's even more important as PAs and NPs, I feel like, in a lot of ways, to be able to have good evidence to back up what we're doing, be able to talk that through and understand why we might have a particular suggestion. If we have one that we're trying to see, okay, where's the middle ground here? What can we do if I'm asking for help, or if I want some clarifications, or just a second opinion? Because sometimes that's another thing. You just want someone else to bounce an idea off of, and that happens all the time. And even my physician colleagues do the same thing with me. We have a very open, communicative relationship. It's excellent in that sense. You have to keep in mind, though, there are going to be policies that vary location by location. You might be in a situation where they tell you, okay, none of the ESI 1 or 2 patients we want you to see at all. Or anytime you see an ESI level 3 patient, we want you to talk to a physician about it too. And those policies a lot of times are built on some kind of background history, whether it's, hey, you know, PAs and NPs, they're new to this clinical environment. We want to make sure they're used to it. Or maybe it's when we have a lot of new grads, we want to make sure that the new grads at least have this. It might be that you can't manage certain patients, or they would prefer you not to manage certain patients. Maybe they don't want you taking the level 1, the critical strokes, the cardiac arrest, stuff like that. And then other places, like mine, it's basically, we trust your ability. You do whatever you believe is appropriate. You ask for whatever help you believe is appropriate, and that's fantastic. When I first started in that same department 6 years ago, it was not like that. I had to kind of break the mold there a little bit, but again, it was by showing and by demonstrating that skill set. So just to run through some numbers here, PAs, especially in emergency medicine, we've grown quite a bit. We continue to have some rapid growth. It seems like right now in emergency medicine, at least, there are still a little bit more males than there are females in emergency medicine. We tend to be a little bit younger than the nurse practitioner colleagues. Something that is potentially a benefit, and it just depends on your clinical environment and stuff like that. I will tell you, I got a little bit of a raise out of it, is having your emergency medicine certificate of advanced qualification. That CAQ can be something that is nice. You will not be able to get it fresh out. It's not like something that, well, I just graduated from my program and I'm going into emergency medicine, I get my CAQ now. No, you have to do like a couple years of practice. There are certain things you have to do in the background with it. But it's something that can help you with either future employment and or when you are trying to see about maybe, getting a raise or getting other responsibilities, stuff like that. For nurse practitioners, 90% of NPs in emergency medicine are female, and that tracks with where I'm at and a lot of places I'm at. Also a little bit older, so the average age being 49 years. More recently, there is now a dedicated ENP certification. Now, with the ENP certification, at least in a lot of places, and this may vary by location because it's a little bit different in how this is set up, but a lot of times ENPs, if they only have their ENP, if they have their FNP or they have their PNP, it's different, but they might only be able to see older patients, so they're not being able to see pediatrics, which was a deal breaker in a lot of rural emergency departments because they expect you to see the full spectrum. Again, that might change some by location. This is just more of my experience working with ENPs. So a lot of times we're hiring FNPs who may got their ENP later, or they're a PNP and ENP. But just something to kind of be aware about as well here. Like I said, with PAs and NPs, it really is all about the teamwork, and it's knowing your guidelines, it's knowing the policies at the hospital, it's being able to stick with that evidence-based guidelines and practice, and like I said, it's that much more important when you're talking about being APA or MP, and I know there are physicians in the audience and stuff too, but to be able to practice in a way that we can strongly back up and explain what we're doing is vitally important. But also, you really have to know your state laws, and you have to know the hospital's policies, not just in your department, sorry, not just in your department, but in general, because as I have come to find out over the years is that you'll have some other kind of more global policy that doesn't quite match your department's policy. And then that's where hopefully your medical director, the board, the administration, someone can help kind of clarify where those things line out. But if you don't know about it in the first place, that is a great way to get yourself in some hot water really quickly. And it gets very frustrating when that occurs. The statutes are, in most states, fairly broad. That continues to improve with time. But hospital policy can trump that as far as they say, well, we know what the state statute says, but we're going to narrow in the practice a little bit more. And one example of this in my own place was the fact that controlled substances took a little bit longer for us to use, even though state statutes said we could do it much sooner than that. When I was talking about the staffing and the supervision side of things, and as you might notice with state laws changing over time, we use a lot of supervision, but we're moving more towards collaboration. Missouri, just speaking out of personal experience again, Missouri just switched to collaborative. I much more appreciate that. My physicians don't see a lot of difference there because it's already collaborative, but the weight in the language and when I'm working with different positions and stuff, to be able to say this is a collaborative, not a supervising agreement, does put a little bit of ease on things. But as you might notice here, when we're talking about these numbers, 4s and 5s, ESI level 4 and 5, so our lower acuity patients here, tends to be pretty straightforward as far as, in theory at least. If you worked in emergency medicine any length of time, you notice that someone who got labeled as an ESI4 can easily turn into someone much more sick. But generally, it's a little more lax as far as you don't have to have real-time involvement of one of the physician colleagues. They most likely are not having to see that patient as well, though some places, maybe because of billing purposes or because of, again, just department policy, they end up seeing every single patient that you see. I worked briefly in a place like that, and it was very burdensome. It did not make things move at all. And basically the physicians were like, we don't want to do it this way, we want to switch. But most of the time, it's not until you get into the higher and higher acuities that you tend to have more and more physician involvement. Procedures. So these are some interesting numbers here. As far as the text here, percentage of EDs in which various procedures may be performed independently by at least one NP or PA. The part that really surprised me here is that just under 4% for laceration repair, I guess, could not do independently. Like someone had to eyeball. That just blows my mind because of all the lac repairs and stuff I do, every day. Same thing for IND. Some of these though makes total sense. Chest tube placement, cardioversion, stuff like that. Okay, yeah, I'm not expecting many places to have that done independently. Again, I've got the luxury, I can do those things independently. Most of the time though, I still have a physician nearby who is able to help, just because these tend to be very hands-on patients where we need the extra hands, the extra support. But it just kind of gives you an idea of what you might anticipate when you're looking at positions of, is this the norm or not? Do I have to have someone who is also involved so that way I can do X, Y, or Z procedure? Another thing to keep in mind is our setting. This is broken down by PAs, MPs, and then both. So overall, when it looks like what we're doing is that NPs tend to be, and I do stress, tend to be maybe a little more involved in the rural settings versus PAs tend to be a little bit more on the suburban to urban side of things. I can tell you that's changing a bit over time, and it just varies by location. One of the reasons why you'll probably see a little bit higher of rural NP numbers is just because of the fact that more and more states are moving to independent or autonomous practice, and so that can play its own role in that too. With PAs with optimal team practice, that might be changing more with time. That just, again, depends by the state level. So when we have our team characteristics and what we're looking for here, we're trying to, and apologies if it's a little bit harder to read some of these words on here, but we want to make sure that we're sharing the same goals, that we have mutual respect. This is all basically a continuous flow of different concepts. And again, this should be open communication. Whenever possible, especially if you're in a department where you're working with physicians closely, is I like to have easy and open communication with them. And obviously, when there's a patient that's applicable, it comes up, whether it's theirs or mine, I like to ask for feedback and their thoughts. Not only to get their legitimate opinions on things, but also sometimes to just feel them out a little bit, especially if they're newer to the practice, is, okay, how do you feel about this? So that way in the future, I can get an idea of what kind of conversation I'm coming into here. So I'm not totally blind. And same thing for them with me. If they're saying, well, I know Chip is really good at intubation and chest tube placement, so I want to be able to know that when the time comes and we've got a critical trauma patient, that he's going to be able to do these procedures, I can stand off and direct care. So those types of things and those kind of communications early on really help your clinical practice, not only at that moment, but also building a long-term relationship with your physician colleagues. So when it comes to the collaboration types, and again, moving more and more from supervision to collaboration, sometimes they feel like they truly are just words, but as we're seeing over time, and we're noticing that more and more collaboration, that term really does seem to matter. It carries with physicians, it carries with other PAs and NPs, it carries especially with administration when they're looking at who to hire and stuff like that. But a lot of this is pre-planning, right? The more that you can kind of pre-plan with that collaborative agreement of saying, basically the physician who you're collaborating with or the group of physicians who you're collaborating with, what are their expectations, and then what times might they prefer or require that someone else be involved in the clinical care. And then, again, asking in real time, hey, I need help with this, or I'm just curious, what are your thoughts on this kind of situation? This is what I have. And then the retrospective side, this is one of those things that I, at least personally, and I think is a good idea overall, there shouldn't be surprises after the fact. You don't want someone who is reviewing your chart later to say, hey, why'd you do this? Did you really think this was a good idea? Anytime where there might be some question, I'd like to have whoever's going to look at this later be involved actively. Now, sometimes it might be, again, just a difference in opinion. I had one physician very early on in my practice who was old school. No offense to anyone who's a little bit older here, because I do see some gray hair, not just on myself. But we had a little bit of a difference in opinion on certain things. But I was able to, after that one time where he's like, hey, I looked at this and I don't entirely agree, we had a good conversation about how clinical practice has changed based on newer evidence, and that's what I was using. If he didn't agree with that, since he is collaborating with me under this purpose, I want to make sure that we can clarify that for the next time around. And it's very important to have a good relationship ahead of time, because that conversation was very different, especially compared to anything that I have now. So dealing with conflict, this is perfectly ties in right here about how do you work through these situations. I'm always cautious with dealing, because it makes it sound like this is such a burden. Sometimes it can be. Sometimes it can be to work with a totally different personality than yourself. But we all come in with slightly different perspectives of things. So we want to make sure that, once again, we are on the same page, but we have to remember that our physician colleagues, especially the ones we're collaborating with, whether we're speaking to in real time or they have an agreement with us, they're responsible for the care of that patient in the end. We get this practice where, yes, when you looked and yesterday's talk about malpractice rates showed that PAs and NPs in general are not very commonly sued, but in the cases that you do, most of the time, not always, there are some exceptions to this, but most of the time, a physician is getting sued with you. So they're looking out for themselves too, very much understanding. They don't want to be named in a lawsuit, just like we don't want to be named in a lawsuit. But when those kind of things happen, it affects them directly as well. So we want to make sure that if there's any time that we have any kind of question with this, we get them involved in some form of the care if it's at all anticipated. And most things that end up going to court, there's some anticipation of something was not right at the time, right? It just didn't totally come out of the blue. But we need to understand that we need to respect their opinions, their thoughts, even if we don't necessarily agree with them. And that's why when those disagreements occur, that we talk about it in detail and try and come to a middle ground. Every now and then, if I have a really clear, like, I really do not agree with what you're suggesting. I know I came and asked you a question, but this was not at all what I was anticipating there. They'll say, okay, well, maybe we can get a third person. You know, a lot of times that can be in the form of a specialist, whether we talk to the hospitalist, whether we talk to a surgeon, ENT, someone else. You know, I like to try and get them in. If that's not applicable in that kind of situation, maybe I ask another one of our physicians, say, you know what, let's just get a third set of eyes on this and then ask them. Now, depending on your setting, that might not be possible, but you'll try your next best thing, right? So it's important to try and bring sometimes a little bit of extra support there and collaboration there to make sure that you can identify, okay, what can we do? Because the thing you want to avoid is having this like he said, she said sort of situation where now you have contradictory notes in the chart, or you have other things that, again, attorneys love. My parents are attorneys. My wife decided to become an attorney after like practicing 3 different other careers first. I still, for some reason, like attorneys most of the time, maybe, kind of. I think it's because I have to. But attorneys love any conflicts on there. My wife comments all the time because she has to look through a lot of medical records, and she's like, your notes are great, they're solid, they're clear, they have clear intention, they're well documented, it's great. Meanwhile, Dr. So-and-so's charts are absolutely awful, and this is a major issue, because she can take that to court and just rip it apart. And that's the thing that you don't want, especially with these kind of collaborative situations where you have 2 totally different cases that are going on, at least when you read it. And so now you have something that they can just tear up in court, if it even gets that far to a trial and not just a settlement. Going back to conflict a little bit here too, we're also dealing with different generations and stuff. This is a little bit older graphic because it talks about the fact of like, some of these people are aged 15 or younger. Obviously, 1997 has been a little longer than 15 years ago, but the points are still there as far as you have your millennials, which I fall into there. Although I was raised more as a Gen Xer just because of the personality wise, but a lot of my colleagues are millennials or Gen X. Fewer and fewer are boomers. One of the first physicians I worked with, he actually was old enough, he was a traditionalist. So the mentality there, keep in mind these are overarching themes. So I know some boomers who are incredibly up to date on technology, who are very much skilled at computers, but overall, these are the same people who, traditionally speaking, might be more the ones who have scribes and stuff like that, or at least kind of help push for scribes in emergency medicine because they don't want to deal with the computer, at least as much as possible. But by keeping in mind the different personalities from the different generations, it can sometimes help you with anticipating and knowing how to work through maybe sometimes some conflict that can come up as a result. So again, know your state statutes is incredibly important, especially when it does come time to maybe you realize that a department policy doesn't make a lot of sense because your statute allows more. When you have that good early relationship, maybe you can talk to your medical director about, hey, we can prescribe these kind of drugs, or I can do these things in my state. Why can't we do it at the hospital? it might be because of some old rule, maybe something that happened one time, and rather than, correct that one individual, we just made a department policy. You can no longer do this at all. And that happens a lot. Every hospital I've been to, every place I've worked at, there is at least one kind of rule that came out because one person, one time, screwed up something, and now we all pay for it. A lot of times, though, once those kind of things happen, let a little bit of time pass, or better yet, you try and head that off entirely, and we can avoid getting those restrictions because most of the time they're not actually going to be beneficial to long-term clinical practice at that site. So we try and stick with as much as possible about encouraging using state statutes, and then focus in on, okay, what are the individual collaborative agreements? Most of the times, if you're working in bigger departments, your collaborative agreements are going to be a very much a template. And maybe your medical privileges and credentialing changes person to person. Again, I'm allowed to intubate, do chest tubes, do central lines, art lines, all those kind of things at my facility under me. But I have some brand new colleagues that are fresh out of school. They are not anticipated to do any of those things solo. They're allowed to do it with direct supervision and support until they have enough under their belt that they can start doing it on their own. Just something else to kind of know is independent contractor versus being employee status. You will have some places who will try to, because they're trying to save somebody, they'll want you to be an independent contractor, but then they're offering you all sorts of benefits with it, or maybe they have you, have certain regulations in place, stuff like that. I am not a tax person. I'm not an attorney, even though I'm surrounded by attorneys. Follow those up with an attorney, a CPA, someone like that. But review the guidelines because this has helped me in different situations of saying okay, you want to pay me as an independent contractor, we have to make it very clear how I am an independent contractor versus a full-time employee. And knowing that in advance can save you a lot of grief later, legally and financially. Liability insurance, this is another one of those things that is going to vary situation to situation. Just know that there's occurrence-based and there are claims-made types. Usually we want occurrence-based insurance. A lot of states have in their statutes for malpractice minimums that need to be there. A lot of times it's like a $3 million total or $1 million incidental. So per incidence, they'll cover up to $1 million. Again, make sure that when you're getting your insurance, that not only are they spelling that out for you, like is this occurrence-based, is this claims-made, but also tail insurance. Tail insurance is so important because it covers you after you leave that practice. Most of you, if not all of you, will not be in the same clinical setting your entire career. You're not going to be at the same hospital for all 20 more years, however long you practice for. You're most likely going to change careers, at least change positions somewhere in the hospital. And at my hospital, we have, for some reason, 3 different insurance carriers, malpractice insurance carriers, between our emergency department, the outpatient side, and then the inpatient side. They are 3 different insurance carriers. They have 3 different roles. So even when I switch to the outpatient side, I'm dealing with a different malpractice company than I was dealing with in the emergency department. So we want to make sure that our tail insurance is clear, who's covering it, how's that covering it, does that get deducted in some way at the end of my time there. Just make sure you have that in place, and best to get that, if you're starting a new job, you're looking at it, get that in that contract. That's just my personal thoughts on this, is get that in that contract now, because that is something that can be a very expensive prospect moving forward. When it comes to coding and billing and stuff like that, there are some fantastic resources out there. They can be as simple as even reaching out to your own billers and coders and say, okay, what do I need to put to get these things better reimbursed? Sometimes it's some of the silliest language that's in there. Depending on what kind of charting system you use, they might actually have it spelled out for you. one thing about electronic medical records is that they do, a lot of them work on making sure that you're hitting the minimum points that they need so that they can bill the max amount possible. But we don't want to just know the charting rules as far as that goes. We also want to know like the different components. So for example, like what all is needed in the medical decision-making portion, which I would argue your MDM, outside of just the billing portion of the MDM, is probably the most important part of the chart, because it tells the reader of that note later what you were thinking at the time, why you did what you did, and that can make all the difference in the world later. I think we're going to talk about that more separately, so I won't dive too much into that. But also, obviously, it's important to know the medicine. There's lots of great resources out there. So there's MRAP, there's other authoritative podcasts out there. I have my own blog and podcast called Total EM that I cover lots of different stuff, emergency medicine related. It covers over to urgent care as well. But read textbooks, take courses like this one. This is a fantastic course. Again, get training in specific skills, a procedural course like an ultrasound course. Those things can make all the difference in not only your abilities, but also to a certain degree your satisfaction. So for me, as Rick was alluding to, is that my clinical practice drastically changed when I started integrating ultrasound more and more into it. My throughput in the emergency department is so much faster because I can do part of the testing myself, or at least develop which way I'm going to go. Do I need to get both an ultrasound and a CT? Do I even need to get any of that imaging? If so, why and how? It makes all the difference in the world. Charting defensively is kind of like a fine line there. I want to say, just make sure when you're charting that you're making sure to put in there what you really need to put to help illustrate what the situation was. But also, there are sometimes certain things that with your best judgment is usually pretty clear. Probably shouldn't throw that in there. Be careful about when you throw things in quotes. Making sure that it's indeed legitimate and accurate. And sometimes when you have these really upsetting patients, the ones that kind of blow up into an argument and things just didn't go well. Sometimes I purposely, if I know I'm not 100% in my best mood or mindset, I leave that chart and I go back to it at the end of the night, or go back to it when there's a lull, and then reread it, because then I realize maybe there's something in there I don't actually want to leave in there because that's not appropriate. It happens less and less with time, but I still acknowledge that happens. I just had a patient last week who was quite upset about something, was very belligerent, and I made sure to go back to that chart a couple hours later once everything had calmed down. They were now out in handcuffs with the police and everything else. I made sure that after that all settled down, I'm back in my normal self. I'm back in a good mood. Then I could look at that chart again and be like, okay, is everything I said here something that I want to actually have read back to me in a courtroom? Not that I anticipate that to happen with this gentleman, but it's something that I just want to make sure that I feel is all appropriate in there. Otherwise, just make sure you're treating your patients respectively. And then when it comes down to billing, also just remember that there are what are called shared visits. They require very specific kind of rules and stuff with them too, as far as that face-to-face time. The physician needs to document their own separate notes, so they need to have a note a lot of times separately, or maybe at the bottom of your chart, that says, I saw this patient, I agree with what they did, or recommended this, but there needs to be a clear part in that note for them to bill that way, saying this is what we did and this is why, not just saying, oh, I agree with the above and that's it. When that happens with CMS, they tend to bill at 100%, although right now with the COVID emergency, a lot of places are still being able to bill at 100% for what the PA or NP is doing, versus traditionally it's more of that 85% mark. This was also talked about a bit last night, so I won't dive in as much of the detail, but liability, a lot of that comes from diagnostic errors, stuff like that. So we just want to make sure that we're working closely with our physician colleagues when there are any questions or any concerns. The last thing here, this is truly the elephant in the room. If you keep up with this at all, you might be aware of this kind of whole political situation here. But ACEP 2021 workforce study They found out that there will be too many, according to that study, and I have yet to see the final paper with this. I think that's going to make a big difference, but there might be too many board-certified emergency physicians for the spots available to them. Meanwhile, PAs and NPs are quickly outpacing the rate of how many emergency physicians are in clinical practice, so there's a little bit of headbutting there. What this comes down to in real life, I'm not entirely sure yet if this is going to be something we're going to have to see as far as, are we going to find fewer and fewer PA and NP positions? I don't think so. I think it's just going to mean our world changes a little bit, and what we might find is that more and more emergency physicians who are actually board in emergency medicine are practicing in rural environments. There's a ton of resources up here. If you're an emergency medicine PA, look at SIMPA, not just AAPA. Same thing for if you're an NP, looking at the AAENP, not just the AANP. But otherwise, thank you, and I believe Mike Sharma is next.
Okay. I feel weird welcoming you guys on day 3 because you guys have already been here for a couple days already. But still, I'm thrilled to. Hi, we good?
Yeah, I'm going to tell people a little about you because
Okay.
you're such a humble kind of guy. Mike is from the. He got his start in.
One of us got to be in the box. Otherwise, should we both be in the box?
We have to share the box. Mike got his start in medicine in the Army, where he became a PA and was transferred to Afghanistan for how long were you there?
About 10 and a half months.
Long time. He was a frontline PA where they were doing the initial stabilization of wounded civilians and soldiers, and sent them back for more definitive care, and he did that for the whole time. He's now in Texas, and he has he's part of a podcast series with Martha called The Two of You, and he also is a teacher of PA training for PANS course and PANRE courses around the country. So, Michael, take it away.
Thanks. Appreciate it, Rick. The joke is like 2 days in Vegas is perfect and 3 days is a little bit too long. And you guys are here on day 3, most of you. So hopefully you guys are hanging in there. I appreciate you being here in the seats. Those of you watching out of one bloodshot eye from your bed right now, I appreciate you too. So thanks for being here. All right. Like Rick said, my name is Mike Sharma. I'm an emergency medicine PA. I practice full time and like to teach when I have some spare time as well. I want to talk about the eye today. I'd love to talk about the eye today because this is going to be, I'm not prepared to give this talk. While we get set up here, there was a little bit of schedule change, so that's not their fault. That's my fault. I didn't communicate this clearly enough to people. While we're getting this set up here, page, I think it's 435. One of your fellow campers recognized that in the Slido and posted that. So flip ahead to around the 430s, and you're going to find the eye talk. And while we get set up here for this, maybe there is a complaint in emergency medicine where when you see it come up on your emergency medicine, patient tracker, the EMR, you look at that and you go, time for my break. I'm going to go suture that laceration. Looks like a big one. Might have to do 2 layers on this. Could be in there for a while. Hope no one else comes in the meantime. That sort of thing. So for me, a long time, that was toenails. Because, you do your best with the anesthesia, and it's still usually not perfect, and you are shoving these metal implements under the toenails like you're trying to extract a confession from this person, right? And it's just a bad day. But guess what? At the end of the day, what if the worst possible scenario happens, right? Mr. Smith, our team worked valiantly on your toenail, but I'm sorry to report that you've lost your toenail. That's okay, right? I mean, I know a lot of folks with 9 toenails, and they're doing amazing, all right? So that's fine, toenails. I got over my toenail thing. How about the eye? Mrs. Smith, you recall that binocular vision you used to have, that depth perception. Sorry to say that's not going to be a thing for you anymore, right? So maybe the eye is like your toenail for me. Hopefully over the course of the next half an hour, we will kind of reduce your OOG factor when it comes to the eye. So let's get cracking here. I think the most important anatomy feature is not listed here, and it's called the limbus. So look at the colored iris and look at the white sclera around it. And the part of the sclera just adjacent to the iris is the limbus. And why it's so important is that when you have a condition, whether it's bleeding or injection, that is concentrated in the limbus, that is more concerning for some sort of intraocular, more serious problem. Versus if you have bleeding or injection and it spares the limbus, that's something you want to note either way. And that's usually more reassuring. Hey, you know, the limbus is clear. There's no ciliary flushing. When we have really concentrated injection to the limbus, we call it ciliary flushing. And if it's not there, that's really reassuring for you that this is more of a superficial issue here. Okay, so remember the limbus. If the chief complaint has eye in it somewhere, go ahead and request the visual acuity and make sure it gets done before the patient leaves. Because classic, you know, nurses are busy, we're busy, everyone's busy. You can put an order in for visual acuity, doesn't mean it's going to get done before the patient leaves. So really make sure that's clearly done and documented. And you might think, well, clearly they're going to know if their vision is bad. But no, sometimes you have a real slow slide into poor vision that is not captured by the patient. So important to get objectively how good it was when you saw them. Because maybe they leave and it gets worse. You want to prove, hey, when they were here, it was fine. Okay? Of course, you want to do a good exam for things beyond the globe as well, as far as just the periorbital tissues and the lids, looking under the lids depending on the chief complaint here. Here's more kind of in-depth eye anatomy. Let's talk about new grads. Who are my new grads here? Who are my new PA grads, my new NP grads, my new physician grads, new grads? Welcome, new grads. You guys are doing the right thing by coming here. You guys think you're so smart. I mean, you are, but think back to that whole person exam and when it came to the fundoscope, right? And you're looking in that eye with a fundoscope and you're like remembering everything they told you to say? Because you don't see a thing in there, right? Like, especially if your partner has like 2400 vision, you're like, I'm screwed. But you're like, oh yeah, the cup to disc ratio is this and this, and there's no nicking. So we know that's really hard. There are tools to do that better in the ER. This panoptic scope is a better way than the regular fundoscope to see to the back of the eye here. As long as you can get a gross look at the back of the eye, you're doing okay. You don't have to go as crazy as you did during your whole person exam, new grad. So don't worry about that. Intraocular pressure, sometimes good to get. Just remember 10 to 20. That's a good general range, 10 to 20. It can be a little bit higher than 20, and doesn't mean necessarily anything is bad. Some folks can have intraocular hypertension without having acute angle closure glaucoma or other bad things. It's okay, but to have a little bit higher than that, okay? Fluorescein staining, super important. If you've tried to stab somebody with a wet noodle before, it doesn't work really well, right? And that's kind of what I feel like I'm doing sometimes with this fluorescein strip. I'm like trying to, this person's already kind of uncomfortable, and I'm trying to jab this thing. It doesn't really go very well. And so what I like to do is I'll take a 10 cc flush, which is like in every drawer of your emergency department, right? You pull out a drawer, find a 10 cc flush, you squirt out about 3/4 of that, and you pull the plunger out of the back of it. It takes some time to get used to doing that because sometimes it leaks everywhere or whatever, but practice with it, right? Pull the plunger out of the back of your kind of like wasted flush mostly and drop the fluorescein strip into the flush and shake it around a little bit. And now you have some fluorescein eye drops, which are way easier to get into somebody's eye than the strip. So consider that if you have a hard time with your fluorescein, okay? If somebody is clutching their eye and screaming and rocking back and forth, maybe we can hold off on asking them if they are suicidal or homicidal or when their last menstrual cycle was, right? If it's really that bad and they just got splashed with something awful, let's speed them through triage a little bit and let's get irrigating really fast, okay? And in those patients, too, the visual acuity can kind of wait because, again, you're not going to be able to read the big E if you're clutching your eye and screaming, okay? This pinhole test, we've heard of that. That will fix the most classic scenario in the ER, I feel like, with visual stuff, right? My vision's really blurry, and I wear glasses. Great, where are your glasses? They're at home. Brilliant, okay? So if you have a problem that is fixed by refractive error, by glasses or contacts, that's what your pinhole is for, right? If you give them that pin, you can even just poke literally a small hole in a piece of paper and say, hey, does that make your vision better? And if it does, then that kind of reassures you that that is more of a refractive error than some other bad reason for the loss or change of visual acuity. So that's a big reason for pinhole acuity. Why would you use that? Because we've heard of this. Do we use it a lot? This is why you would use that, okay? You probably walk by the decon sink or shower, and you're probably like, I don't even know if this works still. You know, this is a great reason to see if it works. If someone is just coated in stuff, they just got slimed by something at their place of work or at home, go ahead and use the eye wash faucet or the decon shower, buy EVS a pizza later on, you know, and thank them for cleaning up, you know, but that's a great way to do that and do that early, okay? Topical eye anesthetic, boy, I love tetracaine, and we'll talk later on about how applying analgesia or giving something for pain is not diagnostic for things like chest pain, for things like abdominal pain, when it's like a bad chest pain. But I feel like it's pretty darn close to diagnostic if someone's got really a painful eye and you bloop, bloop, drop some tetracaine in there, and they're like, in minutes, they're like, I am completely fixed. Like, I am way better. That, I think, is a very reassuring thing for me to say, okay, this is probably a superficial thing, because this topical anesthetic only touches the surface of the globe. And so if a problem is deeper inside the eye, it's not touching that. So if it goes away with a few seconds of tetracaine, I'm very reassured, okay? Everting the lids, you probably learned this with a cotton tip applicator. If not, we'll talk about that later on. Come find me. I don't know a lot of folks who are going to sit still for prolonged irrigation, right? That Morgan lens is like another torture device, like your little toenail elevator here. People don't like that thing really well. There's other ways to irrigate. You can see in the bottom right picture here, they've kind of rigged this nasal cannula to the saline, and that allows you to kind of flush out both eyes with, you know, high volume slowly over time. That's a cool way. You can take an 18-gauge angiocath and like shove it onto the end of your saline tubing, and you make like a little hose, right? And so the nurse or the patient can irrigate someone's eye, and then they kind of pinch off the saline tubing when the patient needs a break, and you unpinch and you keep going. So lots of ways to irrigate beyond the Morgan lens, okay? It says topical anesthesia is required. I find even just as important, if not more important, is anxiolysis, okay? I'm going to give someone a little Versed. I'm going to give someone a little Ativan because that allows them to kind of like relax a bit and just deal with this water torture that they are going through for their own good, okay? And document how long they tolerate it for, document how much volume put to their eyes here, just so it's clear how much they dealt with later on. These pH strips are a pretty cool thing to do, especially when there's been some sort of like chemical exposure. You can document what is the pH of the eye before, what is the pH after irrigation, and if you're like back to your physiologic pH of like the low 7s, that's kind of reassuring. But maybe you're not quite sure, did I irrigate enough? Especially with some of these more persistent agents, did I irrigate enough? You check a pH and it's not back to physiologic yet. Well, that's a clue that maybe you need to irrigate more. Okay, and you can document, hey, we went from 8 to 7-8. We're going to keep on irrigating here, and do whatever you have to do to get them comfortable for that. A pretty ninja trick you can do if you don't have those special like eye pH, that roll there, find a urine dipstick. Find a urine dipstick and find the square that is the pH square and use that to check someone's eye pH. If you can't find those, you'll find a urine dipstick in your practice setting. Okay? That's a cool way to be able to have that without having this specific device. Sometimes, these foreign bodies they're so small, and that fluorescein really like highlights them. People come in like, I think I have something in my eye. I look real close. I'm like, I don't know, man. I don't see it. And you put the fluorescein in, boom, it really just like encircles that foreign body. So super helpful if you're not sure. Okay. My wife came with me to Vegas for the first time. She's a Vegas first timer. I'm so thrilled to have her here, and she is murder on me. When we are driving along and it's been raining, the second the last raindrop hits the windshield, right? Boom, she's reaching over and she's slapping the windshield wiper selector lever on the steering column because she used to have a car where she lived in upstate New York and lots of slush, and the wiper blade got damaged, and she let the thing go on for too long, and she got this deep scratch in her windshield. So it's not always going to happen, but this pattern you see here, this up and down scratching pattern, is classic for somebody having a foreign body underneath their eyelid, okay? Because every time they blink, and that foreign body is scratching, okay? Getting the foreign body out is the important thing. Who does, like, routinely rust ring removal in their emergency department or practice setting? Can I see a raised hand? A couple. It's relatively the minority, though, okay? This is not necessarily the emergency. It's cool if you can do that, especially if someone has a low likelihood of following up with an ophthalmologist. It's a nice thing you can do, but that's not the emergent thing to do, okay? But especially if it's in that field of vision, that can stay in the cornea, they need to have close ophthalmology follow-up if there's a residual rust ring. Intraocular foreign bodies kind of really scare me because I can't really see that when I look at the globe. Or can I? Right? Can I see maybe your pupil is not exactly as round as you want it to be? Okay, can I see a Seidel sign? I squirt the fluorescein in there. And you should all look this up on YouTube, okay? Because you'll see what the Seidel sign is. The fluorescein is kind of flowing. It's moving because the eye is leaking, and it's pushing the fluorescein around, okay? Even if I don't get that, but there is some sort of a high-energy mechanism here, drilling, grinding, hammering, even if someone says, oh, yeah, I was wearing my eye protection the entire time. Even if they say that and I'm concerned, I'll get an X-ray if that's all I got. I'll get a CT if I can. I mean, you could do an MRI, and you'll get it out, right? If it's metallic, you'll get out the foreign body, but just not the way you want to, okay? So don't do an MRI for these things, okay? X-ray or a CT. Don't do an MRI. Okay? We've all gotten stuff in our eyes before, and sometimes the classic situation is, does this person have a corneal abrasion, or is this pink eye? Right? And how do I know? Because like the treatments are kind of different, kind of the same, honestly, but can be kind of different. But I mean, being poked in the eye, having something in the eye is quite uncomfortable, right? People are usually looking uncomfortable. We've all, just even, us not having something requiring to go to the ER, we've all gotten stuff in our eye walking around in Vegas. It's windy, you get some dust in your eye. So look for that. The degree of discomfort often tells you the suddenness, right? I was fine, and all of a sudden I was not fine. That suddenness is more associated for me for a corneal abrasion. Okay? Often we're doing some sort of a topical antibiotic, topical local anesthetic, also very helpful there as well. And then you can do some oral analgesics if you want to, too. These, as miserable as eye pain is, if it's something like this, it fades pretty quickly, okay? So I'm kind of tight on my oral opioid prescriptions here. This is one of those where I will say, yes, I'll give you a couple of days of oral opioids, throw them out in the trash can or flush them in the toilet, really. When you're done after 2 or 3 days, don't keep these. But yes, I'll give you a couple of these if the pain is still bad for a couple of days. If your pain is still horrible on day 2 or 3 or 4, that's weird, and you should come back and see us again. It shouldn't be that bad if we fixed your problem, okay? Like I said, this anesthetic, the tetracaine, is really good, almost too good, right? I still recall being a junior PA and someone had something in their eye, and I come in and I like, bloop, bloop, and by the way, what I do is this, right? That stuff burns. And so I'm not going to tell them 5 minutes before I do it, hey, this stuff is really going to feel like I'm stabbing you in the eye. So just get ready for that, right? I wait until I'm right there, I've got the eye pried open, and I'm about to squeeze the bottle, and I go, hey, this is going to sting a little bit. And they go, huh? And boom, I'm already like squeezing the bottle, okay? Because I don't want them to be already like fighting me for this tetracaine, right? So that's my little technique there. I warned them. I did warn the person, okay? But sometimes it works too well, right? And as a new grad, I do this for a person, and I come back 5 minutes later, and the room is empty. Like, the person is gone. Their stuff is gone. That tetracaine bottle is gone, okay? Because I guess the person was like, this fixed my problem. Clearly, this is what I need. And off they go back to home, okay? Lots of interesting literature that is more emergency medicine focused, that giving somebody who is reliable and who you think purely has a simple corneal abrasion, that it's very okay to give them some tetracaine for home use with the strict instructions that you use this for 2 or 3 days, and then into the trash can it goes. Okay? If the person is not as reliable, you don't think it's going to happen very well, then maybe you don't do that for this person. But literature suggests that is a safe practice to do in the setting of 100% sure it's a corneal abrasion. Ken Milne, one of our faculty members, he runs the SGEM blog and podcast, which you can actually get CME credit for through the Center for Medical Education. But he had a great discussion with Dr. Glockenflecken. You guys know Dr. Glockenflecken, a very funny medical TikToker and an ophthalmologist. Like, he had Dr. Glockenflecken on his podcast. They talked about, is it safe to send somebody home with a topical anesthetic? Okay, and even brought that ophthalmologist around to go, yeah, begrudgingly, I admit it's probably safe. But expect, if that patient goes to an ophthalmologist, expect that they're going to trash talk you. Because ophthalmologists don't like emergency medicine clinicians doing this sort of thing, even though the literature says it's pretty safe. I'm forever asking my patients with abrasions or other eye stuff, do you wear contact lenses? Do you have diabetes? Because those things will predispose you to having Pseudomonas as one of your eye flora, okay? And if that's the case, the person needs fluoroquinolone antibiotics to treat, or at least protect against Pseudomonas infections. Your typical erythromycin, sulfacetamide will not do it for Pseudomonas, okay? Patches, don't do them. It's not really advised to do for abrasions. Tetanus immunization, who's taking care of a patient with legit tetanus? Raise your hand, anybody? One person, 2 people. Who's taking care of a patient with eye tetanus? It's even rarer than that, right? If you want to get somebody boosted against tetanus, it's most important when there is an intraocular foreign body penetrating into the globe, okay? Corneal abrasion, if you forget or they don't want it or whatever, it's less of a big deal to update their tetanus, because we wouldn't do that for an abrasion on our skin, right? We don't need to do it for an abrasion on the eye either. So don't get too freaked out if you forget to boost somebody's tetanus for a corneal abrasion, pure abrasion. Yeah, I mean, I can see this hyphema from across the room, right? But how about your micro hyphemas, your little ones, okay? I had, as one of my first slides, a link to an 8-minute video on how to use the slit lamp. And we all know what the slit lamp is. It's this thing that looks like it was made in the 60s on wheels in the back corner of your ER. It's got a sheet or at least a thick layer of dust on it, right? And you know, you'll see a patient who might need a slit lamp exam, and you'll get back to your dictation area, and you'll sit next to your colleague and go, whoo, that eye looks pretty bad. I think you might need a slit lamp exam. And you look at that person looks at you, and both of you are like, not it, right? Pull the Band-Aid off, watch the 8-minute video on how to use the slit lamp, okay? I think it's a very important part of examining the eye. And they're even making little phone-mounted slit lamps now that you can get and probably have your job reimburse you for. So wouldn't that be cool to have a slit lamp that you can play with at home, be more comfortable? For me, that's my big thing. It's like, I can do it. I'm just not comfortable with using the slow lamp. So maybe you get one, or you guys pool some money, or have one where you can practice better on, and just get more comfortable that way on slow lamping. Any kind of hyphema, that's at least a call to the ophthalmologist. That's an indication of more serious injury. This is real bread and butter, like ESI level 4 stuff for the ER. Hey, my kid or I have a kind of an uncomfortable red eye. It's not very painful. It started in one eye, it moved to the other eye. I wake up in the morning and my lids are stuck together. What's going on? I have never appreciated the preauricular lymph node. That's a classic finding in this viral conjunctivitis. All right. The real treatment is supportive care and reassurance, and telling folks to wash their hands a lot, okay? And maybe a school note or a work note, because no one likes going to work or school with someone with a nasty red eye, okay? But I will often give ophthalmic antibiotics for this. Like, I worry about PO antibiotics, and what am I going to do as far as, like, give someone C. diff, or at least give them bad diarrhea, allergic reactions, systemic. But like ophthalmic antibiotics, I'm very free with those, and so I have no problem dropping someone with some erythromycin for the next couple of days for what's probably viral, but we don't know if they came in earlier in the course. It's okay, as you're not going to cause these bad effects that you might with PO antibiotics unintentionally, or IV antibiotics unintentionally. Contrast that viral conjunctivitis with a more serous, a clear discharge here with bacterial conjunctivitis, right? This eye is like leaking yellow pus as you look at it. It's gross, okay? In these cases, you are going to do very broad coverage here. Like, I'm worried about gonorrhea. I'm worried about chlamydia. I'm worried about other bacteria here. So I'm like updating a bunch. This person's getting a lot of stuff, okay? And I'm doing some cultures as well on the pus coming out of that eye. Right? That's one where I may want to even call the ophthalmologist and be like, I have a really gross eye. He really needs to see you and not just primary care or whatever, just in case, because how nasty this thing is, okay? Or iritis, uveitis. So the key here to not miss this, I feel like, is paying attention to the photophobia. How well does that patient do with the light in the room? Even if you numb their eye with tetracaine, they're still like, oh, the light is still bothering me, okay? And the next thing you can do is this, is you take your light and you shine it in the unaffected eye. Because we all learn about this consensual reflex of the other eye that you're not shining the light into, right? You are going to constrict both eyes when you shine the light in one eye. And so if you do that, you shine the light in the other unaffected eye, and they go, oh, that makes my bad eye hurt as well. I'm very concerned about iritis in those patients. You can see the ciliary flushing I talked about earlier in the middle picture right there. That's very concerning for a more serious problem than just a good old-fashioned pink eye. And it's important, again, an ophthalmologist gets involved because this can be a sign of just straight-up ophthalmologic issues, but a lot of other interesting, more serious medical problems, like systemic medical problems, can show up as an iritis as their first symptom. So it involves sometimes more specialties, more testing, more consultation. That's where you got ophthalmology involved here. We've kind of gone over some of these important questions to ask, and so you kind of already know some of these things. Some other kind of like benign red eye issues, UV keratitis. I finished my PA school in Colorado Springs, so a lot of folks out there on the slopes getting that nice powder and is exposed to the white sun reflecting off of the snow. That's a way to get UV keratitis. You get this kind of like stippling pattern you see in the right picture there, just kind of very diffuse, almost like a buckshot pattern of the entire eye, okay? Cobblestoning, it can be very dramatic in a bad eye allergy reaction. You can see the cobblestoning to the globe even, not just the underside of the eyelids. You can see kind of the cobblestoning here. I really like not just, of course, regular allergy treatments, but ophthalmic allergy drops, like ketotifen is my best friend. In Dallas, when the allergies get bad every year, I'll pull out my ketotifen and I'll use that in my eyes too. It's a great over-the-counter allergy drop for your eyes. Hordeolum, chalazion, good to know the difference between these things here. You can have an internal hordeolum, where you have a red tender bump that is not at the margin of the lid. All right? Debate is out whether antibiotics are necessary here. It's really not necessary in the first couple, like first day. Warm compresses. It's been a few days. It's not worked. There's some debate out there about PO versus ophthalmic antibiotics for a not resolving hordeolum here. Chalazion, that's going to be a referral to an ophthalmologist. You're not going to fix that in the ED. Nice to know terms just because you can communicate easier here. So I think of a pingueculum like a little penguin on a little iceberg, right? So the pingueculum is this kind of like fibrous tissue just on the white of the eye. Versus a pterygium, I think of a pterodactyl kind of spreading its wings across over into the iris and visual field here. Classically, these patients have had this for a while, and there's some sort of a wind or sun exposure chronically. My mom, who is immigrant tough, she was born in the Philippines as a little farming girl and grew up there before she came over to North America and met my dad and had me. She had for the longest time this pingueculum, and I saw it from her, my young age. I always wondered what it was. Well, now I know, because she was out there in the fields, all the years of her young life here and getting exposed to the wind and other stuff like that. Difference between dacryocystitis versus adenitis, the tear gland is up in the upper, more lateral eyelid versus the tear duct is more medial. And you can have some kids who have this chronically, and if there's no acute exacerbation, that's more of a follow-up with a peds ophthalmologist for observation here. But you can have sometimes a more acute, infectious dacryoadenitis or cystitis here, and you can see how you treat that. Super important to distinguish orbital versus periorbital cellulitis. Some pearls, I feel like, the proptosis is very helpful. If someone's eye is straight bugging out of their head, yes, that's very helpful to go, hey, this is probably not just a periorbital cellulitis. This is probably something more serious behind the eyeball, pushing it out. Pain. Hey, when you look around, does that make your pain worse? Look left, right, up, down. Does that make your pain worse? If it does, I'm more concerned about a more serious orbital cellulitis because the muscles are inflamed behind the eye as well. If you're not as concerned about this, I think it's more of a periorbital, often, PO antibiotics and reassurance and sending home. How do I know this is not an allergic shiner, right? Because you get that too, right? People have allergies. They get the kind of puffy eyes here. Those don't hurt when you push on them. This is a cellulitis like a cellulitis anywhere else, meaning it's hot, it's indurated, you push on it, it hurts. That's another way to know, oh, this is cellulitis and not, an allergic shiner. We talked about this stuff already mostly, except for the diagnosis. If you're not sure if the patient is higher risk because of comorbidities, the two I've seen of this had diabetes, do a CT of the orbits with contrast because sometimes you have a cellulitis or sometimes you have an abscess back there behind the eyes. So that's how you're looking for that more. Take a look at these nasty eyes. Often the complaint is when they come into the ED, yeah, I was sitting on the toilet and I was, grinding one out. It was kind of hard coming out and I got up to wash my hands and all of a sudden like, oh my gosh, my eye is red. Usually that, on the first visit, is fine. And it's kind of, just reassure them. But if it's like, and this is the fourth or fifth time that it's happened to me, that's kind of weird. Probably need more fiber in your diet, number one. Number two, you probably should see an ophthalmologist. Maybe we'll draw some coags on you while you're here in the ED to make sure nothing else funny is going on. Okay? Again, if the limbus is spared, I'm reassured, despite how bad it might look. The classic scenario for acute angle closure glaucoma is I was sitting in a dark room watching a movie or TV, and all of a sudden, one of my eyes started hurting really badly, and I got a headache and nausea and vomiting. Again, 10 to 20 is kind of like our happy zone here as far as intraocular pressure. You start cracking into the 30s, I start to get more worried there because of the pressure that can be put on the optic nerve. Here we go again. Ciliary flushing including a kind of a mid-dilated pupil, a kind of a cloudy cornea. These are all very concerning for acute angle closure glaucoma. The treatment you give is really going to depend on your consultation with your ophthalmologist. You're clearly getting ophthalmology involved with this person. A lot of folks have little pocket brains, little smart books or on their smartphone now about how to do things that they don't really feel, like they haven't really inculcated to themselves yet here. This is a great slide. It's kind of like a real systematic approach to the red eye when you get it. A couple more kind of random things here. I'm pretty brave on suturing, but if the laceration goes through the lid margin, that's one I don't touch. Okay, I'll suture most any other thing here, but that's one I don't touch here. I hope that our time together for right now has helped you, if you're oogie about the eye, to not be so oogie about the eye. If you have any questions, please get on the Slido and ask them, or just hit us up here offline here. Thanks a lot. See you soon.
I love it. Thank you. Good morning. Good morning. Yeah. All right. Mike gave some good energy. I appreciate that, Mike. That was great. We're going to switch from the eye to people who come in with lower abdominal pain and how we should approach these patients. And I promise you the answer is not to CT everybody. That is not the answer to all of these problems. And for many of you who work in places where you don't have a CT scanner, you do not want to hear my answer for every problem is CT, CT, CT. And I think that one of the challenges when you work in a place that doesn't have a CT scanner is which ones do I refer, which ones do I send home, what do I do? And I'll do my best to address those as we go along. So we're going to start with a slide like this, which shows you a ton of tiny text, and this is typical in textbooks when you look at the differential diagnosis for a patient who comes in with lower abdominal pain, which is that it could be any of these tiny text things, which is a very, very long list, and that is true. There's a huge differential. But if you think about, by age, by gender, that differential really changes depending on the patient in front of you, and that's true. But there is a really big differential diagnosis that you have to customize to the patient in front of you. This is an area where it is very easy to make mistakes because people's exams are different. There's a lot of bad stuff in there. The age puts them at risk for different things, and that's the purpose of this lecture, to kind of walk through what are the high-risk things, what are the things I really need to know about. Importantly, gastroenteritis is likely the most common diagnosis that you put on a chart, and it's wrong. And Rick mentioned that yesterday, that when you find yourself wanting to choose gastroenteritis, think again, because it is a place where we tend to label people who have certain problems, and often there might be more going on underneath. Now, you could say back to me, but Jan, people have gastroenteritis. That's a real thing, isn't it? And that is true. Yeah, of course, people have gastroenteritis. But you want to make sure that when you're putting that label on someone, that you've really kind of walked through all the other bad things that it could be, and making sure that they actually have gastroenteritis, that they have vomiting and diarrhea. The gastroenteritis is kind of both of those things, but that is the diagnosis that you want to stop and think twice in all age groups. And you want to be careful here, especially in the very young and the very old. That's kind of where you want to start thinking, I'm going to test a little more liberally, I'm going to be a little more careful, because these are groups where bad things can be hiding and the history may not be the best. The exam may not be the best that I can rely on. Now let's start by talking about constipation, which is, it turns out that very early, in my career, I was asked by my chair, who was one of the editors of the Rosen's textbook, which is kind of like the Bible of emergency medicine, do I want to write a chapter for Rosen's? And I was so excited. I was a few years into practice, and I was like, absolutely, I want to write a chapter. Is it, great? Is it going to be like airway emergencies? Is it going to be like hemorrhage and trauma? And he's like, no, it's constipation. And I was like, okay, great. So I'm going to author the Rosen's textbook chapter on constipation and be like the expert on constipation and emergency medicine. And I wrote that chapter for many years. But I do know a lot about constipation now, I will tell you that. And this is often a diagnosis we reach for in patients who tell us a story that is constipation. And again, you could challenge me and say, but Jan, people have constipation and they do come in for pain associated with it. And that is true. But remember that constipation is really a symptom often, and it can be reflective of something more serious going on underneath. So before we bite on the history that says, I haven't pooped in a week and I'm feeling this discomfort, and say, oh, well, this is constipation done, could there be something else more sinister behind it that we need to consider? And there is no definitive test to say that someone has constipation. As much as we would like to believe that ordering a plain film that shows us stool all over the place says they have constipation, again, yes, they're filled with stool. Doesn't rule out the fact that they could have something more serious underneath, so don't hang your hat on that. So plain films and CT scan even are not sensitive nor specific to nail down a diagnosis of constipation. So it may be a symptom of something else rather than the ultimate diagnosis. So just keep that in mind. Now, when we do see a patient who's reporting constipation and discomfort from it, we have to think about, okay, what are the common things that cause this? Inquiring about narcotic use that they may not be disclosing to you is a very common cause of constipation. And then we also have to think, particularly in our older or immobile population, do they actually have an impaction that I need to deal with? Are the pipes stuck? You know, are they gummed up that I need to also deal with? Now, disimpacting someone is not a fun task. It is something that we sometimes have to do, but it is a major undertaking. I have seen patients in the ED that we have used procedural sedation on to disimpact them because that was ultimately what they needed. But this is, kind of a big deal, and most people don't want to have this dealt with in the ED if they don't have to. But you can have severe impactions that can be really life-threatening in our elderly, frail population. So when we see patients like this, again, especially in our older immobile patients that come from nursing homes, et cetera, we want to be generally liberal with our testing to make sure there's not something else going on. There are a lot of solutions to constipation. I'm sure you're familiar with a lot of them. My one little caveat to just put out there that docusate, which is Colace, which often people think about as a first-line solution to constipation, really isn't that helpful. Docusate is a stool softener, not a laxative in terms of a propulsant. I also am very interested in palliative care, and in the palliative care world, we say that Colace creates mush, not push. So if you're really trying to move things to the track, docusate or Colace is not your ultimate answer. You're going to need Senna or something else along with it. The stool softener may help, but something else along with it may be ultimately what you need. Now let's go to the other end of the spectrum and talk about infectious diarrhea for a minute, because we see a lot of people coming in with diarrhea. What do we need to think about with these patients? Well, remember that viruses are the most common etiology, although we're tempted often to consider antibiotics in this population, and that may be what they're hoping they get. It's viruses that are the most common things. And if you happen to send the stool, which I'm not advocating that you need to do, but if you were to look at that stool, you would not see fecal leukocytes. It's not an inflammatory type of diarrhea, nor would you see blood in the stool. And often, people don't come to the ED for diarrhea. So if they're really coming to the ER with diarrhea, you have to think about, again, this is a select population. This person's presenting with something that most people just stay home and deal with. So take it a little bit more seriously than anyone else with diarrhea. There are invasive types of diarrhea, of course, but typically patients who have something like this have cramping, they may have some fever, they have a little bit more than just frequent stools. And if you were, again, to look in the stool, you would see white blood cells, you would see even some blood, because these are typically invading the colonic mucosa, et cetera. Now, a poor man's test of fecal inflammation would be a guaiac or a hemocult, where you look for blood in the stool. Again, not necessary to do, but if you happen to have a stool sample and you want to check it, that'd be kind of a cheap corollary to see if you have inflammation there. There's a list here of the bacteria that cause invasive diarrhea. You've got your Campylobacter, you've got your Shigella, you've got your Salmonella, which are all associated with certain buzzwords and features of the history that you should elicit, and you should document that you thought about these things and asked about them. And, do other people have diarrhea? Were you recently somewhere, where other people have it? Have you had a fever at home? And in young kids, Shigella in particular is also associated with neuro complaints like febrile seizures. Often that happen before the diarrhea actually sets in. We have people who travel, and that should be a standard question you ask when a patient presents with diarrhea. Where have you been? And we know that E. coli is the most common cause of travelers' diarrhea. Staph is another really common one. This happens usually about 6 hours after you ingested something, and often they're vomiting as well, and there often are other people who are sick. And there's a whole long list of things that can cause infectious diarrhea. I'm not even talking about the things that can affect people who are immunocompromised. There's a long list of things to think about, but these are some of the general things to know. So what about treatment? In general, we need to take a good history, think about these unusual causes. In general, we do not need to send stool cultures, stool O&P, all those things. Again, in the ED, you're not getting those results back. So they're not actually going to help you decide what to do right now. So I generally do not send those things, except when I really suspect one of those etiologies and I think it's important to their ultimate trajectory of care. And I better have a system of following up on those things since I'm not going to get the result. Certainly if they're sick, there's fever, there's bloody diarrhea, then we're talking about like, yes, let's take this more seriously, let's send some labs, et cetera. But in most cases of diarrhea in an immunocompetent adult that doesn't have risk factors that I'm worried about, I'm considering dehydration is probably the most serious thing that I need to think about, but otherwise a lot of these self-resolve. Now, should you treat them with antibiotics or not? It's a little bit controversial. There are some papers to support the fact that in community-acquired diarrhea, that antibiotics will shorten the course a little bit. There are other people who would say, you know what, we are really focused on antibiotic overutilization right now, and we do not need to expose people to bad potential side effects for a case of diarrhea. So some people would give a short course of antibiotics depending on how much the patient has suffered, how they look, et cetera. And doing over-the-counter things like loperamide is reasonable in most cases of diarrhea. Now, a patient with diarrhea, we have to think about the serious things. Is C. diff the most common thing of diarrhea? Of course not. But in some patients, we need to consider it because we know that this is rising in terms of incidence. We've been taught that C. diff is associated with antibiotic use, and that is true. We should ask about recent antibiotic use, recent hospitalizations, but there are cases of C. diff that don't have either of those risk factors. But if someone's coming in with a lot of diarrhea, voluminous, with some abdominal pain, again, the sicker looking patient with diarrhea, especially if there's blood in the diarrhea, this is a test we should send and we should think about. So we want to send that test if we think that C. diff is a possibility. We know it's very infectious. We know that we don't want, this can have a spectrum of disease from just diarrhea all the way to toxic megacolon, very, very sick. So we want to try to catch those cases. One thing that has changed in the last couple of years is the recommendations for treatment of C. diff. So it used to be that metronidazole was the first-line treatment for C. diff, and that is not true anymore. The IDSA, Infectious Disease Society of America, changed the guidelines on this, and so metronidazole is not first-line anymore. The current recommendation is to go with vancomycin, oral vancomycin, not IV vancomycin, but oral vancomycin, which is actually pretty expensive. It's 4 times a day. That's their recommendation. Or you can use a different drug called fidaxomicin, which is another medication that you can use, which is only twice daily, also expensive. And if they can't take either one of those or you don't have access, then metronidazole is kind of the line of treatment below that. If you're talking about a patient who has C. diff or you suspect has C. diff and is really, really sick with hypotension, ileus, megacolon, then you go for vanco plus metronidazole IV. Those would be the options there. And a surgical consult would be reasonable from a lot of those cases. So if they've had C. diff before and they're coming in again, go ahead and kind of Google that, look up the CDC website. There are other recommendations that go along with C. diff. We know that when it comes to C. diff, hand washing is the way to go. Those little, our little gel in, gel out doesn't work to kill C. diff. So if I see a patient and I think they might have C. diff, even before I'm waiting for that test to come back, I usually will put contact precautions up right away on that patient so that people are considering this and we're being careful about how we approach that patient so that we're not iatrogenically spreading it around the department. So contact precautions are really important. Okay, let's move on and talk about another really important and common diagnosis that can be very, very tricky, which is appendicitis. And we know kind of the etiology of appendicitis. We know that often it's a little fecalith that gets stuck in this little appendix and then it gets inflamed and infected, et cetera. And often when you see a patient who turns out to have appendicitis and you ask them, have you ever had this pain before? A lot of the times they say yes. And it turns out that the natural history of this is that you can have appendicitis that may self-resolve kind of over and over again. And so some people will tell you that they've had it before. Don't let that dissuade you from the diagnosis of appendicitis ultimately. We know some other factors about how long the perforation happens, from where the obstruction happens, and often there is no actual obstruction. It just happens and it's sort of functional and it can just go away, as I mentioned. Now, we read about the classic history. Yes, they're supposed to get this diffuse mild abdominal pain. It starts around the umbilicus, then it moves down to the right lower quadrant, and when we push right there, it should be tender, and we know all these historical features. The thing about appendicitis is that it very, very often does not follow that pattern. The patients don't read the textbook, and it comes in some other way, and you're always surprised sometimes when you get that read that comes back appendicitis. So we have to be careful. Who are the ones to be careful in? Well, certainly, we know it's our elderly population and our younger population that often are the ones that present atypically. And maybe that's because they can't tell us exactly the story that we're sort of looking for. They may not be able to articulate that for us. People can have constipation and present with appendicitis. They may even have diarrhea. They may or may not have had fever. They may or may not have those classic things you're looking for. So you always still have to be kind of considering this, which is why we talk about appendicitis a lot. Often after they've perfed, they feel better. So they may tell you a history of this kind of ascending abdominal pain, and then all of a sudden I started to feel a little better. And it may even happen while they're sitting in your department or in the waiting room. So pay attention to that. We know that's true as well. The only thing you can really count on is that they should be tender when you push on them. They should be tender when you push on them. I'm not that worried about appendicitis when they give me a story and I go push on them like, really you're not that tender. So, that is the one thing I think you can hang your hat on for sure. But everything else, including the white count, including the presence or absence of fever, including whether they're eating or not eating, is very variable. They're really all over the place. And so in patients who can't give you a lot of history, again, we want to be a little more careful in those patients and be a little more liberal with testing, et cetera. Now, appendicitis in kids, this is the most common non-traumatic surgical disorder in the little guys, and we know that the perf rate can be relatively high, again, often due to limited history and an exam that we may or may not trust. They may have symptoms all over the place. What are the things that we put on that chart and we turn out to be wrong? It turns out to be appendicitis. Number 1 is gastroenteritis, but number 2 is URI. Number 3 is pneumonia. Now, why would that be? URI and API, those are really different things. And I think the reason is because a kid who walks through the door with a fever and may have a snotty nose, because they have snotty noses all the time, we will chalk right up to a URI as fast as we can, do it. But have we pushed on the belly of that kid with the fever who has a runny nose? It's a very easy thing to do, and I would recommend that you do it. So it's very easy to just push down there at McBurney's, anything hurting down here, and not to miss that, because that is something that we have done before, we as the collective emergency medicine world. So be careful with this diagnosis. Document an abdominal exam in those kids with a fever that you're sending home. Make sure you've thought about this as a possibility. Tricky, I know. What about imaging? Well, technically in really classic cases, imaging shouldn't be necessary, but I'll tell you these days, most of your surgeons are going to want an imaging study of some kind. And the first imaging choice in the vast majority of patients should be ultrasound because of the lack of radiation, because of the fact that it can show appendicitis. This is particularly true in our kids, that we don't want to be running through the CT scanner if we can avoid it. Now, I will say with the caveat that you all are at the disposal of various resources. It may be that you don't have ultrasound after hours and the CT scan is what you have, or maybe you don't have ultrasound at all. So it really does depend on where you work and what kind of the typical practice is in your group. But if you have access to these things, ultrasound is where you should start. For young people, kids, young adults, especially those who have a thinner body habitus, if you're not sure if it's appendicitis, one thing about CT scan is that it can offer you alternative diagnoses, that you can look at more than the appendix and make sure you're ruling out other things. The other thing to know about CT scan is, although often where you work they want you to have oral contrast and IV contrast, you really don't need oral contrast to make the diagnosis of appendicitis. So it's something that needs to be worked out at the institution. At my institution, we don't do oral contrast anymore if we're looking for appendicitis, just IV contrast. But you don't always have control over that. I get it. The radiologists get to tell you what to do, but you should know that that's really not necessary. MRI is another option. Again, if you're lucky to work at a place that has that and you were looking at an ultrasound that's inconclusive in a kid, maybe your next step is MRI and not a CT scan. MRI will also tell you whether they have appendicitis or not. So the old paradigm of all appendicitis goes to the OR is actually changing, and that's really interesting in the last 5 to 10 years that we're seeing papers come out talking about alternative treatments of appendicitis, particularly an antibiotic-only strategy. And that is supported by evidence more and more trials looking at it to say that this is a reasonable thing to do. Now, that's not something that I'm going to decide. I'm not going to talk about it with the patients about whether I'm going to treat you with antibiotics or not. I'm still calling a surgeon, and that may be a conversation that the surgeon and the patient have about that type of a strategy. But just so you know that if your surgical consultant were to suggest this, this is not out of line in terms of where we're going. And it may be that this is really a standard treatment that we need to kind of embrace more. But I think it's also an option for patients who are really poor surgical candidates. You know, an antibiotic-first strategy may be very, very reasonable. But again, you're still going to consult surgery. That is the standard of care, and they can decide what they're going to do next. And often they're asking us to do pre-op antibiotics. That's reasonable as well, and I've given you the choices that are common for them to request. Now, moving on to diverticulitis, another thing that we see very, very commonly, and it used to be back in the day that all of these patients with diverticulitis got admitted, and that is no longer true, right? We send lots of people who look relatively well with diverticulitis home. It's very common in elderly patients, but boy, have I seen diverticulitis in 30-year-olds. I mean, young adults. It is definitely, the age limit is dropping. We know what these are, these little pouches in the colon that get inflamed and can get infected, and they can even microperforate. And the more that we do CT scanning, which is very, very sensitive imaging test, the more we see these microperforations. This is usually a left-sided problem. It's rarely a right-sided problem. The ones on the right side are usually the ones that bleed but not really hurt. And often we find these on CT scan at this point, but doesn't mean that we have to get a CT scan on everybody. Now, some people will treat the mildest cases, if we can certainly treat them as outpatients with antibiotics, but they do need close follow-up. You can definitely have failures of outpatient management, so good return precautions are important. In addition, usually it is recommended that at some point when their diverticulitis resolves, they usually will need a colonoscopy as an outpatient to also make sure that there's no cancer underlying this, etc. We want to cover gram-negatives and anaerobes. I have some suggested antibiotic options here. If they're going to be staying in the hospital, I don't always use Cipro. You could also use something like ceftriaxone, and often your consultant may have a favorite study of choice. The CT is really looking for complications, looking for the abscess, looking for free air and perforation, helping confirm the diagnosis if it's a first-time diagnosis. But you may be seeing a patient who's had this before. It's been confirmed by CT before. They're coming in with the same exact pain. They look pretty good, and it is reasonable to treat them with antibiotics and not CT scan them again if they look good, if they're tolerating POs, their vital signs look good, etc. And that is certainly something that you can do and avoid CT scanning all of these patients. Now, another serious thing that we see, but it's not that common, but again, we're emergency clinicians. We have to think of the worst things first, which is a volvulus. And this is basically a twisting of the intestines. And this is the sigmoid volvulus, and we'll talk about cecal volvulus in a moment, but sigmoid volvulus is usually in older patients who are usually immobile. They're often in a nursing home. They've been chronically straining. They're chronically constipated, and they get a lax sigmoid, and this thing can twist. And there are some classic plain film findings that I'll share with you, but most often we're doing a CT scan to make an ultimate diagnosis. So if we see this type of patient, we're probably getting a CT scan in that case because this is the kind of patient that could be a lot of other things that may be causing their symptoms. And this is not a patient that you're going to be seeing in an urgent care, for example. If you do make this diagnosis, you consult a surgeon, but they may end up doing non-invasive things like sigmoidoscopy and decompression. They don't automatically go to surgery. This is what a classic plain film of sigmoid volvulus looks like when that intestine kind of blows up and twists. You see this dilated bowel that's kind of pointing up towards the right upper quadrant, even though it's originating from the left lower quadrant. That's the classic plain film of sigmoid volvulus. And maybe if you work in a place where that's all you have, plain film, you might be starting with this, looking for something like this, and then moving on from there. Now, cecal volvulus is on the right side, and interestingly, it occurs in a completely different patient population. This is usually the younger patient who has a congenital mobility of their cecum, and that's why it twists. And they may be presenting with right lower quadrant pain. You may be thinking this is an appy until you send it to scan and get the result that it's actually a cecal volvulus. That's usually how we find it. There are also some plain film findings here that we'll share. This is actually the most common cause of small bowel obstruction in pregnancy. Very, very interesting. And the only treatment here is surgical. So these all go to surgery for sure, and it's much less common than sigmoid volvulus. This is what cecal volvulus will look like. You get the twisting in the right lower quadrant. You see this sort of kidney bean looking, shape here on the plain film, and that's what that would look like. Now, we see a lot of patients with inflammatory bowel problems, and I'll start with Crohn's disease, and this is also known as regional enteritis, and this is an inflammatory disease, often associated potentially with autoimmune or family risk factors, but it can affect the entire GI tract, from the mouth to the anus, anywhere they can be getting inflammation. This isn't a diagnosis that we're making in the ED. This is usually a diagnosis that they're walking in with already, or that we're thinking, this might be Crohn's disease, but they really need a colonoscopy to diagnose it, so it's not something that we're diagnosing, de novo. The symptoms that they have diarrhea, they have bleeding, they have a lot of pain, and in general, surgeons will want to avoid operating on these patients because they can have disease through the whole GI tract. So operating on one part doesn't necessarily solve the problem and just creates complications down the road. So they're usually admitted for antibiotics, hydration, often to up their immunosuppressives or initiate them if they're not on them. They do have ultimately in their lifetime an increased risk of cancer, and if you were to CT them looking for complications, you often will see wall thickening and any other, if they have abscesses, etc. They also have a lot of non-GI related problems like kidney stones and rashes and arthritis due to the autoimmune nature of these things. So these days, with some of the newer drugs, the MABs, infliximab, etc., a lot of these patients do very well as outpatients, and we don't see them as often, but often they have breakthrough problems for sure. I think the thing that to remember with Crohn's or with ulcerative colitis is that a patient with either of these diagnoses, while they walk through the door and tell you that's what I have, and you're chalking up all their symptoms to that problem, they can also have other problems, right? They're not immune from appendicitis or diverticulitis or one of these other things. So we have to, sort of double check ourselves and say, okay, I don't want to go into this with an anchoring bias, that I'm anchoring myself on the diagnosis of a Crohn's or a UC flare, but I'm considering what else it could be. Ulcerative colitis is limited to the colon, so ultimately you can do a colectomy and solve this problem, and some patients have had that surgery once they've gone through a lot of problems beforehand. But they can bleed and hurt and obstruct just the same, and again, often the first step is supportive immunosuppressive therapy, etc., and they also can have extra GI manifestations. So let's just be sure that we don't anchor too quickly on this is just a flare of their disease, and we consider other things before we end up circling back to this is a flare of their disease. But we've thought about other things. We see patients with small bowel obstruction a lot. There are two really common causes of this, that they have adhesions from some surgery, whether it be recent or remote, so we have to take a good surgical history, and could it be an incarcerated hernia of some kind? That's kind of the top two things that cause small bowel obstruction. It's usually not malignancy, although it's on the list, but it's way farther down on the list underneath these things. Often they come in vomiting, they're very uncomfortable, they may or may not be distended. If you take a listen, you might hear these tinkly bowel sounds indicating that the bowel is trying to push through, but it's not working. And often we confirm this with some type of imaging, whether it's plain film, we move to CT, etc. CT is pretty sensitive, and often if you're admitting them to a surgical service, they'll want the CT scan because they want to know the lead point. They want to know more about the anatomy of this small bowel obstruction. These days, most small bowel obstructions are managed conservatively and don't end up going to the OR. They're usually going to try a trial of time. They may get fluids and some analgesia. I say plus minus the NG tube. They don't all need an NG tube, despite what your surgeon tells you. NG tubes can be really helpful for patients who are doing a lot of vomiting and are very symptomatic, but they don't all automatically need one. That's one of the most painful procedures that we do to patients in the ED, so I often kind of question that particular recommendation to make sure we really need it. And then you want to think about their electrolytes, et cetera, and often they'll be admitted for serial. They do some gastrograph and contrast swallows to see if it resolves before they will take them to the OR. Large bowel obstruction is much less common, and in this case, malignancy is a major cause of large bowel obstruction. There are other things that this could be. It could be intussusception, it could be diverticular disease, it could be volvulus. All those things would be on your differential. And a plain film is useful if that's all you have. You might see some particularly little types of patterns that tell you that that's what's going on. And then the clinical diagnosis of distension and pain and constipation. If you do put it, these ones do get an NG tube, and often they're vomiting this fecal type of vomitus that's pretty gross in a large bowel obstruction. So here's kind of what some of the imaging might look like. You see those haustral markings on the plain film. As you see that dilated large bowel, you see those haustral markings, and that might be what you start with to get this diagnosis. Now, one thing that in emergency medicine we talk about a lot, especially in our older patients with abdominal pain, is mesenteric ischemia. And this is something we really worry about because, obviously, if you have ischemic bowel, that is going to be potentially fatal for you. And this is really time is bowel type of model. So we know the patients who might be at risk for this. These are your patients with AFib, who are vasculopaths, who are at risk for decreased flow to their gut. It can also happen in critical care units when people are on pressors and in low flow states that they end up being ischemic. So this can be sudden in terms of an embolism, or it may be more gradual and kind of intermittent with a low flow state. So in our elderly patients who are on DIG or other medications for AFib, again, they've had lots of vascular issues. We want to think about this. And one of the key clinical findings is that they're reporting to you a lot of pain, but when you examine them, you're not finding a lot of focal areas of tenderness. Think about mesenteric ischemia. If you do consider this diagnosis, you definitely want to call a surgeon early, transfer this patient early to make this diagnosis as soon as possible. They may have classically a very high white count that's reported in many patients, but not all. And I would order a lactate, looking for that ischemic lactate elevation that might be there as well. Again, not perfect, but often there. And again, I know I've said this over and over again. I know I'm saying CT scan, but I'm telling you what ultimately will make the diagnosis. I'm not saying that, again, you have to do CT in every single person, but if this is a person that has AFib and we're giving me the right story, I'm going to consider it, and that's ultimately what they will end up with. We see lots of people with hernias for sure, lots of people walking around with hernias that bother them that they wish you could fix, and often you can't. It's very frustrating to them, but you can at least educate them about hernias. And so remember, when we use the words incarceration and strangulation, those are two different things. Incarcerated means that it's stuck and I can't reduce it. Strangulated means that I think that it's actually cutting off its blood supply and I'm actually dealing with ischemia, in which case I definitely don't want to try to reduce that ischemic bowel. Just as a review here, I offer you some information about what's a direct and an indirect hernia, which you're probably very familiar with. But there are other types of hernias as well. There's femoral hernias, there's Spigelian hernias, there's umbilical hernias. We see the whole variety in the emergency department. Another thing of abdominal pain we have to, an emergent cause of lower abdominal pain to consider is perforated bowel. And we think about this in patients, again, who might have very, very chronic constipation, and maybe they're coming in with a new increase in abdominal pain or distension. We think about perforated bowel. True also with ulcers and upper abdominal pain too. How do we look for free air? Well, we can start with a plain film, an upright plain film where the free air will rise. A CT scan is much more sensitive, and ultimately that's often where you might go. And if you do find perforated bowel, you're getting a surgical consult, you're starting antibiotics, and again, these are, you're covering for gram negatives, and these are patients who often can be pretty sick, and so perforated bowel is something to think about. Often this is in patients, your elderly patients who may be, again, immunosuppressed, they may be on chronic steroids. These are patients we want to think about perforated bowel. And this is what free air might look like. You see under the diaphragm, this sort of free air that's going there. This has to be an upright film. They need to be upright for a little while to let that air rise up, but that may be the imaging modality that you have that you may want to try first. And then again, CT scan will show us all kinds of little bubbles of free air that we don't otherwise see on plain films. I look forward to your questions on Slido, and thanks for your attention.
And another new person.
No, I haven't. Okay. Thank you so much.
This is Jesse Werner. Jesse is a emergency physician, works at UC San Francisco, their Fresno operation. She's teaching there residents in emergency medicine. She's also teaching medical students, and she's also involved in an educational fellowship there. She has taken an educational fellowship, and now she's doing one for the residents at UC Fresno. Jessie went to Brown. She's fully trained and recently graduated, but
Recent,
but
fully board certified.
she's got this down. Okay. So
Thank you so
Jessie.
much, Rick. Hi, everybody. It's so great to talk to you today. Thank you so much for having me. It's an absolute privilege to be here. And today, I get to talk to you about analgesia and procedural sedation. And I actually love this topic because I feel like we're going to cover a lot of pharmacology. And I don't know about you, but in my training, I feel like we focus so much attention on pathophysiology and learning the diseases and learning how to talk to patients, and while you're talking to them, trying to get to the bottom of what exactly they have. But we don't really talk that much about pharmacology. And so when you first start working in the emergency department and you actually have to dose these medications, it's a huge challenge. And we don't always have our dosing memorized. Sometimes it's changing, it's in flux. And there's always new medications that we're using. So this is a really fun topic. And in fact, when I was working with a recent medical student, he's a fourth-year medical student, he's getting ready to graduate, and we were on a shift together, and he presented a patient to me, and I said, yeah, why don't you give them some Tylenol? And he said, yeah. And then he kind of came up to me a little bit sheepishly, and he was like, I don't actually know how much Tylenol I can give them. Like, is it okay to give them a gram? And I was like, oh, that's so interesting. You're about to graduate from medical school. You're not totally sure how to dose the Tylenol. And I think this is common. This is a common problem. So I'm really glad that we're talking about pharmacology, and I'm glad that we're talking about pain. Analgesia is one of the biggest reasons that people come to the emergency department. We see it every day, all the time. This is a huge, huge problem. And what's great about it is it's actually something we can treat. It is something that we're good at. There's so much that comes to the emergency department and we're not totally sure what's going on, or it's not actually an emergent issue, and we say, I'm sorry, this is kind of the best we can do for you. Follow up with your primary care doctor. I'm not totally sure. I don't have a great answer for you, or I can't totally fix the problem. But when it comes to pain, we absolutely can fix the problem. We have great pain medications at our disposal. And so when someone comes in and they're in pain, I'm happy because I can help them and I can make their day a little bit better. And in fact, EMTALA considers pain to be an emergency medical condition. So we are required to ask about pain, document that we asked about pain, and then document that it improved, or we at least offered pain medication. And what's the goal? What's the goal when it comes to pain management? Well, the goal is to treat it and treat it early. You really want to get on top of this. No one wants to be in the emergency department, and a lot of times when they come to the emergency department, they've been waiting a long time before they get to see you. So that pain may have been lingering for, hours, days, who knows? So our job is to jump on top of it, make those people feel better as quickly as possible. Oligoanalgesia. Too little pain care. We are not treating pain adequately. So there are actually a lot of studies that show that we undertreat pain. And especially in some of our populations, such as the elderly, in kids, in minorities, and in women. There's a lot of evidence for this. So this is something that we should be aware of. We should recognize perhaps underlying biases, and we should make sure that we are treating pain adequately. I would so much rather treat someone's pain, and perhaps here and there you're giving someone pain medicine who might be drug seeking, but you're catching a huge swath of people who have true pain. I would much rather do that and assume that the pain is real and catch the people that need pain medicine than to assume that someone is drug seeking and be really on guard with all of my patients and undertreat pain in the people who need it. So the big takeaway here is that a lot of times we're actually not treating pain adequately when we can. And most people are not drug seeking, and we should not bring judgment to the emergency department, assume that the pain is real. Again, people do not want to be in the emergency department. They don't. It's never a good day. You know, people who work at the beach or at a restaurant and people are happy, that's like a nice environment. At the emergency department, it is the worst day of those people's lives. They don't want to be there. The wait is long. They're uncomfortable. It's not, they have to go out of their way to come in. I mean, when you feel sick, the last thing you want to do is like put on clothes, get in the car, go wait in a chair at the emergency department, right? You want to be in bed, you want to be at home. So if someone's going out of their way to come to the emergency department and asking you for help, we should assume that that pain is real. They have pain. Something is not right, and we can help them. The other reason that we undertreat pain, I think, is because there is no good test for pain. It's not something that we can easily see. And we can't just send a lab and say, oh gosh, your pain level's really high. Yeah, let's treat that. Let's address that. This is something that we rely on the patient for, and everybody's a little bit different. But think about it like this. When you see that patient who's screaming and yelling and going on and on about their pain, sometimes you'll hear colleagues kind of be like, oh my gosh, this person's over the top, you know, and kind of minimize it. But then, on the flip side of things, you see the person who's complaining of pain and kind of on their phone playing, you know, Candy Crush or something. And then you might hear a colleague say, they're not in pain. Look at them. They're playing on their cell phone. They're fine. So these poor patients, they can't win. You know, what is the right way to show you that I am in pain? We just need to trust them. We need to believe that if they are going out of their way to come to us, that they do have pain, and there is something that we can do about it. So what are some general principles? Again, this is the absolute basics. You've got to document that you asked about pain. And you can show them these pain scales. You know, if it's kids, you can show them those smiley faces all the way down to the frown. You know, I'm in this much pain. They can kind of point at the picture. But generally with adults, we're going to ask them that number. You know, on a scale of 0 to 10, how much pain are you in? Now, this is tricky. Everyone's going to give you a different number, but you can at least document that you did ask about pain. You can document the number, and then after you've offered pain medications and perhaps the pain is improved, you can show that that number improved. Now, it's really, I think the key here is that you recognize the person has pain and you offer them pain medicine. And the nice thing is you can really establish a good relationship with your patients by addressing this before they even ask you. So if someone comes in and they look uncomfortable, you know, I like to say, gosh, you look really uncomfortable. Can I offer you some pain medicine? Would you like some pain medicine? Before they even ask. And then they can say, yes, this doctor has buy-in, they care about me. If the person says, I don't want pain medicine, or if they say, I don't want opiates, that's great, that's fine. Totally their choice, you engaged in shared decision making, and you just need to document, you know, pain medication offered, patient declined. Non-pharmacologic analgesic measures. These are really cool, and I think that we should use these more. So distraction is a wonderful technique. Headphones, toys, iPads, phones. A lot of times we think about these in our pediatric population, and at my hospital where I trained, actually not where I'm working right now, but where I trained, we had Child Life. And Child Life would come in and meet with the kids, and they'd give them an iPad or toys or stickers and kind of keep them entertained while they were in the hospital. So we're good about this with kids, but we're not so good about it with adults. And I like to try and keep it in mind. So when I'm fixing up a laceration for an adult patient, I always say, do you want to listen to some music? Feel free to put music on your cell phone, or I'll put classical music on my cell phone and just play it while I'm fixing their laceration. And it's a nice little distraction. It calms them down. Acupuncture. So I've actually not used acupuncture in the emergency department, but there are some good studies to show that it can certainly help with pain management. Visualization. I love this one for procedural sedation. So if you're ever getting ready to push ketamine on a patient, you really want to get them to that good spot. I like to say, what's your favorite vacation place? Let's go there right now. The beach? Great. We're sitting on the beach. You can feel the breeze. You see the waves. And even right now, hopefully it's working for some of you. I'm getting there. I'm like, yeah, that's great. So visualization is big. Vibration. Has anyone ever seen that little bumblebee that you can use? Yeah, I'm seeing some people, yes, nod their heads. This is a great one. And if you think about it, when you go to the dentist and they numb you up, they're always shaking your lip or shaking your cheek. And that does kind of help. It distracts the pain. And so that's another great technique that you can use. Ice. So, of course, if they have a broken bone, you're going to use ice, but you can also use ice to kind of help numb the area. And then elevation. All right, let's dive into some local pharmacologic agents. So these are also fantastic topical agents and local agents. Again, this is wonderful for kids, and we're good about it with kids. Emla cream, and Let. So these are really nice. If a child has a wound, you can put Let into the wound and it helps to numb it. And Emla cream is usually used before we start an IV. I wish we offered this to our adult patients. It would be wonderful for everybody. The big thing about these is that it takes about 30 minutes for them to work. So you need to think about it ahead of time, apply them, wait a little while, and then once you've let the time pass, go ahead and address the patient. So it does take a little bit of time. The other thing I love are digital blocks, regional blocks, local anesthetics. Why? Because they are quick. So out in triage, if a person comes in with dental pain, oh, this is the worst. It's gnawing, terrible pain. It's been ongoing. I can't sleep. If you do an inferior alveolar block, a quick dental block, boom, pain is gone. Oh, doctor, thank you so much. Thank you for this pain relief. I feel so much better. So that is a beautiful choice. We should be using local anesthetics, and it's not systemic. It's like a great option. You fix the pain right there, they're good to go. And we use this for intra-articular injections as well. If you're going to reduce a shoulder, you can inject a little bit of lidocaine right there, reduce the shoulder. It's great for finger injuries, just doing a digital block. Toes, again, you obtain pain control immediately, and it's local. This is the WHO analgesic ladder, and this is really basic. Basically what it says is you're going to start small and move big. So you're going to start with your non-opioids, pain management, if the pain is ongoing or worse pain, you can try PO opioids. And then for really severe pain, people who are probably going to be admitted, you're going to move towards your IV opiate pain medications. So some general considerations when we're talking about pharmacologic analgesia, you're always going to consider the route of administration because we've got a lot of options in the emergency department. Do we want to give them oral? Do we want to give them IV? Do we want to give them intramuscular? Topical we talked about. So PO is really nice for patients who can tolerate a little bit of wait time because it's not going to work immediately, right? It's going to take a little bit of time before they start to get pain relief. It's also nice if you feel like they're probably not going to the operating room or if they're not going to need repeated constant dosing. PO is a good choice for that. IV is for those patients who have ongoing severe pain. You're probably going to need to redose it. Go ahead and put in an IV because no one wants to receive multiple doses of intramuscular pain medicine, right? One shot, okay? I don't want to come back for another IM shot of that. So one IM shot. You're going to think about the desired onset. So we talked about dental blocks, how quick those are. Right away, you get great pain relief. Again, PO takes a little bit longer. Topical takes a little bit longer. And think about how long you want this pain medicine to last. So when we're choosing our pain medicine, some are very short-acting, such as fentanyl. Others are quite a bit longer. Morphine actually lasts a longer time. Think about your contraindications. So if you have someone who has kidney disease or renal failure or cirrhosis, or if they're elderly or a fall risk or a bleeding disorder, these are all things we need to consider when choosing our pain medicine. And finally, side effects, nausea, vomiting, those kinds of things. All right, Tylenol. This is like the undervalued, back in the corner pain medicine. And it should be forefront. This guy is a great drug. It's amazing. And it doesn't get the recognition that it deserves because we can all buy it over the counter at Walgreens and CVS. So a lot of patients are like, no, I can buy that for myself. I want something good. I want something only you can give me. But we should remind them that Tylenol is a great choice, and it's great for chronic pain, and it's good for mild pain, and it's good for pregnant patients. Now, it's less effective in some literature. Some people think that it is less effective than NSAIDs for inflammatory pain, such as gout. But it's great for lots of other conditions, and in fact, if a person has bony pain, I'm still giving them Tylenol. Now, this can be liquid, pill, IV forms. The one thing to remember about that IV form is it's expensive. I looked it up. I think a bottle is like $30, whereas a pill is like 0.05 cents or something. So it is quite expensive, and if they don't need an IV Tylenol, don't give it to them. Now, the effective dose, this is obviously one to remember and keep in your mind, 15 mg per kg, and the analgesic ceiling is 1 gram or 1,000 milligrams. So I usually tell people, they can take about 3 grams a day. Now, the true answer, according to the FDA, is that they can take up to 4 grams a day. But generally, patients are going to go home, and if they've got pain, they may take more than you have told them. So if you say 3 grams, they take a little bit more, they're still going to be fine. The big contraindications are people who have terrible livers, okay? Again, we know this, Tylenol and livers. So if someone has underlying liver disease, cirrhosis, you're going to be careful with this. And it lasts for about 4 to 6 hours. This is great for people who cannot take NSAIDs. Let's talk about NSAIDs. And when we think about these, I think we're usually going for ibuprofen. This is the drug that we usually talk about. At a lower dose, so 400 milligrams, it's an analgesic. At a higher dose, 600 to 800 milligrams, it has anti-inflammatory effects. And this is useful for people who, again, have inflammatory conditions such as gout. It's a wonderful choice for anything that's prostaglandin mediated. Prostaglandins, remember, those are involved in our inflammatory cascade. So biliary colic, renal colic, menstrual cramps, anything like that, it is a wonderful choice. The big side effects here, and there are side effects, GI bleeding. It can worsen CHF and hypertension because it can cause some salt retention, and you can't use it in people who don't have good kidneys. So you're always going to have to use a different agent. Remember those big side effects. But I do love it for kidney stones. If there's not a contraindication, I think it's great. What about aspirin? This is the forgotten NSAID. And it's true. I don't really use aspirin to treat pain. I don't know how many people out there do use aspirin to treat pain. I'm curious to hear about that. But I don't really use it very much. I think of it more when someone comes in who's having a heart condition. Maybe I'll give them aspirin. It can be effective, though. It is an NSAID. And there's the dosing for you, 325 to 650. It lasts for about 2 to 4 hours. It can have GI side effects. GI bleeding is the one I worry about. And remember, with any NSAID, and really what we're talking about with the side effects, especially something like GI bleeding, it's not necessarily the dose, it's the duration. So if someone's on 400 milligrams of ibuprofen, sure, fine. But if they're taking that for a month, they are at a higher risk of coming in with complications and GI bleeding. So these are like the elderly patients who are on 81 milligrams of aspirin, and that's not a super high dose, but they've been on it forever, and then they come in with GI bleeding. It's the duration that we need to worry about. The big thing about aspirin, if you are going to use it, watch out in children and in teenage patients. You should not be using it for any kids, especially if you're concerned about a viral illness because of Reye's syndrome. Ibuprofen, naproxen. So these are our usual go-to NSAIDs. Here's the dosing. For children, it's 10 mg per kg every 8 hours. We talked about 400 is really the analgesic ceiling in adults, but you can go higher for inflammatory conditions. And then naproxen. The nice thing about naproxen is that you just dose it twice a day. So instead of ibuprofen where you're taking it every few hours, it's twice a day dosing. So that's kind of easy and nice. Ketorolac, this is the only IV NSAID in the United States. Can you believe that? That is interesting. Now, outside of the United States, there are other options. But in the United States, this is our only IV NSAID option. A few things about it. Now, I am kind of a Toradol fan because I have seen it work so well for patients who are in extremis from kidney pain from a stone. You give them some Toradol, and it's amazing, the relief that some people can get. But Toradol can have some major side effects, and those generally come from overdosing. So remember, you really only need 10 to 15 milligrams to treat pain. You don't need to be giving 30, and you certainly shouldn't be giving higher than that, because there are studies that have shown that people can develop renal failure, not just temporary, but like dialysis. So be careful with your Toradol. Use the lowest possible dose, and consider contraindications to NSAIDs. The other thing about Toradol is that it's, if you're giving it IM, it's really no better than oral ibuprofen. So if the person does not need an IV pain medication, you don't need to give it. Opioids. Okay, the opioid epidemic is real. And I think that is part of the reason that we have gone down this path of oligoanalgesia and not properly treating pain, because we're all a little bit gun shy. We're scared about contributing to the opioid epidemic. We've been taught a lot about people who come in and have sort of drug-seeking behavior. And so in response to that, we're all a little on edge. And like, does this person really have pain? Should I really give them opioids? Here's how I like to think about it. Again, I said it's always good to assume the pain is real and treat it. The other thing is, the person is, they're suffering, and we have something that we can use to treat that pain. So I am always going to defer on the side of giving them the pain medication. So it is complicated. There are a lot of different players involved with the opioid epidemic, but us treating pain in the emergency department is not the big problem, especially when we're talking about treating pain in the ED. Now, when you're writing a prescription for patients to go home and you're writing them for 30 tablets of Percocet, maybe rethink that. But when you are treating pain in the emergency department and the person needs an opioid, do it. Go for it. This is the one thing we can do to kind of make their day a little bit better. And I would much rather improve someone's day. And I like to be on the side of, how can I help you? How can I make your day better? The patient feels better, I feel better. It's kind of a bummer to come in and be like, I don't know, I don't really know if you have pain and you're kind of on edge, and then the patient's not happy, and that just makes everyone's day worse. So if we come in and we're like, yes, I trust you, you've got pain, I'm going to treat you, the patient feels good, everyone's day is better. So that's my 2 cents on it. Okay, now the best agents for acute pain control are going to be fentanyl, morphine, hydromorphone, Dilaudid. Demerol is out. We're not really using that. It has a lot of side effects. The best oral agents for control of moderate to severe pain are hydrocodone, oxycodone. These are your Percocets, your Vicodins, your Norcos. What about codeine and tramadol? Some of you may have heard, there's a lot of contention, a lot of talk around tramadol. In fact, a lot of people have adopted this phrase, tramadont, just tramadont. And so the reasons behind not using codeine and not using tramadol is because they have very unpredictable metabolism. And for some people, they work great. And for other people, they may have a totally toxic effect. So they're unpredictable, they're dangerous, we don't really know how someone's going to respond to them. And so I do not prescribe codeine, I do not prescribe tramadol. Now, if someone comes in and they're on it, they've been on it for a while, and it works for them, fine. I'm not going to stop that, and I'm going to say, great, if that works for you and it's been something that you've been taking, fine. What about IV opioid agents? Okay, let's talk a little bit about morphine. So morphine sulfate, just a note here, when you're charting, you do have to write it out. You can no longer write MS. The dosing here is 0.1 to 0.2 mg per kg IV. And the reason this is so important to think about is because I feel like a lot of times, like my residents, they'll say, oh, it's an adult patient, just give them 4 milligrams of morphine. It's like they've memorized just 4. But we need to remember the dosing, the actual dosing, 0.1 to 0.2 mg per kg IV. If you have an 80 kilogram adult who comes in, that is underdosing. If you're actually following this dosing guideline and you're only giving them 4 milligrams of morphine, you're underdosing the morphine, right? So remember that. You can give them 8 milligrams of morphine. That's, perhaps the proper dosing for them. So that's something that you should consider. And when your colleagues come up and say, like just the other day, I had one of my wonderful nurses came over and she said, "Are you sure you want to give 4 milligrams of morphine to this woman over here? She's a little bit older." I said, yeah, no, that's the right dose for her. So you absolutely want to remember this dosing because it can back up your practices and kind of reassure people that you know what you're doing. Now, it may cause histamine release. It can cause a little bit of itching and hives and hypotension, so keep that in mind. Dilaudid. What about Dilaudid? It is 5 times more potent than morphine. So the dosing here is significantly smaller. We're going to use 0.5 milligrams to 1 milligram usually. Now, the exception here is your patients who have sickle cell or chronic pain. Those patients are often on very high doses of pain medications. They might say, "I'm on 4 milligrams of Dilaudid," and we should trust them. Those patients generally know what they take, and it's usually well documented, so that is an exception. But generally for Dilaudid, 0.5 to 1 milligram, and the dosing is written here for you. What about fentanyl? The big thing to know about fentanyl is that it is 100 times more potent than morphine. And so the dosing is in micrograms. Micrograms. Memorize that guy because it's very easy to misspeak when you're ordering something. 50 to 100 micrograms IV is usually appropriate. And it's nice because it does not have a lot of histamine release, and it's very quick acting. The downside to fentanyl, it's also a short duration and does not last long. Opioid adjuncts. Now, in the past, there was this practice of giving antiemetics to your opioids, thinking, oh, it'll have a synergistic effect and they're gonna feel better. That's kind of been debunked. So we should just give the opioids. If someone develops nausea, vomiting, then you can go ahead and give the antiemetic on top of it. But you shouldn't just hand in hand give them both together. So quick review, oral opioids, you can use these in the ED, especially in patients who don't need immediate onset pain control. And when you discharge the patient, the big thing to remember is you need to counsel your patients if you're writing them a prescription for oral opiates. They shouldn't be drinking with these. They shouldn't be operating heavy machinery. Really shouldn't be driving on these medications. It should be, I like to say, take this at night to help you sleep if you absolutely need it. And you want to give them the lowest dose possible. So I usually do not give more than 10 to 12 tablets. Specific oral opioid agents, hydrocodone, oxycodone, the dosing is there for you. A nice little tip is that this also can come in a liquid form, in an elixir form. And if you need to give it to children, you can, or if the person has a G-tube. Medications, a little miscellaneous mixture here for you. Fentanyl can be intranasal, and this is beautiful for your kiddos who come in with trauma. I love to use intranasal fentanyl, and again, your dosing is there. Just remember your first dose is 1.5 micrograms per kilogram. And then your second dose, you're going to wait about 10 minutes, and you can give maybe half of that dose, sometimes a full dose. Ketamine. What about ketamine? Sub-dissociative doses. So this is just for pain. This is not for sedation, just for pain. It can be useful, and the dosing is 0.15 to 0.3 mg per kg IV. That's about half what you're going to be using for dissociative dose. Nitrous oxide, not much to say here. I don't actually use a lot of nitrous oxide. It's a gas, and we should be cautious about it because it's 50-50 nitrous and oxygen. So you're not going to use it in someone who's needing oxygen, who has an oxygen requirement. You're going to take away some of their oxygen and give them half nitrous. You don't want to do that. And you also don't want to do it in people who have bowel injuries or eye injuries. Any place that gas can go and expand, that's where you don't want to be using this. So when you're discharging patients, if they have mild pain, again, Tylenol is wonderful. Go for the Tylenol. NSAIDs, worry about those side effects, complications, GI bleeding, renal disease. Always consider your non-pharmacologic agents. And if they have inflammatory pain, you're going to use higher doses of NSAIDs. Remember, that's your 600 to 800. And you can consider non-opioid regimens, but if they really need an opiate, just remember you're not going to give them too many, maybe 10 to 12, and you're going to counsel your patients. Got like 1 minute. I'm going to talk to you guys about procedural sedation, and I can do this pretty quickly. The big things about procedural sedation is that it can be mild, it can be deep, it doesn't really matter. In the emergency department, we are always prepared for the worst possible outcome. So always assume that your procedural sedation is going to go terribly, you're going to way over-sedate the patient, they're going to stop breathing, and you're going to need to intubate them. That's what you should assume before you even start. So have all your airway equipment at the bedside, do your entire check, and this is a big procedure. The JC requires that we follow a lot of strict protocols. You need to consent the patient, you need to screen them, you need to have the proper personnel, and you're going to have everything at the bedside, like I told you. The one thing you really need to remember that is sometimes overlooked is end-tidal CO2. Make sure that you hook your patient up to end-tidal CO2 and know that baseline end-tidal before you start the sedation. Why? Because this is the first indication that the person has hypoventilation and is not breathing as much as they should. So end-tidal is your best friend, not the oxygen saturation. Remember, young, healthy patients, they're going to be able to hold that oxygen saturation even when they're not breathing for a little while. End-tidal will tell you immediately if you've oversedated the patient. So a normal range, it's usually about 40. And how does end-tidal work? Remember, this is the exhalation of carbon dioxide at the end of your exhalation, should be about 40. And when the person has hypoventilation and is not, they're a little oversedated and their respiratory drive has been depressed and they're not breathing quite as much, what does the end-tidal do? It rises because they're holding on to all that CO2, so it rises. So if you see that CO2, that end-tidal going up, you know that that person is not breathing as well as they should. The big red flag is when it drops then to 0. When it completely drops, that means they're not breathing at all. The patient is apneic. And that is when you need to do a jaw thrust. Well, really, you probably jaw thrusting when it starts to rise, but that's when you need to bag and assist the ventilation. So that's the big thing about end-tidal CO2. When you are choosing agents for sedation, you're going to think about why you're sedating the patient, what depth of sedation do you want, how long do you want that sedation to last. Think about patient factors, and all your agents are going to play into this. So midazolam, this is a great drug for sedation. You can combine it with fentanyl for analgesia. The onset is 3 to 5 minutes. It's pretty quick onset. It can cause respiratory depression. Ketamine, what a weird drug. It's like this PCP-like agent. The beauty of it is the person keeps their blood pressure, they keep their respiratory drive, but they are completely gonked out and don't know anything else that's going on. So it's a really interesting medicine. It is an analgesic and a sedative, has that beautiful sort of dual property. The big side effect that you need to watch out for is laryngospasm. So you need to push this slowly, usually over about 2 minutes, have your watch out. And nausea and vomiting can be common afterwards. The onset is pretty quick, 1 to 3 minutes. The downsides, as I said, laryngospasm. You can also have nausea, vomiting, you can have hypersalivation. You're not going to use it in patients who are very young or have signs of bad cardiac disease, because another big side effect, tachycardia. You push the ketamine, the nurse says, oh my gosh, why are they so tachycardic on the monitor? It's because of the ketamine. Etomidate, this is a good one for short procedures. Now, this was traditionally used and is still used as induction for intubation. It has no analgesia, none. Okay, that's the big thing to remember. And it also can cause some myoclonus, a little bit of shaking. So it's not great if you need the patient to be totally still for a procedure. But the onset's very quick, 1 minute, and it lasts for about 5 to 10 minutes. Propofol, this is the real deal. This is what is used in the operating room. And this will cause a deep sedation pretty quickly. The patients will not be breathing. You will need to bag them. You got to be careful with propofol. It has some pain on injection. So when you're pushing this white milky substance, a lot of times the patient will say, ow, my hand, it's burning, it hurts. Normal, totally normal. And I always warn my patients to expect that as we push the propofol. It's no longer contraindicated in a soy or egg allergy, so you can use it. The big side effects, hypotension. This will definitely cause hypotension in your patients. It's not a good choice for a patient who you're worried about bleeding or they're hypotensive. Not a good choice for that. But it's a great choice for orthopedic procedures because it causes amazing relaxation, and ortho can do what they need to do. Ketofol. So I actually love ketofol. Originally, it was thought it's a mixture of ketamine and propofol. People thought that they had this synergistic effect, and you wouldn't get decreased respiratory drive. People would keep breathing, and you wouldn't get hypotension, and it would be like the best of both worlds. Well, it hasn't totally panned out that way. The studies don't really support that. Some people still love ketofol, and it's nice. Basically, the way it works is you're going to use. They do work synergistically. You might get less vomiting and less nausea if you use this. You're going to use half a mg per kg of each in a 1-to-1 ratio. That's it. I'm sorry I went a little bit over, but it was an absolute pleasure talking to you, and if you have any questions, I will address them at the Q&A. Thanks.
Okay. So there aren't many classes we do where it's like you have an upper and a lower, right? There's no upper and lower eye class, right? Or upper and lower leg. I was like, but upper and lower abdominal disorders, we have to break those up because there's just so much stuff going on in the abdomen here. And when I talk about upper abdominal disorders, I want to make sure that we're talking, you know what we're talking about here, and that you're aware that just because someone comes in with the complaint of upper abdominal pain, it doesn't mean their problem lives in their upper abdomen, okay? It could be in their lower abdomen, but they feel the pain in the upper abdomen. It could be in their chest cavity, but they feel the pain in the upper abdomen. I will never forget this appendicitis case. I took care of this lady who came in, chief complaint, epigastric abdominal pain. Vital signs fantastic, just a couple hours of pain, do the exam, a little tenderness in the right lower quadrant. Long story short was I got concerned that she had appendicitis, she refused labs and whatever else here, and I said, okay, I need you to come back in 8 to 12 hours when you are worse. And she rolled back in 6 hours, tachycardic and febrile. We took her appendix out, okay? All from a chief complaint of epigastric pain with nausea and vomiting, okay? So be aware that just because it's a pain is there, it doesn't mean that the problem is there. Think up, think down, think around the back as well. When people say they feel something hung up in their throat or in their chest after they ate something sharp or pokey, let's say fish or something like that here, usually it's one of those things that you can kind of take to the bank and believe, and it's good to relate to the GI specialist. Because a lot of these foreign body cases are going to end up needing to see a GI doctor that day if they are impacted specifically, okay? You know, if the person has like the slightest bit of like just irritation and there's absolutely no respiratory complaint at all, they're not coughing, they're not having a hard time breathing, obviously they're not spitting into an emesis bag, having a hard time controlling secretions. It was just the mildest of discomfort, and they're very PO tolerant and no concern at all of an impaction here, then they don't need to get scoped necessarily. How can you kind of help yourself along, help the patient along? Let's take a look. If they're saying they have something in their throat, let's take a look. Like first just have them open wide and say, and sometimes you'll see the fishbone poking out from the back of their oropharynx. Nowadays, I feel like fiber optic scopes are becoming a lot more common. For sure, video laryngoscopy, VL, is becoming more common, right? So we have a lot of these great tools in the emergency department often that we can look down the gullet and see if anything is down there, like dentures or anything like that, okay? X-ray is a nice try if you want to look more, but understand that X-ray will not see every little thing, okay? Fishbones often don't show up on X-ray. I took care of a fishbone case early in my career, and I was like, it's a bone. Like, clearly it's going to show up on X-rays because bones show up on X-rays. Well, no, a lot of fish bones are cartilage, actually. And so if you're concerned or the patient's very insistent, CT scan is a way to better localize those things, but not always required. I like chicken salad, but this person apparently really likes chicken salad, okay? This is some chicken salad impacted in the esophagus, and like I said, these people are usually very uncomfortable, retching repeatedly, spitting into an emesis bag because they can't control secretions. Usually these patients are in a lot of distress, okay? So give them the tools to control their own, saliva. They might even know. They're just so uncomfortable. They're just kind of writhing around, sitting on their side, laying back. Have them sit up so they can spit out better. There's lots of different kind of medications that can be used to help some of these things, and we're going to go into them in a second. Even if you happen to clear it in the emergency department, because sometimes they'll just kind of clear spontaneously. They check in, and you go to check on them again, they go, oh, you know what, it passed. Or you do something and it passes in the ED, okay? Impress upon them how important it is that they see a GI specialist still. Because a lot of folks, I think, oh, it passed, problem solved. A lot of these folks, I think it's like over 50% of these folks have some anatomic thing going on in their esophagus. Hopefully it's just a web or a ring. Maybe it's cancer. Okay, so really important to clearly give them a GI specialist to follow up with, because someone needs to look down there if we didn't do that when they came into our setting here. Eventually someone's got to look. Okay, so what can we do here, right? Glucagon is classically ordered, and kind of these randomized control studies on glucagon suggest that it'll probably increase your likelihood of passage by about 10 to 12%. Okay, except spontaneous passage with no glucagon also happen at about 10% of patients. So like, I'm not thrilled about glucagon, especially if a side effect of glucagon is inducing vomiting. So we have chicken salad impacted into someone's esophagus, and now I have a closed space and someone vomits, increases pressure in that closed space here. That's not good. I could induce some sort of esophageal injury with that, okay? Unfortunately, it is still kind of considered a common thing to do. Glucagon, often some sort of benzodiazepine like Ativan can be given as well. Carbonation. So I like this a lot, this approach here. So you often get this from the radiology suite. You get these things called, the brand name is Easy Gas, but there's other brand names, I'm sure. Comes in a little like, almost like, looks like a sugar packet, okay? And these are effervescent granules. They're like Pop Rocks. And it says here on the slide, I guess maybe the standard treatment is like, mix it with, you eat those, and you follow it with 240 mLs of water. Okay. This person can't even handle their own saliva very well. And some of you have like expensive bottles of 240 mLs of water in front of you right now. That's a lot of water to come back out onto your nice scrubs. Okay? So my approach is this. I don't use that much water. I kind of get 2 little medicine cups from the medication room, and I almost kind of set up a little like Irish car bomb technique, right? I'll put the effervescent granules in the one cup, and I put about a half or 3/4 of water in the other cup, and I have the patient kind of dump the granules in, and immediately, boom, down the hatch with that combo, and just have them swallow as hard as possible. And sometimes that causes enough gas pressure to dilate the esophagus temporarily, and boom, down goes the chicken salad, okay? Something that is gaining traction but is not yet standard of care is dissolving a nitroglycerin tablet, a sublingual nitro tablet, and drinking that. It's a smooth muscle relaxant. That's why we use glucagon in the first place, right? So that's another interesting thing that's been seen in like case studies, not yet standard of care, and I wouldn't do it for the first time without talking to somebody. Okay, if you're a PA or an NP. If you're a physician, then you have a little more leeway, I feel like, but you know, PAs, NPs, I would be careful about just pulling that one out before talking to someone. But I've seen that happen in my ED. The doc I was working with here, he went ahead and did that for a patient who had a really hard time with an impaction. These button batteries are really nasty. These are the things that have to get out if they're in the esophagus. Classically, you see this stacked pancake sign because of how these batteries are shaped. The good news is that if the battery passes into the stomach and into the small intestines, a lot less concern. It gets coated with poop, which kind of reduces the ability for it to do damage, and out it goes in the stool later on, hopefully here. But if it's been there for a couple of hours here, these things can cause burns very quickly, and they can cause problems down the road. There's a case study of a kid who had a button battery. It was retrieved in the acute setting. 18 days later, he had a perf and a bleed, and he passed away, unfortunately. So these are high-risk issues, even if you do all the right things to get that out as fast as possible in your emergency department. Got to impress upon them very close follow-up, important. You're getting worse, you've got to come back immediately so we can check you out again. Okay, I wish when someone typed in esophagitis to the EMR as a discharge diagnosis, right? I wish that little paperclip from Microsoft would pop up and say, hey, it looks like you're trying to diagnose esophagitis without directly visualizing the esophagus. Are you sure you want to do that? Okay, because esophagitis is a very specific diagnosis. It's an itis of the esophagus. And we can kind of like assume, or at least suspect, esophagitis in a lot of patients, right? If they eat spicy foods 8 days out of 7, very common in my practice in Texas. But at the same time, don't just think, oh, retrosternal chest pain, you eat a lot of spicy foods. Clearly, this is a benign cause. Oh, you got better with a GI cocktail? Clearly, this is from something benign. Be careful with using esophagitis as a diagnosis. I don't use it unless someone's already been directly visualized and they tell me that they have esophagitis. Okay, I just call it chest pain. Some folks may be rushing here, dump their pills down their hatch and didn't get a whole lot of water with them, and maybe you've got some pill esophagitis coming on. Some very common reasons for pill esophagitis for some very common medicines. So just shout it out there. What's a very common reason for pill esophagitis? What pills often cause esophagitis here? Let me hear it. I think I hear NSAIDs somewhere over here. Okay, so yes, NSAIDs, very irritating to the esophagus, okay? Back in the Army, the treatment was often like any painful condition, take an 800 milligram ibuprofen every 8 hours. And often people just down the hatch with their own saliva, and that can cause a lot of bad irritation. So NSAIDs, how about a supplement that is given to a lot of pregnant women? Iron, thank you. Iron, very irritating, and there's often some suggestions on how you can better absorb the iron as well. How about an antibiotic we are now giving more to our sexually active patients? Doxycycline, thank you. I was supposed to take doxycycline every day in Afghanistan to prevent malaria. And I had people come to me all the time and say, Doc, I'll take the malaria, because it was just so upsetting to their GI tract, okay? So much abdominal pain, vomiting, diarrhea, right? So there are ways to deal with the side effects of doxycycline. Martha Roberts and I do what I think is a great podcast called The Two View, and we're doing an episode today after our classes end for the day, so feel free to hang out and listen to us do our recording here for November. But we talk about doxycycline and how we're using it more for the treatment of chlamydia in most patients. And it's very important, I feel like, to really specify to them, hey, you've got to be very careful. We want to make sure you're compliant with this, because we worry about the rise of noncompliance and then the rise of chlamydia in our patients because they can't make it to day 7. It's just so irritating. So check out our podcast. We talk about it more in detail there. Same thing with gastritis. How do you know it's gastritis? Maybe it's just stomach upset, okay? Treat it kind of the same as esophagitis. Let's talk vomiting. I love talking about vomiting. I feel like I am incomplete if I end my shift without having a vomiting patient. It's such a common complaint. We need to know a lot about it and be very good about it, okay? The top line, I think, is super important, right? Because you can see vomiting, of course, after some sort of benign viral gastroenteritis, but maybe they had a head injury and they have some increased intracranial pressure. Maybe they got a small bowel obstruction. Maybe they have some sort of other organ failure, okay? Maybe they've got glaucoma. Hey, you're having vomiting? Are you having a headache? How's your vision, okay? Or maybe they have cannabis hyperemesis syndrome. Let's talk about it. Who here works in a state where they've legalized marijuana? Who is really happy about that? No, it's really miserable, okay? Because people come in really you can diagnose them, thankfully, often down the hall, right? Because you hear them coming, okay? Patient with vomiting checking into room 3, and you hear them vomiting pure sound into the emesis bag, right? Just, it's like this really horrific sound, like they're being exorcised, okay? Not exorcised, but like from a priest exorcised, okay? So what do I do about that? Okay, so I think the approach is super important, okay? Because as you guys have figured out, a lot of the classic medications for nausea and vomiting don't work on these patients, okay? What also doesn't work very well is a suggestion that, hey, maybe the reason you're vomiting is because you're a pothead. That doesn't work very well either, okay? So I have to kind of like get on their side a bit. So how do I just first get them to admit that they smoke marijuana every day, like they were just hotboxing it in their car on the way into the ED? How do I get them to admit that? I have to do like a jab, jab, uppercut. How often do you smoke tobacco? I don't really care unless I'm also thinking about other things that tobacco does. How often do you drink alcohol? Not do you or not. This is not a purity test of some sort. I just want to know how much you use it. How often do you use recreational drugs? Not illegal, like I'm a narc or something, okay? And not illicit, but recreational. How often do you use them, okay? And you'll be shocked at people just admitting that they like do coke or meth or things like that, okay? So classically, this cannabis hyperemesis syndrome is on our regular users, okay? Daily or multiple times a week for several, weeks to months in a row. And Haldol, haloperidol, 5 milligrams IV, so many of these lions get turned into lambs after a little bit of Haldol, okay? Now be aware, Haldol, the rap on Haldol is that it can cause QT prolongation. So it's important to understand what other medications are you already taking for other stuff right now. Do you already have congenital long QT syndrome? Okay. Maybe you burn an X-ray before, an EKG before you give it, or at least look on the monitor and see does it look like long QT on the monitor before I give it? Okay. And often I want to just get a good history before I order the Zofran, because ondansetron is also a QT prolonging medication. So if I just put Zofran in them, and after we push the plunger, they go, oh, and by the way, I smoke marijuana every day. It's like, oh, shoot, this is not going to work very well for you, unfortunately. And that's the kind of attack I get, It's all about them. If I sense there's more to be told after I ask those questions, I say, look, I don't care from a legal perspective if you smoke or not, but the medications I would give you if you don't smoke are not going to work as well for you if you use marijuana regularly. So I just want to get you feeling better faster. Because I think marijuana is a great drug. I think marijuana is a great drug, and I think its use in medical settings has yet to be tapped by traditional medicine. Try to make sure they know I'm on Team Green, right? That I'm a safe person to talk to about how much they smoke. Okay, there's lots of ways to increase your, information coming out of the patient if you really show them that, look, I'm just here for you. You feel miserable. You look miserable. I want you to feel better, faster. This is why I'm asking these questions. Okay. And then the last part I'll say is this. Look, I don't smoke a lot. You smoke more than me. You know a lot more about marijuana than me. But High Times Magazine has been reporting on cannabis hyperemesis syndrome for years. And I'll even give them a handout, like an old article from High Times Magazine with their discharge instructions, okay? Just don't try to get on hightimes.com on your hospital internet, okay? You'll have to explain that to somebody later on probably, okay? But I have that saved, so I'll hand that out sometimes to people. It's like, look, I don't know more about smoking than High Times does. And if they're saying maybe you dial it back, maybe you dial it back. And it takes about a month for it to get out of your system. Maybe you feel better after that. Okay, I just like to go over that because these are often hard cases to crack, these CHS patients, so hopefully that worked out well for you guys. Let's talk other more standard treatments here. Ondansetron, we give it probably first line for everything because it's like pretty, well tolerated by a lot of people, no sedation here. Just be careful about our early pregnant patients. Again, Ken Milne, SGEM blog and podcast, there is a study suggesting maybe an increased risk of oral clefts in the first trimester. That being said, it's not that you can't give it, but maybe there are other medications that are safe in pregnancy that you can give that don't increase that risk, okay? So metoclopramide, great. It's back in the category days of medicines, category B for pregnancy. Prochlorperazine, category C for heavy use in the third trimester. So you're good in the first trimester. So we have options beyond just hitting the Zofran button every time for someone who's vomiting, okay? Promethazine you probably know about. Some EDs you can't even give it IV because too many bad outcomes. If you're going to give it low dose, diluted, pretty good. GI bleeding, classically we talk about, upper GI bleeding comes out the back door as black melena. Lower GI bleeding classically comes out the back door as bright red. That's not always the case, though. If someone's having big time hematemesis, there are different cards to use other than your stool guaiac, your Hemocult. There's a gastrocult card if you want to make sure this is blood and not red Kool-Aid or Flamin' Hot Cheetos or something like that, okay? Important to understand Mallory-Weiss versus Borjas. Mallory-Weiss, the classic scenario is I vomited 10 times, and on the 10th time, a little bit of blood came out. And I'm not having a lot of pain. I'm just freaked out because there's blood. That's classic for a little superficial abrasion of the esophagus. You get a little blood out. As long as you can stop the bleeding, stop the vomiting, that little abrasion heals up usually very well. Okay, versus Boerhaave's, violent vomiting followed by severe chest pain. Okay, this is full thickness rupture of the esophagus, super bad, super emergent here. Big difference in presentation between these cases. Okay. Debate about how much lactated ringers or saline you're going to put into a patient who is having GI bleeding, because if they're having blood coming out, they need blood going in, and not just pasta water, right? But nice to maybe challenge them with a 500 cc bolus. Okay, me and Chip, who you met earlier today, we do an ATLS kind of podcast on Total EM for him, and that's one of the kind of debates we had on one of our episodes, was how much do you really give? Because current ATLS standards say give a liter when you're suspecting bleeding to challenge shock. And that's too much, I feel like. We can challenge, shock with a 500 bag without diluting out their clotting factors and such, okay? Obviously, type and screen to get them ready if you think a bleed is really going on here. Type O. Yes, you need an Rh negative blood for someone who is a young, childbearing age woman who is also Rh negative. But if this is a patient who is either well past childbearing years, doesn't have uterus, or is male, it's okay to give them the O pause with, fast release blood. We're not worried about that alloimmunization there with them. So consider that to spare your O neg blood. Okay. I feel like a common practice is maybe a GI bleed. Let's give them 80 and 8 of pantoprazole, right? 80 milligram push, 8 milligram per hour drip. It's not really shown by literature to stop or lessen the severity of a GI bleed, though. So that may be a local practice. Just understand it is one of those things that is a practice, but not necessarily backed a lot by evidence. Okay. If I'm trying to get some irritation, just the discomfort to go down, famotidine, H2RIs, hit max effect in a half an hour to an hour. That's an emergency medicine medication, right? Versus PPIs can take, days to hit max effect. I don't have time for days. I need something that works kind of right now. So famotidine, a big favorite of mine if I'm thinking more of more gastritis type stuff, okay? The big thing I want to say here, because boy, we could get crazy on our large volume transfusions, is understanding the paradigm now of balanced transfusions. You're not just giving PRBC after PRBC after PRBC. This was a thing we figured out in Iraq early on, was patients do better not just with all these RBCs, but let's get some platelets. Let's get some plasma in there as well, okay? Hypocalcemia on the second bullet. You might have heard about the lethal triad of trauma. Some folks are advocating to make it now the lethal diamond of trauma and adding hypocalcemia in there. Because if you give a bunch of PAC cells, that can lead to hypocalcemia and cause other downstream effects. So be aware of looking for calcium and considering that if you have a big bleeding patient here. I changed my practice on pancreatitis earlier this year after listening to this JAMA clinical review on pancreatitis, and we go into much more depth in a 2View podcast. So love for you to listen to that here. The thing I want to hit most of all is that, what's going on here? Well, some sort of damage has happened to the pancreas. It's leaking the enzymes that it uses Okay, the pancreas dissolves sugars and fats. We are all made of sugars and fats, okay? And so the pancreas is basically digesting ourselves from the inside. So we need to get that injury to stop. And what can happen is you get all this third spacing. Used to be, oh, a pancreatitis patient, let's start with 2 liters of IV fluid and go from there. Okay, but we're realizing, hey, this is not necessarily a hypovolemia problem in the sense of all the vomiting, but they are third spacing. Okay, they're getting this edema. And so if they're already into that third spacing reason for shock, and you start dumping more fluid in them because like they're hypotensive, and you get their pressure up, maybe you're making that worse. That fluid is not going to stay in the vascular space. It's going to go extravascularly, make your problems worse, give you like abdominal compartment syndrome, stuff like that. So be careful with that. Alcohol gallstones kind of tie for most common reasons in the U.S. for pancreatitis here. Rarely high triglycerides, lots of medications, including marijuana. Boy, by the way, how similar does an acute pancreatitis patient look to a patient with cannabis hyperemesis syndrome? Right? Very similar. So just be careful about, oh, it's Jimmy's 5th time this month coming in for his cannabis hyperemesis. Still have a broad differential diagnosis here, okay? And a classic thing on boards is like scorpion or wasp bite, and now severe upper abdominal pain and vomiting here. Consider pancreatitis. It's rare. That's why I put it up there, just because it's interesting to talk about. Lipase is the money for acute pancreatitis. I wish we would stop ordering amylases in the ED. I don't think it's necessary. Doesn't add diagnostic certainty when you're uncertain otherwise for acute pancreatitis. Checking the other belly labs is important because maybe this is a gallstone pancreatitis. If I see my lipase bumping greater than 3 times normal plus bilirubin plus alk phos elevated, hey, there's probably some sort of connection here. One study suggested ultrasound changed management of acute pancreatitis patients in over 50% in this study. Because is it a gallstone? Is it alcohol? Is it something else? So, hey, there's no radiation involved. I'm quick to order ultrasound in patients for acute pancreatitis here. You don't have to do the CT if they're coming in on day 0 or even day 1 and it's somewhat mild to moderate pancreatitis. We talk more about that on the podcast, okay? And turkey sandwiches are therapeutic for these patients, okay? It used to be you have pancreatitis, you're only going to drink Powerade and broth for the next 2 or 3 days. Enjoy that, okay? But no, we're finding that if you give whatever they can tolerate, PO, food, on day 1, then that kind of helps decrease some sequelae, some bad sequelae of pancreatitis. So it's okay that they eat. Ranson's criteria was kind of like the old school way to assess severity of pancreatitis, but I mean, half of it is calculated after they've been admitted. So not a great test for us as emergency medicine PAs, NPs, MDs, DOs. So this BISAP score is kind of the new one. Bedside Index of Severity of Acute Pancreatitis. It also shows you, or reminds you, what BISAP stands for. So super cool. You want to score at 2 or less, and if that's the case, mortality risk less than or equal to 2%. That's pretty good. Okay, I like those odds. But another study suggests SIRS criteria by itself is enough to get you worried. If they come in tacky and hypotensive, and you treat them and they're still tacky and hypotensive, but nothing else is there for the BISAP criteria, still consider bringing them into the hospital. Because you can still have a small but significant amount of these people get worse and die from pancreatitis, from all just the damage that's going on here, okay? These are 2 things I like to look for and document on our pancreatitis patients. They're not going to be in our milder pancreatitis patients. Okay, these are the pretty severe ones. Cullen's, Gray Turner's. I think about Gray Turner's as the flank. I got to turn the patient to see Gray Turner's. That's how I remember that one. Okay. Hepatitis, we think of like, oh, hepatitis, right? I got vaccinations against hepatitis. But there's also drug-induced and alcohol-induced hepatitis. It's all considered hepatitis, okay? The symptoms are all kind of the same. It's kind of like sounds like kind of gastroenteritis. You got like a little nausea, your appetite is less, you got a little discomfort. But some things that are unusual, maybe the liver is enlarged, maybe they're getting jaundiced, maybe there's some change in urine color. So those are ways to think about, like, is this something else other than, Wednesday after Taco Tuesday? Okay. These folks are almost always going home, even if you diagnose them with hepatitis here. If there's encephalopathy, so their brains aren't working properly, number one, you're looking for an ammonia level, and number two, those folks will stay. Our true liver function test is our coags, right? Alk Phos, bilirubin, ALT, AST, those assess for liver injury. They don't tell me how well the liver's working, though. So coags are a good, thing for that. If that person's, INR is 2.5, 3, and they're not on some sort of, warfarin or something, that's weird. You should come in because maybe your liver is not working as well we think it is, okay? Lots for biliary disease here. It can cause different problems to the liver, to the gallbladder, to the pancreas, depending on where the stone hangs up, okay? I think about, do I order ultrasound early or not in this patient? Because I'm worried about, cholecystitis or something. If the pain's been there already for like 3, 4, 5 hours or more, and it's not gone away a bit, I'm just going to go ahead and order the ultrasound, even if there's no Murphy's sign, the classic finding, okay? That pain's not going away, getting worse. Yeah, I'm leaning toward ultrasound early. If the pain's more colicky, like, boy, it hits hard, then it goes away after half an hour, hits hard again, goes away after half an hour, I'm maybe going to slow play that a little more and get the labs and give pain medication first and reassess. Serial exam is very important. Ultrasound, super good. Bedside, if you're good at that, you can do that really quickly here, okay? If you're not quite sure, a CT scan is more sensitive to look for the inflammation of the, gallbladder or other things like that. This is pretty rare. These are both pretty rare here, okay? Acalculous cholecystitis. This is not a healthy patient. They're already pretty messed up from the jump, and then they get cholecystitis from that other condition here. Cholangitis, you see that triad classically. I see a lot of jaundice and pain, and a lot of pain and fever, but not a lot together. And when they're all together like that in that triad, be very concerned about this ascending cholangitis. If this just looks like colic, off again, on again pain, briefly, with no other signs of inflammation, whether by labs or imaging here, these folks can often go home if their pain and vomiting are appropriately addressed. Okay? Again, please don't be fooled by pain in the epigastrium and a little bit of a history from the patient. It's not always esophagitis. It's not always a problem up in the upper abdomen. Thank you very much.
Okay, oops. All right, I'm back. This is my last lecture of the day for me, and this is my favorite one, so I saved my favorite one for last. This is about environmental disorders, and this is truly a potpourri. All of these lectures are really a potpourri, but this one really is. We're going to jump around to wildly unrelated things. And a lot of the things under this umbrella of environmental disorders are things that, until emergency medicine existed as a specialty, we're kind of the redheaded stepchildren of medical topics that nobody really owned, to be quite honest. And a lot of them pertain to what we do. So you will find that these are areas that we now have experts in that before, like, nobody really owned them. So it's kind of a fun list of topics. So we're going to jump first into altitude illness. And for some of you who may have lived at altitude or live at altitude now, you know a lot about this. But for those of us who don't, just a review of what are the kind of things that altitude illness brings to the table. So as we go up in altitude and the oxygen concentration around us drops and our bodies are physiologically subjected to a relative hypoxia, a bunch of things kick in. We have an increased sympathetic activity, and what happens is that capillaries start to leak, in our, especially, particularly in very key end organs, our brain and our lungs, and this leads to a host of problems. Now, this can occur in anyone. Being in good shape doesn't necessarily protect you from this physiologic effect, which is important to know. And so this is a little chart of like, as you go up, looking at these relative hypoxic states, which over time, if you live there, you know that you can adjust to this. But if you do not live at altitude and immediately by the grace of air travel can go there, you can suffer a lot of symptoms. And like a lot of these environmental conditions we'll talk about, there is a spectrum of illness. So it kind of starts with acute mountain sickness. When you first get to your destination, you just don't feel great. You have a headache, you may have a little nausea. It feels like a hangover. And then typically this happens at around 8,000 feet, but that number is very variable from person to person. And this is kind of day one at altitude, and you feel this stuff, and you can't sleep very well. And if you happen to drink, that can make it worse, that's for sure, and alcohol for sure. And you can do something to prophylax against this if this is something you know you typically have, which is to take prophylactic acetazolamide. Acetazolamide, or Diamox, the trade name, is a carbonic anhydrase inhibitor, and it can do things to your metabolism that will help you counteract these sympathetic offsets of the hypoxia. So it increases your ventilation, that helps offset your CO2, and it can help offset the symptoms if you know that you get this. Now, if you don't take acetazolamide, which you certainly don't have to take, this will be a self-limited thing. You'll feel crappy for a couple days, and you can take some NSAIDs, and it'll go away eventually as your body starts to adjust. But if it's bad, ultimately the answer for a lot of these altitude illnesses will be that descent, of course, will help. Steroids may help, and a little bit of oxygen may help on these first couple days in terms of helping your body deal with the physiologic effects that it's encountering. Now, on the far end of the spectrum, just to mention, if you haven't taken acetazolamide, it does some very interesting things. It has some interesting side effects. It can make you feel tingly, which is normal, and it is a little bit freaky when you first take it because you're like, what is happening? But if you know that that happens, that's okay. And it can also make carbonated beverages taste very flat and sort of different. So those are interesting side effects you can look forward to. For HACE and for HAPE, this is high altitude cerebral edema and pulmonary edema, and as I mentioned, your capillaries start to leak in very key end organs. This is a bit unpredictable, but often people have some acute mountain sickness symptoms as they progress to this end of the spectrum. So high altitude cerebral edema is certainly life-threatening. This is the person who comes out of their tent and they're ataxic and they seem a little confused, and maybe they vomit, maybe they have a seizure, and it can definitely progress to coma. So absolutely life-threatening. And the ultimate answer is to descend, right? To get them out of that situation. But in a lot of situations, you can't do that right away, right? You're at altitude. You can't just descend. It's not that easy. So things that can be done at altitude include things like steroids, include things like a Gamow bag, which is like a mobile hyperbaric type of bag that you can do to temporize as you make plans to get out of there. HAPE, which is high altitude pulmonary edema, is actually the most lethal of these because your lungs cannot tolerate this type of edema. It's usually the second night that you're up there, people start to have shortness of breath, they can start to have RALs on exam, they can start to have pink frothy sputum, and this is one of those conditions where we say that it's a non-cardiogenic pulmonary edema, meaning that it looks like acute pulmonary edema that you would see in someone with CHF, for example, but if you do a chest x-ray, their heart size is normal. There's nothing wrong with their heart. This is all about capillary leak in the pulmonary system. So this is a normal heart size on chest x-ray with pulmonary edema. And again, descent is really the answer and temporizing until you can do that. Now let's transition into hypothermia. We'll talk about hypo and hyperthermia. Hypothermia is technically when your core temp drops below 35, but we know you don't have to be in a cold, freezing temperature to get clinically significant hypothermia. I live in Los Angeles. We see hypothermia a lot. We call that kind of urban hypothermia. And this is people who are outside, people who are exposed. It doesn't have to be in freezing temperatures. They just aren't responding necessarily to their body's signal to tell them to get somewhere warm, and sometimes they just can't. What's important about hypothermia is that some of our standard thermometers that we use do have a lower limit where they can't go below. And so using an accurate thermometer that can go lower than normal is important. And typically, when we think we're dealing with a case of really significant hypothermia, we're using a core temp, meaning that we're doing a bladder temp or a rectal temp in an ongoing way with a probe that's giving us an ongoing temperature. People who are at risk for this include people who are at the extremes of age, who can't respond to those types of signals that they're getting, people who are altered because of drugs, alcohol, etc. We can also see people who have hypoglycemia become hypothermic. We can even create iatrogenic hypothermia in trauma patients, for example, or burn patients, where we, in our own emergency department, are exposing their skin and they can't compensate. They can get hypothermic as well. We start to see different clinical signs in hypothermia. They can get altered, they can get quite bradycardic as their body adapts to this cold temperature. This is kind of a cool EKG finding. You won't always see this in hypothermia, but if you do get an EKG looking at that bradycardia that you're seeing on your monitor, you might see something like this. This is called an Osborne J wave, which you see right at the end of the QRS complex. Again, it's not of any really physiologic significance except that it's associated with hypothermia, and you may find it on your EKG, and you could be, oh yeah, that's an Osborne J wave, cool. Other cardiac rhythms that people who are hypothermic can get, they can go into a slow AFib, they can have junctional escape rhythms. There's a bunch of different cardiac phenomenon that you can see in a patient with hypothermia. The key here is to start warming people up, right? We need to start warming people up depending on what you have available to you. The first step is to get off any wet clothes, put on a warm blanket, but then we have active things that we can do. Things like a bear hugger, which is sort of a radiant way of passively giving warm air over the patient, using warmed IV fluids, using whatever you have in your department, even as far as going to very active rewarming, such as putting in an NG tube and doing warm lavages of the gastric area. We've even gone so far as putting in chest tubes with warm lavages of the central area. You can get pretty active with your rewarming depending on how sick the person is in front of you. So that's really active core rewarming, warm humidified oxygen, all those things. Now, patients who are at hypothermia for a long time can have frostbite. And frostbite I think of as really burns. They're burns that are caused by cold exposure to the skin. But a lot of the pathophysiology and the way that you want to describe them is very similar to burns, in that you want to describe them as superficial or partial, deep thickness, etc. We'll go through some of that terminology. So those are kind of ways to describe it. You will see sometimes hemorrhagic blisters in frostbite. You can see it even all the way down to bone. And the thing about frostbite to know is that you really want to rapidly rewarm these things, but you don't want to do that until you're in a situation where there's no chance that it will refreeze. Because if you rapidly rewarm it, but then you have to go back out in the elements and it's going to have a chance of refreezing, you can do more damage that way. So the answer is to rapidly rewarm with warm circulating water, but in a circumstance where there's no chance of refreezing. In general, we leave these hemorrhagic blisters alone. When it comes to burns and blisters, there's a little bit of controversy about what to do, but in this particular circumstance, we tend to leave them alone. The skin is a nice natural covering for what's going on underneath, and by debriding them, you can often, expose this now, wet, vulnerable skin to the outside world. So in general, we leave those alone. Now let's talk about heat illness. Heat illness is another spectrum of disease, everything from sort of mild heat symptoms to heat stroke, which we'll talk about. And there's really kind of two major groups that are at risk for this. We know about old people who are stuck in apartments in hot, there's a little hot spell and an urban setting, they don't have access to air conditioning, etc. That's one kind of group that can classically get heat sickness. The other group is, the young person who's out doing excessive exercise, who causes exertional heat symptoms to themselves. Those are kind of the two classic groups that we talk about heat illness in. But there are, of course, the people, again, at extremes of age who are on certain types of medications that can put them at risk for this, that can also be at risk for these types of things. And we've mentioned that lack of air conditioning as one risk factor as well. But it can happen, again, it doesn't have to be that hot outside to have someone come in with a heat illness. It can happen in ambient temperatures as well. So as we walk through the spectrum of disease, we see patients complaining of some puffiness, a little bit of heat edema. Again, just leave it alone. You don't want to treat someone like that with a diuretic. It'll resolve as they cool down and things sort of normalize. People who have heat cramps after they're exerting themselves in hot climates, again, generally will just go away with some good hydration, electrolyte hydration. You got heat syncope, where people get pooling of their blood in their extremities, and lie down in a cool place, things will resolve, maybe fluids if you have them, that kind of thing. And then heat exhaustion, which is more like a flu-like thing where people are generally feeling unwell. Again, hydration, rest, it'll go away. Make sure you're checking the electrolytes, no hypoglycemia, those basic things. When you use the word heat stroke, what you really want to be meaning is that person has altered mental status, that you are now seeing like true end organ damage. That's where medically the word heat stroke should be used and reserved for that situation where you really have altered mental status. And this means this is an emergency. I now have someone who has true end organ damage. I have to cool them emergently. That is a whole different beast than all these other little heat things, right? So not only when you see altered mental status should you be worried about their brain, but at that point you're thinking, okay, not only is the brain probably involved, but probably the liver, other end organs that I can't see the manifestations of externally. This often happens when core temps exceed 40 degrees centigrade or 104, and they will, their vital signs will be variable, but typically they'll have tachycardia and tachypnea. They could even be hypotensive. And as we check their labs and start to explore their metabolic abnormalities, we will see that they're acidotic. We're going to check a CK, looking for rhabdomyolysis as their muscles start to melt. That's what I think. I think of everything melting inside. The brain starts to melt, the liver starts to melt. You'll see elevations of LFTs. You'll see hyperkalemia as a result of kind of this metabolic dysregulation. And so these are the things that I'm looking for on my labs that I know are life-threatening. We mentioned that there are two kind of groups that get heat stroke or heat illnesses. There's the classic, as mentioned, and the exertional. And so looking through kind of the difference between these two, on the classic side, the old person sitting in the apartment with no air conditioning, this is a non-exertional type of heat illness. Often they are dry and dehydrated when you see them. And it turns out that when you check their labs, it's rare to see ATN or renal failure and rhabdomyolysis. Versus the other side, the military recruit who's been exerting themselves outside, they're very healthy, they're active, they will often be profusely sweating as their body is trying to compensate. They may even have diarrhea as well, and they are the ones that are really at risk for going into DIC and ATN and renal failure and rhabdo and that kind of thing. So these are kind of two classic types of heat illnesses. So we really want to cool them. It is an emergency. We talk about changing kind of the ABCs to the CABCs and throwing cooling up front there because we want to get this going. We're resuscitating, we're giving fluids, we're cooling simultaneously. How you do that is up to you. I think there's many ways to do it. You can mist them and put fans on them for evaporative cooling. You can get a body bag and put ice in it and put the patient in that to really cool them down as well. Depends on how sick they are, depends on what your resources are, but those are some popular ways to do it. They will start to shiver, and that's a normal physiologic response. You may want to use a drug like chlorpromazine or benzos to kind of control that shivering. And we want to start dropping their temperature, but we don't want to overshoot. So we typically recommend to stop that active cooling when you hit around 101 degrees Fahrenheit, to kind of stop there, because if you wait till you get to normothermia, you will end up overshooting because they are still cooling as this is going on. So you want to stop about that point. You don't want to overshoot. Let's talk about burns for a moment. I think this, especially if you don't work in a place with a burn center, which is most places, this is a common question that comes up about when do I transfer, et cetera. I happen to work at a burn center, so we do see a lot of transfers for burns. And I'll tell you that where I work, the burn surgeons are very, very honest about the fact that, if you're worried about this person, it is okay to call us. Call us, get advice, transfer. We're happy to see them. And we do get a lot of referrals for patients with burns. When we look at patients with burns, we have to classify their burns, right? We want to talk about what's first. We classically describe it as first degree, second degree, but really those things reflect different levels of the dermis. Where is the burn? At what level of the dermis am I seeing the burn? So, you start with your superficial burn, which is really like a sunburn, we'd say, right? That's just the superficial layer of the epidermis. It can be very painful, it can be very hypersensitive, but that's going to get better. It's not going to scar. We can use NSAIDs, et cetera. And then we start to move down to a superficial superficial, partial thickness burn. And this will look like a little deeper than a sunburn. It's painful, it's red. You may see some thin-walled, a little bit of blistering happening at this level. In general, these also tend to heal a little bit longer period of time, more 1 to 2 weeks, but they typically won't have scarring. And as we start to move lower, that's when we're starting to talk about scarring and more permanent effects. So as we get a little bit lower, now our burn's going to look a little bit, it's very painful still. It could be red. We might see some areas that are white. We might see a little bit of mottling going on here as well. The blisters will look a little bit thicker in terms of their wall thickness. They may have a little bit of decreased sensation, and this is an area that might require grafting and is going to take weeks to months to heal. And that's because we're getting down into the neurovascular layers of that skin. So now we're really threatening the viability of the skin that's overlying it. And once we get down to full thickness, now often these are actually painless because we've burned all the way through their nerves that feed that part of the skin. And these are obviously going to need grafts, and they're going to often look very dry because there's really no vascular input anymore to this area. I will say that burn patients are some of the patients that, for me, are the hardest to take care of because of my compassion for them. You see a patient with bad burns, someone who's coming out of some kind of terrible motor vehicle accident and has lots of burns, and you just know that they have a very rocky road in front of them in terms of survival in general, and also just the amount of surgeries and cosmetics and things that they're going to go through. It's really a patient that you want to understand what that next part of their road looks like, that it's going to be, you need to do aggressive analgesia and prepare for the worst, especially when it's an older patient. There can be pretty poor prognostic signs associated with this. Now, how do we estimate burned body surface area? And this is important to do when you're communicating with a burn center, you're going to transfer a patient, they often want to know this number. And so you want to give an estimate of their body surface area burned. And you want to include the first degree burns, like just the areas that are red you don't count. You're talking about really second degree or deeper thickness burns and above, which really, really matter. And so you can look at charts like these. These are easy to pull up, on the internet and look at. In general, we use the rule of nines, which is just sort of generally chunking the body surface areas into things that are divided by 9, and you can see the chart here. The other way to do it is that a patient's palm is approximately 1% of their body surface area. So you can kind of estimate looking at that in terms of a gross estimate of what percent body surface area is burned. For kids, we have a different estimation because they have big heads and different proportions of their limbs, so their rule of nines looks a little bit different. So this is not something I think to memorize. I think you know it, but you can always look this up if you're wondering. For kids, they use a Lund-Browder chart, which is divided into infants and more older children, depending on their proportions, and they give you the estimates here. So knowing, okay, there's a special chart for kids I got to look up, that'll help me know how to estimate the body surface area. For minor burns, these are the common things that we see that we ambulatorily treat and discharge, et cetera. And if it's somewhere that it's in a very functional area, this might be something that you refer to a burn center for follow-up. Things like facial burns, perineal burns, things that are circumferential around joints. These are all things that are not going to heal very well and should generally be referred to a burn center. But in terms of minor burns, what are the kind of the first aid things? You cool it right away. You're going to treat their pain because they'll be very painful. The blister thing I mentioned is a little bit controversial. In general, we can argue about whether you rupture the blisters, don't rupture the blisters. If it's in an area over a joint where there's a blister there and you know that it's probably going to rupture, people would argue better to debride those in more of a sterile condition and get them set up with the right covering rather than let them go. And you can go back and forth about that. Updating tetanus is important, and what you use on top of the burn is often a point of discussion. It is true that traditional Silvadene has kind of fallen out of favor. It's not contraindicated. It's often what people have, and it's still okay. The reason that Silvadene's kind of fallen out of favor is because there is some silver staining that can occur, particularly when you use it in areas that are exposed. So some people don't prefer to use Silvadene anymore. They use other types of things. But it's okay. It's not like you have to throw it out. But sometimes that's what people have, and there's a controversy about that. Okay, so for major burns, we want to cool them down. We want to watch for hypothermia. We want to definitely think about airway. And when you're working outside of a burn center type of area, you want to think about, if I have to transfer this person, do I need to take their airway? And it is a very important consideration. We know that patients who have had major burns need lots of fluids. And as we administer those fluids aggressively, they're going to start puffing up. They're going to start getting edematous, and that is definitely the case. So we want to think about airway management early. We do not want this person to suffer an airway death in transport to a different location. So you want to assess their airway and think about how long it's going to be before they get somewhere. In terms of airway burns, there are things to look for here. You can look for singe hairs, you can look for oral burns, and this is a little bit controversial because a lot of people, if they've suffered some kind of a flash burn, like it was a really quick flame and then it went away, they often may have singed hairs, but they don't have necessarily oral burns inside. So ideally, you want to look in there with a flexible scope to see if they actually have airway burns or edema. But if you're not in that situation, you don't have that equipment, it's better to overcall it and protect an airway than to make a mistake with the airway. So people would generally advocate for early intubation in these cases before you lose an airway you can't get back. If someone was in some kind of a fire with an enclosed space, we also want to think about the toxins they may have been exposed to. Carbon monoxide, cyanide toxicity are the toxicologic things that we're thinking about in addition to managing their burns. Fluid resuscitation is key, and the Parkland formula is kind of the standard one that we use, but there are others out there. The bottom line being that we want to be aggressive with fluids and we want to titrate to a good urine output. And the reason for this is that you've lost the skin barrier, which obviously is going to affect your fluid regulation. They're also going to be faced sometimes with rhabdo and be faced with renal complications of their body processing what's going on, and so flushing all of those toxins out is important as well. So the urine output is really what we're shooting for here, and I offer you the Parkland formula here as well, which depends on their weight and their percent body surface area that's burned. So most minor burns that we see, we can dispo ourselves and treat as outpatients. They don't need to be referred to any specialist. But if it's a major burn, obviously that's getting transferred. And then there's some other little things here that I've mentioned already, which is circumferential burns, things that are on areas that aren't going to heal very well. Inhalation injuries would be something to transfer. Electrical burns, those are usually deeper than you think. That would be something to transfer. And then depending kind of on how much body surface area is there, you can consult with your burn center to see if that's something that they think should be transferred or not. Now let's talk a minute about electrical injuries. We see people come in with these as well, and certainly as an electrical current enters the body, we get tissue damage. That's what happens. Along with that electrical injury that occurs, often there is trauma associated with it. So classically, you've got someone up on a ladder, they have some kind of shock happen to them, they fall off the ladder. Now you're dealing with not only a patient with an electrical exposure, but also a trauma patient as well. So those two things are kind of being considered side by side. Alternating current is actually worse than direct current. And the reason is because alternating current, often the patient can't let go of that source, and so they're stuck to it longer, getting a longer exposure. But direct current is usually higher voltage and will also cause its own damage. So the degree of injury we see depends on sort of the type of current they had, how long they were in contact with it, and which tissue was actually in the path of the exposure. The biggest risk of death in these scenarios is a cardiac arrhythmia that happens at the moment, or also the trauma, as mentioned, that can be associated with it. Those are the things that kill people. The other little caveat to know here that we sometimes see is a kid who went chewing on some kind of electrical cord and gets burned in the corner of their mouth, as this picture here. And the reason this is a unique injury to know about is that it often bleeds up front. There's an artery that goes to this area, and so you stop the bleeding. But as that kid over the next week is healing and that scab is retracting and coming in, they can have a major rebleed happen later down the line. So these are patients that we recommend typically to refer to plastic surgery for repair of this. When we see a patient who's had an electrical injury, we want to evaluate for where the injury, the path of the injury itself. So look for the entry point, the exit point. We want to resuscitate them. We want to think about our ABCs, thinking about that trauma workup if pertaining to that. But if somebody's had some kind of household exposure with some kind of low voltage thing, in general, those are not patients that need to be admitted for telemetry modeling, monitoring, et cetera. You can get your EKG, but if they look pretty good, the EKG looks good, they do not need to be admitted admitted for extended observation, which is one thing that some people will do, and it's really not borne out in the literature that you ever actually find any kind of later arrhythmia that happens. But if it's more than any kind of minor, household electrical shock, that's a patient I would do a little more for. Those are patients I'm going to send a CBC and an electrolyte panel and a CK, looking at that rhabdo factor, looking at their coags, and that's someone I'm going to admit for more monitoring. So looking at that urine output and admitting them to a cardiac monitored bed if it's more than just a household type of exposure. Okay, what about mammalian bites? We see lots of people that have been bit by dogs and all kinds of animals come to our department. What are the things to know about that? Well, we know that the human bite is the worst mammal to bite. Our mouths are dirtier than any other creature, so that's the most worrisome type of bite. And that pertains to people who have fight bites, right? You punch somebody, you get a wound over your MCP joint, and you see that patient and they tell you that it was just them punching a wall, and you have to say, is there any chance that any human saliva could have contact with this wound? I'm not accusing you of anything, but is there any chance, because it would really change my management? And sometimes you can get a more honest answer. Okay, well, there's a chance. Okay, great. Now let's go down that path. That's something that needs to be irrigated and antibiotics, and you need a consult on that because those are at high likelihood of leading to a hand infection. Dog bites, these are a little bit lower in terms of infection rate, but they have more of a crush injury component that we want to consider. And often, getting an x-ray and thinking about a crush injury is important in these cases, depending on the type of bite that happened. Cats are particularly nasty. They cause a puncture wound, which gets those organisms down a little deeper. And the truth is that most people who've had these types of bites, they don't come to the ER. But if they come to the ER, you have to think this is a little different than the average bite. And so when you look at studies, those types of bites have higher infection rate, cat bites. But those are of the people who come to the ER. That's not like all cat bites that happen in nature. So you'll often hear that statistic, but really it's a selection bias type of number. The way I remember this is that if I see a bite and I need to cover it with antibiotics, I use Dogmentin, which is amoxiclavulanate, which is Augmentin. Dogmentin. Use Dogmentin for animal bites. That'll help you remember what coverage to give them. Now, what about rabies coverage? Now, rabies is actually very rare in the United States. When you see a case report of rabies, it often makes the news. It is not common. Most cases of rabies happen when somebody is traveling overseas somewhere else. They've been bit by an animal in Thailand, somewhere else. That person is at risk for rabies, and that is like an immediate trip ender kind of thing. So we know that there are certain animals in our country that do actually have a risk of rabies. The bites that will put people at risk are things like foxes, skunks, raccoons, and the highest one is bats. That's the most common risk animal. Typically, things like a rat bite, that they come in, I got bit by a rat, that's not going to cause rabies. And, rodents in general, it's not going to cause rabies. And the lagomorphs, the rabbits, that doesn't cause rabies either. And, sometimes it's hard to remember these things. The CDC has really nice a website to go over these things. So does usually your local public health department as well. But anytime someone's around a bat, and this is kind of the classic test question, that there's, a baby in a crib and there was a bat found in the room, presume that there was some kind of exposure. Rabies is a fatal disease that we do not have a cure for, so we want to offer prophylaxis when we think there's a significant risk. Early post-exposure prophylaxis is key for the right cases. And we have here sort of what you do in terms of giving immune globulin and the vaccine. And it is true now that you do have to give 4 doses of the vaccine, but it's not long needles that go into the stomach and all the things that patient thinks is associated with rabies shots. It's not that bad. So they have to get one at day 0, and then they come back a few other times to get those subsequent vaccinations. What about general bites and stings that we see? We do see people who come in with these things. Most of these don't come to the ER. But often you might see someone who is stung by something, and they've got this big red wheal, and they're wondering if it's infected. And I think what we need to know is that there is a percentage of people who will have a hypersensitivity reaction to that type of bite. It doesn't mean it's cellulitis. It means that it's more of a hypersensitivity. So the questions to ask are kind of like the timing from the bite. If I'm talking 5 days later, then maybe that's cellulitis. But if they just got stung and it's like within 24, 48 hours, usually that's a hypersensitivity reaction and not cellulitis. And so I don't always just throw antibiotics at those things, but more like let's put some ice on it, do some over-the-counter pain meds and see what happens. There are a couple spider bites to be aware of. These are not that common, but they're out there. Most people who come to the ED with a complaint of spider bites don't have a spider bite, right? They have an MRSA abscess. It's not a spider bite. But you do see spider bites. It can happen. So know a little bit about them. There's black widow spider bites. There's brown recluse spider bites. They look different. Often they can describe the spider. That might be helpful. People who are bit by black widows tend to have immediate pain versus someone who's bit by a brown recluse. That's more of a delayed pain. Doesn't happen right away. So that's an important clinical difference there. And so these are things that we usually treat supportively. There is a antivenom that's out there for black widow spider bites, but in general, it's not recommended to use it. It has more side effects associated with it and risk of anaphylaxis and such that really don't make it worth it in the risk-benefit equation. In terms of black widow spider bites, besides the local sting, you can also get some abdominal pain. This is on the list of things that can mimic appendicitis, in fact, and so you can get some unusual symptoms with that. But we can treat with ice and benzos and supportive care. And brown recluses, they do get this delayed pain, and they can have some interesting skin findings as well, but usually these are locally treated, debridement, et cetera, if they need that. And then rattlesnake bites, we could have a whole talk about snake bites, so there's no way we can get into it in depth, except to know some of the basic things about rattlesnakes. And especially if you live in areas where this is a possibility, you probably already know these types of things. But most of the crotalids, which is the rattlesnakes that are the most common in our country, and there are coral snakes and other types of snakes as well, these are things that often it's good to call a toxicologist to get some help with managing these things if you don't see them that often. These will swell up, they have local effects, lots of swelling. Often it will look like a compartment syndrome, and the answer is antivenom. Antivenom, antivenom, antivenom. That is what you want to give patients when they have a significant snake bite to prevent these kind of complications that go on. The other thing to know is that if someone gets bit out there in the wild, you want to splint that in place and elevate. You don't want to tourniquet it. You don't want to suck the venom out, all of those sort of other myths that are out there. You want to immobilize the extremity and get them to definitive medical care. And antivenom is the answer. Thank you for your attention, appreciate it, and Jesse's up next.
All right, we're going to talk today about acute coronary syndrome, the essentials, just the essentials. Going to try and make this super high yield for you, the things that you need to know when you're seeing a patient with chest pain who you suspect of having acute coronary syndrome. Whose chief complaint of chest pain is favorite? Whose favorite chief complaint is chest pain? Anyone? Anyone? It's mine. I love it. It's my favorite chief complaint because it's like pretty algorithmic. For the most part, we have a good sense of what we're going to do with these patients. We have a pretty good sense of whether or not these patients need to come in or if we can do some troponin work and then discharge them. So I like this chief complaint, but it's kind of a mixed bag because on the one hand, you've got this great algorithm, and then on the other hand, you also have to read and interpret EKGs, which is hard. It's challenging, and it is a lifelong learning. So for anyone who feels slightly insecure or very insecure about reading EKGs, you're not alone. This is a feeling that seasoned attendings have, and it's something I'm always learning more about EKGs. They always make us uncomfortable, and generally no two are alike. So I'm going to try and break down some concepts for you and make it a little bit easier. So when we're talking about acute coronary syndrome, what are our goals in evaluating patients who have possible ACS, acute coronary syndrome? The number one thing is to grab an EKG, and you ideally want to do that within 10 minutes. Why? Because you're trying to figure out which of these patients have an ST elevation MI, a STEMI, the big daddy, the one that needs to go straight to the cath lab and be intervened on. So if someone comes in and they have chest pain, grab an EKG quickly, and importantly, make sure that somebody looks at that, because there are always these stories where the patient gets triaged as chest pain triage, they quickly get an EKG, and then maybe a tech leaves the EKG just on the table for someone to read, but no one's around, and then someone comes back and picks up that EKG and is like, oh my gosh, this is a STEMI, where's this patient, when was this done, how long has this person been here? So make sure that when that EKG gets ordered that it's also quickly read. And what we're really trying to do is identify those patients who would benefit from emergent reperfusion, as well as initiate medical therapy for patients who have ischemia. We want to address these patients early. The other thing that we're trying to do in patients who have chest pain is sort of risk stratify them. Is this low risk and potentially someone who can go home, or is this a high risk person who, regardless of what we find, is going to be coming in because they have so many risk factors? Now, the objectives today is to identify STEMI, so we're going to talk about STEMIs, and we're going to talk about STEMI equivalents on the EKG. So we're going to go through some EKGs, like your must-know, need-to-know EKGs. We're going to talk about the medical management of ACS, which has changed over time. And then again, we're going to review the risk stratification and risk assessment, and that's using things like the HEART score, which you may have heard of and perhaps use. This is, in my opinion, a very intimidating slide. I had to sit and look at this thing for a long time. So let's try and break it down. In the top left corner there, you've got a normal EKG, just sort of your P, your QRS, your T, and a quick reminder of what that is. So P is the P wave is your atrial depolarization. The QRS complex is your ventricular depolarization, and then your T wave is ventricular repolarization. And that correlates nicely with the picture just below it. It's the electrical direction of movement in the heart. The electrical conductivity of the heart is being reflected there. So everything starts in that top corner of the heart, in the SA node, the top right atria. It moves down to the AV node. It goes down the bundle of His and into the His-Purkinje system and depolarizes the ventricles. So that's what that picture is showing you. And when we're looking at an EKG, we're just looking at a map. We are looking at a map of the electrical conduction of the heart. And it just takes a little bit of time to figure out how to read those maps. So if we slide over to the right here, there you can see this very sort of busy, flowy, colorful slide. And what is that? That is an EKG showing us what parts of the EKG correlate with certain blood supply of the heart. So a lot of times we break down EKGs by the parts of the heart. That's that's showing us ischemia in the inferior leads. That's showing us ischemia in the lateral leads, in the anterior leads. Why does that matter? Because knowing what parts of the EKG correlate with what parts of the heart is key in identifying what blood supply is affected. So there in green, you can see the left anterior descending. That is the coronary artery that is supplying blood, generally in the anterior septal leads, V1, 2, 3, and 4. And then in blue, the LCX, that's your left circumflex. That's usually your lateral leads, blood supply to the lateral leads there. And then inferior, in red, the RCA. That's your right coronary artery supplying blood inferiorly to the heart. Now, if you look up at those drawings of the heart, you can again see how the leads correspond to the location of the heart. Inferior, septal between the ventricles, anterior, and lateral. So that's just sort of a quick breakdown. Definitely spend some time looking at that slide. Okay, a few definitions. What are we actually talking about when we talk about ACS? Well, what the heck is it? It is unstable angina, NSTEMI, and STEMI. That is the definition of acute coronary syndrome, those three entities. So what are those entities? STEMI, again, that is the big daddy. That is the ST elevation MI on your EKG, and you have troponin elevation. And this generally suggests that there is full wall thickness of the heart involved. And these people need to go to the cath lab. NSTEMI, the sort of less severe. So this is someone who has symptoms that are very suggestive of ischemia. Geez, every time I go up my stairs, I get chest pressure, I feel short of breath, I get sweaty, and then I sit down, I rest, I feel better. Or I take a nitro, I feel better. That's a very concerning symptom. And they have troponin elevation. What they don't have is ST elevation on the EKG. So they have the troponin, they have the story, but the EKG may look normal, or it may just have some signs of ischemia. It just does not have elevation. That is your NSTEMI. And it can mean lots of different things, but generally we kind of think about it as perhaps there's a partial wall thickness involvement. That's a bit nuanced. Now, unstable angina, what is that? Well, first we've got to define angina. So angina is when you're getting chest pain with exertion. Just like I said, every time I go up the stairs, I get chest pain. That's normal for me. Every single time. I've had that for a long time. That's my angina. But now it's changed. It's different. It's different. I'm getting it more frequently. And in fact, I'm getting it at rest. So now all I have to do to get chest pain is just be sitting. Or, you know, I only used to get chest pain when I would walk a mile. Now I walk, you know, a half a mile and I immediately get chest pain. It's changed, it's different, it's more frequent. That is unstable angina. And importantly, these patients do not have a troponin elevation. So the clinical presentation of acute coronary syndrome, well, unfortunately, no one follows the textbook. So it can come in looking like a lot of different things. And we know that. We know to really anticipate and search out those people who might have a rise in their troponin or kind of masking symptoms of acute coronary syndrome. We know that. But what are some of the historical factors that are really strongly associated with this? Exertional discomfort, we talked about that, going up the stairs, going for a walk, and I really try to elicit this from my patients because I think one thing that's common, it never fails, like, well, you know, someone comes in with chest pain, and you say, well, what were you doing when this pain came on? And a lot of times, the patient says, I was just sitting there. Like, I get that all the time, I was just sitting there. But if you kind of elicit a little bit more of the story and say, okay, well, do you have stairs in your house? Yeah, I have stairs. Okay, well, when you've been going up and down the stairs over the past couple days or weeks, have you noticed that that's harder for you, or does that bring on your chest pain? Yeah, now that you mention it, yeah, I have been getting chest pain with that. So you do kind of have to ask about that exertional component. Diaphoresis. Diaphoresis is always bad. I think many of us are taught that. It is always bad if someone is sitting there and sweaty. Radiation of the pain to the arms, the neck, the jaw. Classically, we're taught, and I think patients come in thinking, well, I have radiation of pain to my left arm, it's got to be ACS. But actually, it can be radiation of pain anywhere. It doesn't matter if it's the left arm, the right arm, the jaw, radiation of pain is bad. Vomiting is definitely a concerning symptom. And a lot of times my residents will sometimes say, oh, you know, they're having some stomach discomfort, they're vomiting, I think this is a GI thing. But don't be fooled by that, of course, because that can be the heart. And epigastric discomfort and vomiting can be a sign of acute coronary syndrome. And then the other big factor that I like to think about is if someone says, you know what, this pain is exactly the same as the last time I had a heart attack. I'm like, wow, thank you, that was amazing, you know? That's really helpful because that is also a really strong risk factor. If it's similar to their past pain with MIs or anytime they've had a heart event. Other common descriptions, so it's substernal chest pressure, it's squeezing, it's tightness. And some people don't describe this as pain at all. You might also have to elicit that. You'll say, have you been having chest pain? No, I haven't really been having chest pain. Okay, well, are you having any chest discomfort, any heaviness, any tightness? Well, yeah, now that you mention it, it is a little uncomfortable, especially people who are really stoic. They often don't describe it as pain. It's just a pressure and a discomfort. Heartburn. People who come in with that epigastric discomfort or heartburn, it's heartburn, I think it's just heartburn, it's something I ate. Anyone who minimizes symptoms, I'm immediately worried about. And definitely with heartburn, you should be considering ACS. Sure, maybe they have a gallbladder problem, but we gotta take the heart off the table. Anyone with jaw or arm pain, shortness of breath, pallor, you know, if they just don't look good, they're kind of pale and they don't look so hot. And then fatigue, especially elderly patients. They'll just be like, you know, I'm just getting tired more. I just feel more tired. That can be concerning, and sometimes they have an NSTEMI. And a lot of these people will not have symptoms when they come to the emergency department, importantly. So they may be asymptomatic, and you just need to find out what happened before they got there. Okay, let's talk about STEMI. So again, this is on the EKG, and this is new ST elevation, and if you read this slide here, it says measured at the J point relative to the PQ junction. That's a little confusing. Basically, what I like to say, it's just the ST is elevated above baseline. So if you're looking at it, you're following the baseline, you can kind of see where it's going. Big ST elevation, ST elevation. There, yes, this is the formal definition, but you'll know it when you see it. And it needs to be in 2 contiguous leads. Well, that's not talking about on the EKG. That is talking about anatomically contiguous leads, which is why it's so important that you know what those leads on the EKG correspond to. What's inferior, what's lateral, what's anterior, and we're going to go through that. And then the other definition of STEMI is that it needs to be greater than 1 millimeter of elevation in those 2 or more contiguous leads, except there's one exception, and that's V2, V3, your anterior leads. You need a little bit higher. It needs to be greater than 2 millimeters in men, or greater than 2.5 millimeters in young men. And for women, it's greater than 1.5. So just think a little bit higher than a millimeter, greater than 1 little box on the EKG. Okay, so what's our initial assessment? IV, O2 monitor, a lot of people kind of know that term, sure. A chest x-ray, labs. What are we looking for on that chest x-ray? Pretty much any other reason that they have chest pain, or if they're having some sort of problem from the ACS. You know, people who come in with an MI, they may also develop CHF and be in acute heart failure and pulmonary edema. So usually you can see that just by looking at them, but the chest x-ray can be helpful. So you're looking for signs of fluid, you're looking for signs of a dissection, you're looking for perhaps a pneumothorax, maybe that's why they have chest pain. So some other reason that they might present with chest pain. You're gonna give them aspirin if their story is consistent with ACS. Now, the one warning sign here, I think we've all sort of, I know I've been burned on this, where an older patient comes in, they are complaining of chest pain, you think they have ACS, you give them an aspirin, and you find out later that they're having like a concomitant GI bleed. So watch out for that. If there's any concerns about bleeding, you're gonna wanna hold a little bit on the aspirin until you have some labs back perhaps. And you're giving them a full dose, and it needs to be chewed. And then, again, for STEMI, of course, those patients quickly need to go to the cath lab. We're calling cardiology, we're activating the cath lab and getting them there or giving them thrombolytics. So what is the medical management? Aspirin we talked about. Heparin, we're going to start a bolus and an infusion. Why? Because this helps to prevent thrombosis when they go to the cath lab. And then those P2Y12 inhibitors. Those are just helping to, antiplatelet agents, again, to help prevent thrombosis, and then plus or minus nitroglycerin to help treat pain. Now for a STEMI, you've all probably heard of dual antiplatelet therapy, and that can mean a couple different things. It can mean aspirin plus one of those P2Y12 inhibitors like your Plavix, or it can mean aspirin and a glycoprotein 2B3A inhibitor. I hate these names. It just means antiplatelets. So a lot of antiplatelet agents. Sometimes all 3 are given. This is a lot of times in conjunction with cardiology. Now, who's heard of Mona B? This was something that I was always taught in school. Okay, someone has acute coronary syndrome. The treatment is Mona B. Morphine, oxygen, nitroglycerin, aspirin, beta blocker. Well, sadly, we cannot use that anymore because most of the things on this list are not things that we're going to use to acutely treat people with acute coronary syndrome. So let's go through them. Morphine. Morphine has been shown to have problems with mortality, to increase mortality. Now, some studies do not show that, but some studies do show that it can lead to increased mortality. And so now the practice is that we are not initially giving morphine. It is not our first choice when a person comes in with chest pain. That being said, if the person has a STEMI and you've tried nitroglycerin and they have ongoing pain and they're going to the cath lab, yes, give them some morphine, give them some fentanyl. There's some concern that opioids may delay the GI uptake of antiplatelet agents and make them less effective. So there is some concern about that. And the other thing that some experts have talked about is that there may be concern that we're masking the symptoms of worsening pain. This is usually people who maybe they have an NSTEMI, so they are not going straight to the cath lab and we're kind of watching them, or maybe they have unstable angina, we're kind of watching them, and if they develop worsening chest pain, we want to be able to know about that so we can quickly get an EKG and see if they're developing a STEMI. But some people are worried if we give opiates, we're going to mask that pain. I personally would rather treat the pain, so it is my practice to just go ahead and treat the pain, but it's good for you to know about these concerns. What about oxygen? In the past, everyone got oxygen, and even now, a lot of times people come in and they have oxygen, and I'll, say, oh, why is that person on oxygen? Oh, it's just for their comfort, just for comfort. Actually, hyperoxia is harmful. And there's some studies that show, all these studies listed on this slide show that it can have really harmful effects. And in fact, the AVOID trial, which is at the bottom here, showed an increase in infarct size, arrhythmias, and recurrent MIs. So you only want to give oxygen to patients if they are truly hypoxic and truly need it. It should not for those patients who are, satting well. What about nitrates? Yeah, nitroglycerin is a great drug. It's wonderful for pulmonary edema, those hypertensive patients who have pulmonary edema, good for your hypertensive patients. It can help with chest pain. You can give it IV, you can give it sublingual. Watch out for the transdermal. We've all had those stories where the person is kind of persistently hypotensive and we're like, what is going on with this person? Why are they hypotensive? You kind of look under their gown and they still have that nitro paste on from EMS. And you're like, oh, okay, all right, and you've been giving them meds on top of that, and you got to kind of wipe that off. I think it's very hard to control the dosing of that nitro paste. So I always wipe that off when the patients come in, and then you can control the dosing of my sublingual or my IV nitroglycerin. And who are the patients we want to avoid nitroglycerin in? Patients who are receiving alteplase, so the people who are going to get that thrombolytic, because it can increase the metabolism of alteplase and make it less effective. And then, of course, people who are taking sildenafil or Viagra, because that can cause refractory hypotension. Okay, aspirin. Yes, patients are going to get aspirin, and we already talked about this. This has a wonderful mortality benefit with a number needed to treat of 42, but the one thing you want to watch out for is they're not having concomitant GI bleeding or bleeding of any kind. That is the one thing you need to keep in mind. What about beta blockers? These can be given within 24 hours if patients don't have a contraindication, something like CHF or low cardiac output, or if they're high risk for developing cardiogenic shock, or they're in a block. Those are all contraindications, but this is not something that I'm starting in the emergency department. I usually leave that for the inpatient team. What other additional therapies? We talked about heparin. You're going to give the bolus, you're going to give the infusion to any patient who's going for intervention. It helps to prevent thrombosis. It can act as a bridge to definitive therapy. So if patients have an NSTEMI though, let's say they're not going straight to the cath lab, should we start a heparin bolus? They've got a concerning story, they have a positive troponin, should we start heparin? Some people are going to say, absolutely, yes, you should. Other people will say, no, you shouldn't. You should talk to cardiology, in my opinion. It's a little bit different. Cardiologists may feel differently, so I always involve my cardiologist in that decision. And then statins. What about statins? Well, they, again, sort of like beta blockers, can be started within a 24-hour period. Let's talk about troponins. So troponin I and T are from the heart. They are from myocardial cells. But they don't leak strictly because of ischemia. There are a lot of reasons that you might see troponin elevation. So the other thing to know about troponins is that in the setting of ischemia, they're very predictable. So they don't rise immediately. If the person comes in and they said, my chest pain started 10 minutes ago, we're not going to expect to see a rise in that troponin. It takes about 3 to 6 hours to rise, and it peaks in about 12 to 24 hours, and then will normalize. So that's why we are trending the troponins. We want to see if they are following this sort of expected pattern. And remember that right away you won't get it. That's why we have to repeat our troponins. Some places have these ultra high sensitive troponins, this troponin 3s. Most people are using troponin 2s still, and just kind of check in with your institution to know how to interpret those and what your institution uses, because there are different cutoffs depending on your institution. These are all the different causes of troponin elevations that are not related to an MI, and there's a lot there. So just remember, you can get troponin elevation for other reasons. Okay, what about the treatment for STEMI? Well, time is heart. Just like in a stroke, time is brain. This is like a stroke of the heart, right? There's a clot in that artery cutting off blood supply to your heart. It is like a stroke of the heart. The clock is ticking. We need to try and preserve our heart muscle. So the goal is to get these patients to the cath lab for PCI, percutaneous cardiac intervention, within 90 minutes of arrival. And that is your door to balloon time, 90 minutes. And if you're at a non-PCI facility, you have 120 minutes. If you are at a place where you cannot get them to the cath lab and you're going to have to use thrombolytics, that's within 30 minutes of arrival. And that is your door to needle time. So who should go to the cath lab? Really, anyone who's coming in with concerning story, ongoing pain, has ST elevation on their EKG. And that's, you've got, within 12 hours, those patients come in, they've got pain, they have ST elevation on their EKG, they need to go straight to the cath lab. If it's been more than 12 hours, what we worry about is, maybe the heart they've already killed that part of the heart, it's done, the damage is done, there's nothing for us to intervene on. But if they have ongoing ischemia and ongoing symptoms, they should still go to the cath lab. What about NSTEMI patients? Any of those NSTEMI patients who are unstable, hypotension, shock, they're having arrhythmias, they need to go to the cath lab. And then NSTEMI patients who have refractory ischemia and ongoing symptoms and their EKG is dynamic, those people need to go to the cath lab. What about thrombolytics? Well, we just kind of talked about the timeline. If it's going to be greater than 90 to 120 minutes for that patient to get to PCI, then you're going to go ahead and think about thrombolytics. The symptoms need to be going for less than 12 hours or between 12 to 24 hours if the patient's unstable or there's a large part of the heart that may be involved. And if the EKG shows that this is acute, right? We're always comparing the EKG that we have with priors, if possible. Did this person have these findings on their EKG 3 months ago when they came in, or is this new? You always want to review the contraindications before you give thrombolytics. So our options include tenecteplase or alteplase. Tenecteplase is nice because it's simpler dosing. It's weight-based, single IV push over 5 seconds. There's no prolonged infusion. But make sure you review those contraindications, and I always look them up. There's a list, so make sure you look them up. And then after you've given thrombolytics, these patients still need to go to a PCI center. You're still going to transfer them because some of them still go to the cath lab. What about risk stratification? How do we risk stratify our patients who come in with chest pain? This is the heart score, and many of us use this. This is nice. It is great for patients who come in with chest pain and they have normal EKG, or maybe a non-specific EKG. What are we going to do with these people? So the heart score uses the history. What's the story? What kind of a story was it? Was it really convincing for ischemia? It looks at the EKG. Do they have any changes on their EKG? It thinks about risk factors. What are the risk factors that this patient has? Have they had a prior cardiac event? Do they have diabetes? Do they have high blood pressure? Are they a smoker? Is there family history? And then it also brings in the troponin. That all comes into play with the heart score. When you calculate it and the number comes out to less than 3, those patients are low risk for having a major cardiac event in the next 6 weeks. And you can consider discharging those patients after getting another troponin. The patients who have higher risk scores, you can admit those patients for observation, and then if they end up having a positive troponin, while you're watching them, those patients are certainly going to need cardiology consult. So what you want to do is really combine the heart score with a diagnostic pathway and kind of talk to your hospital about the way that you may approach risk stratification. But the heart score is a nice thing that you can document in your decision making, in your MDM, to say, this is why I chose to discharge this patient. They were low risk by heart score, it's an accepted, validated score, or this is why I chose to admit this patient, because they're high risk. This is just showing the sequence of an evolving MI. So you have a normal PQRS-T complex there, then you develop a hyperacute T wave. So this is very early. This is what you get before the ST elevation. And sometimes you will catch this. A person comes in, they have chest pain, you get an EKG, and you see these big T waves. Some of us rightly would be thinking, gosh, do they have hyperkalemia? You know, you're thinking about potassium, but also on your differential is, gosh, maybe they are developing STEMI. So what do? You get a repeat EKG 10 or 15 minutes later. At that point, you might see the ST elevation, and that person needs to go to the cath lab. After that, you'll see a Q wave. Then you can see ST elevation with T wave inversion, T wave recovery, and either the EKG will normalize. Some people go on to have sort of a persistent ST elevation, and that is your LV aneurysm. Let's keep going. So EKG leads and anatomic distribution. These are the leads and how they match up with the heart. And so you can see V2, V3, V4, that is anterior. Those are your anterior leads. Well, what about the lateral leads? V5, V6, 1, AVL, those are over there on the side. Those are all your lateral leads. And then down at the bottom, those inferior leads, 2, 3, AVF. This is how the leads correspond to the heart. This is the blood supply. The big one, now there's a lot of branches, but the big ones you really want to remember are your right coronary artery, your left anterior descending, and your left circumflex. And then there are branches off of those that are also important. This is the big money slide. So this is what you always want to remember. Commit this to memory. These are your contiguous leads. When we talk about ST elevation in 2 or more contiguous leads, that again corresponds to anatomy, and this is your anatomy slide. So 2, 3 AVF, that's the reflecting the inferior part of the heart. In green there, V2, V3, V4, that's your anterior leads reflecting the anterior part of the heart. And then 1 AVL, V5, V6, those are your lateral leads. You might say, hey, what about septal? What about septal? V1, V2. So anterior septal, you'll often hear that. This is a normal EKG, and the reason we have this is as we talk about the EKGs, you can go back and refer to this normal EKG. So first we're going to talk, we don't have much left, I'm going to do this quickly. We're going to quickly talk about an anterior MI EKG. Let's just review what this looks like. So V2, V3, V4, you guys can see this, that they are prominent, something's not right. This is ST elevation in the anterior leads. And you can see some reciprocal ST depression in 2, 3, and AVF, not necessarily on this EKG, but on other EKGs. Sometimes you have anterior septal, sometimes you have anterior lateral, so it can be a combination of things. And when you see this, it's not always in isolation. And so you also want to look at those lateral leads. How does 1 AVL, V5, V6 look? Lateral MI, remember this is your circumflex. This is a lateral MI, and where are we looking? ST elevation in the lateral leads. 1 AVL, V5, V6. I think on this EKG it's especially prominent in 1 and AVL. V5, V6 look big, but really 1 and AVL. And you can see reciprocal depression here in the inferior leads. So those are your deep ST depressions. What about an inferior MI? Remember, this is branches off your right coronary artery. This is my favorite. I feel like this one's easiest to see. 2, 3, and AVF have the ST elevation. You can see Q waves in 3 and AVF, and maybe reciprocal depression and T wave inversion in AVL. That's your inferior MI. What about a posterior MI? This is like the forgotten MI. It's missed. It is very often missed. So if you're looking at this, you might say, well, you know what I see here? I see ischemia in the anterior leads. This looks like anterior ischemia. There's ST depression in the anterior leads. You're right, that is what it looks like, but your mind should then immediately go to maybe this is a posterior MI. Because remember, those anterior leads that come out right here, if you have anterior leads, they're also picking up the back of the heart, the posterior part of the heart. And so that's what you're seeing. And basically, if you turn this upside down, it will look like ST elevation. The mirror image is ST elevation, and that is a posterior MI. Now, what are the big findings? A tall R wave in V1 and V2 greater than the S wave. Remember, normal EKG, tiny little R wave, V1, V2. It gets bigger as you continue going through V4, V5, V6. The R wave should get progressively bigger. So if you have a really big R wave in V1, V2, bigger than the S wave, you should be thinking, this could be a posterior MI with that ST depression in V1 through V4. And here you go, you flip it vertically and you have some ST elevation. You can also get a posterior EKG where you put leads on the back and pick up the posterior MI, V7, V8, V9, you'll see those there. Those are leads that go across the back, and you should see some ST elevation there. Gonna finish up STEMI equivalents. What are STEMI equivalents? Things you should worry about that aren't necessarily recognized as a STEMI. So posterior STEMI, hyperacute T waves. These are these really big T waves in V2, V3. Tall, prominent, symmetrical T waves in the precordial leads. And this can suggest LAD occlusion. The modified Scarbosa criteria suggests a STEMI in patients who have a known left bundle branch block. I always have to look up that Scarbosa criteria every single time, hard to keep straight. But if someone has a left bundle chest pain, you're going to look up the Scarbosa criteria. If they meet Scarbosa criteria, it's a STEMI equivalent. ST elevation in AVR with diffuse ST depressions. That can be ischemia or LAD occlusion. Really, the AHA only recognizes a true STEMI equivalent in the left bundle branch block with Scarbosa criteria. But we, as emergency clinicians, know to be aware of all these other concerning findings, and I'm going to get cardiology on the phone for those. Last slide. Big reminders. Young patients can have ACS. Just because they're young, don't take it off the table. If they get relief with a GI cocktail, it does not mean that they don't have ACS. Risk factors, yes, they are red flags, but lack of risk factors doesn't mean that they don't have ACS. And here are some of the acknowledged risk factors we talked about. So always have it on your differential. Thank you so much.
Okay, please don't run away. Just 2 quick announcements. We know that your time is valuable and we want you to be able to eat and take your relaxing break. So we're going to defer the Q&A for right now until this afternoon. We try to answer all the questions on the Slido so you can take a look, but we will integrate them all this evening. Then we'll announce our winner for the free advanced course at the live episode of The Two of You tonight, coming at you right here at 5:45. We have a really wonderful panel discussion. We're going to be talking a lot about prescriptive authority, prescribing to your friends and family, some rules with the DEA, some changes with prescribing certain medications, as well as interviewing some of our panel hosts, talking about some more topics in depth. So join us here if you want to stay for that. That's going to be at 5:45 tonight. And for now, take your lunch, come back at 1:30, and we'll start up again.
Hello, everyone. Welcome back from lunch. I'm Arthi. I'm coming in from Los Angeles from the LA County USC Medical Center, and I have the task of trying to capture your attention immediately post-lunch with this really exciting talk on knee disorders. So let's get started. This talk is going to cover not only anatomy of the knee, but also the approach to the exam of the knee. We'll spend a lot of time talking about can't miss diagnoses, but we'll also talk a little bit about non-emergent disease processes of the knee. And why is that? How many of you in this room get really jazzed to see a patient coming in with knee pain, especially knee pain with 2 months? Oh, I have one. Great. No one else. And so that's kind of how I felt, particularly early in my career. I felt dissatisfied with these encounters. I would see patients who had been waiting in the waiting room for 3 to 4 hours in my county hospital, maybe 16 hours, with subacute or chronic knee pain. And I do my history, I do my exam, maybe I do an x-ray out of pity, and I wouldn't find anything. And I'd say, you know, great news, you don't have a fracture, you don't have an infection, I have no idea what's going on, I'll send you back to your PMD, and I diagnose them with non-specific knee pain. And I think that left the patients and me feeling a little bit wanting. So as I've moved on in my career, I've started to learn a little bit more about these non-emergent disease processes and expanded my diagnostic vocabulary. And now I find that much more commonly, I can actually give the patients a name of their disease. Oh, you have patellofemoral syndrome, or you have Osgood-Schlatters disease. And not only that, but help to establish their expectations for what is to come and prevent a bounce back to the ED for persistence of that pain. So that's why we're going to talk about some of those disorders as well. So let's go over the knee anatomy, and I have to just break it to you, the knee is not a well-designed joint. The hip above it, that's a great joint. That's a ball and socket joint. It's built for stability, it's built for range of motion, it's built for weight bearing. The knee's just not that. It's the femur on top of the tibia. That's it. So it does flexion and extension quite well, but it's certainly not built for lateral movement. It's certainly not built for any sort of twisting. And so when you engage in any of those movements, you put all of the supporting knee structures at risk. So what are some of those structures? We have in the center of the knee the 2 cruciate ligaments, cruciate crossing the ACL and PCL. On the sides of the knee, you have your collateral ligaments, and in the middle of the knee, you have the meniscal cartilage that acts as a shock absorber for the knee. Above the knee, you have the quad muscles, behind the knee, the hamstrings, along the lateral aspect of the knee, that long IT band, and then sort of to add to the strangeness of the knee, you have a floating patellar bone that's hanging out in front of the knee, supported superiorly by the quad tendon and inferiorly by the patellar tendon. And all of these are just waiting to get injured if you do anything other than sort of gentle flexion and extension. Continuing on to be the bearer of bad news, x-rays of the knee are just not that helpful. It's the minority of cases in which a patient comes in with knee pain and I get an x-ray and I have my diagnosis. It just doesn't happen that much. They're pretty low yield. When you do get them, you get your AP view, you get your lateral view, some oblique views, but occasionally you might need a supplemental view. And one of the more common of these is the sunrise view. So what is the sunrise view and when do you get it? If you take a look at this AP view, you can see that the patella is completely hidden behind the femur. I can't make heads or tails of it. And then if you look in the lateral view, you just get a little sliver, a crescent of it. And so you really can't really evaluate for pathology of the patella. So the sunrise view is a dedicated view that I get specifically in patients that have fallen directly on the patella, that have pain specifically over the patella. So while x-rays are bad, the exam is a little bit better. Let's talk quickly about when to get an x-ray. Sorry, going back. And so we have this group out of Ottawa that has come up with a lot of clinical decision rules in many facets of emergency medicine, and the knee is no exception. And they've really tried to reduce the incidence of unnecessary knee imaging. So what they have told us is that a patient needs an x-ray if any of the following are met. They cannot bear weight after the injury and in your emergency department. They have tenderness at the head, the proximal part of the fibula. They have isolated tenderness over the patella, so that's not pain for the entire knee, but pain directly over the patella. They're unable to flex to 90 degrees, or they're older than 55 years old. And these rules have actually been validated down to the age of 5, so you can use these in your pediatric patients as well. Now moving on to the knee exam, here's a laundry list of maneuvers that you can do, and many of you have heard of. I would add to this list that I checked for laxity with both varus and valgus force, and I also recently have become a fan of the lever test. I'm not going to go through any of these tests specifically because I think they're best learned visually, so I'll direct you to this YouTube link at the bottom of the slide. But what I do want to leave you with is 2 key points. When you're doing exams of the knee, how many of you feel really good about determining if a knee feels lax? Oh, good, some of you. I still don't feel all that great about it, and so whenever I'm examining a knee, I'm always comparing it to the unaffected side, because I certainly can tell if what I'm examining feels different from the patient's baseline from the other knee, but I don't know myself that I can pick up laxity just by examining the unaffected knee alone. The other thing is that I really implore you to get these patients undressed and onto a gurney. All of us feel the pressure to see these patients in fast track, right? And I can't tell you how many times I've seen my residents examining a patient seated on a chair in jeans and trying to do a knee exam. It just doesn't work all that well. What you really need to do is get them onto a gurney. Ideally, you'll have the knee in gentle flexion by putting some towels underneath the knee that will help you to really elicit laxity. And then you can make out subtle changes in contours of the knee that was just an effusion, or you can tell if the knee is warm or is red in any way. So I would implore you to get these patients undressed. Let's move into actual knee pathology. So the first we're going to talk about are injuries to the cruciate ligaments, ACL really being the more common. I grew up playing soccer. I played soccer in college. I was surrounded by ACL injuries, and it got to the point where you'd see a teammate running somewhere, changing direction, and then collapse holding her knee, and you'd just sort of assume it was an ACL injury. And then you'd run over there, and she'd say, you know, I heard a pop, and that sort of clinched the diagnosis. So that is the mechanism of these injuries. This isn't so much a contact injury. This is a running, deceleration, change in movement, and there goes your ACL. Patients will often develop a knee effusion, a joint effusion, a few hours after the injury because that ACL is so vascular, so they'll develop hemarthrosis. And then when they come into your ED, they may actually be bearing weight. So if you see them bearing weight, don't let that throw you off this diagnosis. Many of them still can bear weight, but what they will complain is that, you know, every time I put weight on this leg, it feels like it's buckling. It feels like it's going to give way underneath me. That really clues me into the diagnosis. If they can tolerate the exam, which many of them can't because they have this big swollen knee, you can check for laxity. I've more recently moved over to the lever test because I find it doesn't require me to pull on the knee. So again, that's one that I recommend looking up. Generally, we send these patients out to be followed by an orthopedic surgeon and for an outpatient MRI. But what we used to do is throw all these patients arbitrarily into a knee immobilizer. And that's something that I'm definitely not doing anymore. I'm much more judicious with my use of the knee immobilizer because it's not without its harms. When you put someone in a knee immobilizer, it can lead to knee stiffness. It can quite rapidly lead to atrophy of the surrounding muscles, and in our older patients can precipitate falls. So what is the role of an x-ray here? We're frequently getting an x-ray. Most often it's negative. It just will show us a knee effusion. There are 2 things I want you to look for in x-ray that will highly suggest an ACL injury. The first of these is a second fracture. So that's a lateral avulsion of the tibia. And you may wonder, why is a lateral portion of the tibia being pulled off by a ligament that's in the center of the knee? Well, the truth is, the same mechanism that results in this avulsion fracture is the mechanism that results in the ACL injury. So they just have a similar mechanistic mechanism of injury. Doesn't really change the management all that much, but if I do see a second fracture, it pretty much tells me they have an ACL injury, and it helps me to tell them what to do afterward. The tibial spine fracture, now this directly has to do with the ACL. The ACL attaches inferiorly on the tibial spine, and as it's wrenched off, it pulls off a little portion of the tibial spine, and these patients I actually make non-weight bearing when they leave the ER. Mostly I send them out in an ACE bandage with crutches, and I send them to go get one of those hinged braces as an outpatient. While we're talking about internal derangement of the knee, we have to mention the terrible triad, that unhappy triad. And this occurs when the foot is planted and there is a lateral blow to the knee that causes sort of the medial side of the knee to explode. So that gets your ACL, that gets your MCL, and then either your medial or lateral meniscus. It's a relatively rare injury, but if you can imagine, the sports where this may occur are football, rugby, right? You have your leg planted and you're tackled right at the level of the knee. These are almost always surgical and need to be referred to an orthopedic surgeon. Again, reviewing the mechanism of injury, ACL injury is deceleration, change in movement, and this terrible triad is a planted foot with a lateral blow. Meniscal injuries are a little bit sneakier. We may miss these a lot. They're usually associated with twisting, but you don't get that big pop or big knee effusion. But what the patient may complain is that every time I'm trying to flex and extend my knee, it feels like something is catching or locking. And in some cases, they may actually develop something called a locked knee. And that occurs when a little piece of the cartilage has sort of flipped up and gotten caught in the knee joint that's not allowing them to fully extend the knee. All of these patients need outpatient ortho and MRI, but those patients with a locked knee need much sooner arthroscopy. And actually back in the day when surgeons would suspect that you had a meniscal injury, they'd just sort of take out the meniscus and say, great, you're healed, job well done. And then it turned out that all these patients developed arthritis, because you can imagine this would lead to bone on bone, so they're much more sophisticated in their repairs these days. The lateral collateral ligament and the medial collateral ligament, I won't spend a lot of time talking about. Generally, if I suspect an injury to the lateral collateral ligament, I will push that leg, the tibia, I'll push it immediately in varus stress and see if I elicit laxity laterally, and I will do the opposite to look for an MCL injury, but these are all outpatient orthopedic referrals and outpatient MRIs. Now let's talk about a series of can't miss diagnoses, and the first of these is the knee dislocation. And these are really, really important can't miss diagnoses, where none of us are going to miss the ones that come in and their tibia is here and their femur is here and they're very obviously dislocated. The unfortunate thing is that 50% of these are going to relocate before they get to your ED, and you do not want to miss a relocated dislocation. Why is that? They've already relocated, everything's fixed, right? The problem is that huge anterior-posterior movement that happens when these knees dislocate and relocate threatens the integrity of all of those structures running behind the knee, the most important of which is the popliteal artery. And so if you have injury to the popliteal artery, it can clot off and subsequently eventually lead to ischemia and amputation of that leg. So obviously we're not going to miss the ones that are still dislocated. How are we going to catch the ones that have relocated? And I'm going to give you a few pointers. One, this is a high impact injury. So the moment you have a high impact injury with a negative x-ray, your red flags and tickers should start going off. The second is that if a patient tells you that their knee was out of place and it went back into place, believe them. This could actually have happened, and then I would treat that as a reduced dislocation. The third is that when you're doing your exam and you're checking for laxity and you say, they're really lax anteriorly, they're lax posteriorly, oh, actually they're kind of lax laterally, there's bidirectional laxity, then that is very concerning for a knee that's been sort of ripped out of place and injured multiple ligaments and come back into place. And the last one you can do is to grab both the legs by the great toes, hold them up, hold the legs up by the great toes, and the one with the relocated knee dislocation is sort of going to hyperextend and hang in concavity compared to the unaffected knee. So if you have any one of those things, or you have a still dislocated knee, you need to assess the integrity of the popliteal artery, and feeling for pulses is not enough, and ABI truly is not enough. You really need to get a C2 angiogram of the knee. Patellar dislocations, on the other hand, we're not going to miss these. They usually come in still dislocated. Occasionally they will have relocated, but these are very far from those important structures at the back of the knee, so they're much less limb threatening. They're very, very fun to reduce. Usually when I see these encounters, the entire encounter is about 5 to 10 minutes, because you can do these reductions without any sort of sedation at all. And then they usually have been dislocated laterally. I have the patient slowly extend their knee, and as they're doing that, I push on the patella, and it sort of goes, and then plops right back into place. And this, for me, is one of the indications for sending someone out with a knee immobilizer so that they don't re-dislocate their patella. Femur fractures, we won't spend a lot of time talking about. If you have someone who has a femur fracture, there are two things you need to know. One is that's a really high impact injury, so if you have a femur fracture, look for other concurrent injuries. And the second is that people can dump a lot of blood into the femur, up to 3 liters, so do a really good job continuing to assess their compartments, assess their hemodynamics, and determine if they need transfusion of blood. But all of these are going to get admitted, so there's not a whole lot to spend time talking about. Tibial plateau fractures, on the other hand, those are a little bit trickier. none of us are going to miss the x-ray on the right? This is an obviously destroyed tibial plateau, but this x-ray is a little bit more challenging. Tibial plateau fractures are called fender fractures because they often happen when someone is crossing the street and then a car comes and hits them and the fender strikes them right at the level of the tibial plateau. And the reason that these are tricky is that some of them will have x-rays that look normal. So if I have a patient who has had a direct blow to the knee, they have a knee effusion, and I get a negative x-ray and I'm like, you know what, okay, time for you to go home, there's nothing here, and they can't bear weight, I stop, I undo that discharge, and I send them over for a CT. And I'm always shocked by how many of these patients have really, really obvious fractures on CT that were completely not evident at all on x-ray. Depending on the degree of displacement or depression, these will either be sort of emergent or urgent surgical interventions, so talk with your orthopedic colleagues about these. Osgood-Schlatters disease is one of these non-emergent diagnoses that I mentioned we were going to talk about, and this is entirely a clinical diagnosis. This is seen usually in our adolescent teen patients, the ones that are going through a growth spurt. I had this when I was younger, and what happens is the bones are growing rapidly, and the tendons are just not keeping pace. So the patellar tendon in particular, as the bones are growing, it's getting stretched and stretched and stretched, and it's attaching inferiorly at the tibial tuberosity, which is a weak growth plate. So as it's getting stretched and pulled, it's yanking at that growth plate and causing a lot of inflammation. The diagnosis, as I mentioned, is clinical. If the x-ray doesn't show anything, but you palpate at that tibial tuberosity and they have tenderness, you have made that diagnosis for that patient, and then the treatment is supportive care. While we're talking about pediatric patients, we can't skip talking about non-accidental trauma. We're always looking for this. The knee is no exception. So you can see on this x-ray you have corner fracture here at the femur, and then bucket handle fractures of both the tibia and the fibula. These are fractures of the metaphysis, and they are highly suspicious, if not almost pathognomonic, for child abuse. So I always, when I see these, I'm pretty much pursuing a full NAT workup and also involving CPS. All right, on the other end of the age spectrum is osteoarthritis. Certainly not the sexiest diagnosis we're going to make in the ER, but we're doing this a lot. I'm not going to spend a lot of time here, but the one thing I want to leave you with is that X-ray findings can be very discordant with the degree of osteoarthritis that a patient actually has. I can't tell you how many times I've seen a patient who's come in and they're the perfect candidate for osteoarthritis. They're maybe in their 60s or 70s, they're a little bit heftier, they played ice hockey or basketball growing up, they put a lot of wear and tear on the knee. Then I get an x-ray and it's normal. And I thought, okay, what am I missing? What else is going on? They could still have osteoarthritis. So if the clinical picture fits, don't let the x-rays dissuade you from this diagnosis. I still go through the, talking about weight loss and chronic pain meds being in the form of probably Tylenol or topical NSAIDs rather than oral NSAIDs, and advise them that, if this continues to progress and becomes excruciating, that potentially you can pursue a knee replacement. So while the osteoarthritis effusions are sort of indolent, they're not all that painful, this is very different from the effusion that you see in someone who's coming in with acute gout, right? So these are warm, tender knees, they're acutely painful, and they occur because there's been deposition of uric acid crystals within the joint. And that diagnosis is made through synovial fluid analysis by sticking a needle within the knee, pulling out some fluid, and sending it to the lab. Now the question is, who actually needs a knee tap? Which gouty patients need a knee tap? I would argue to you that if someone has an established diagnosis of gout and they come and they're like, doc, I messed up. I had a bunch of beers last night, or I had a big steak dinner, and I'm not supposed to because it's on this list of purine-rich foods, and I know that caused my flare, and this feels like all my other flares, and I'm getting better with NSAIDs. I usually don't tap those patients. I think about doing an arthrocentesis, one, if it's a new diagnosis, it's an acutely painful knee, and there's no history of crystal arthropathy, or if I'm concerned about a septic joint. If I am not, then the treatment is supportive. It's usually NSAIDs plus or minus colchicine. I find that patients really seem to love colchicine, even though toxicologists hate it. But if they have renal failure or some contraindication to these interventions, then you can consider a burst of steroids. Pseudo-gout is very similar. The only benefit is that these crystals are calcium-based. So you often can see deposition of crystals within the joint itself. The main difference is that these patients are traditionally older, and in contrast to gout, where every single time a person with gout will say, it's my big toe, my big toe, my big toe, or it's my knee, my knee, my knee, pseudo-gout can migrate, and so maybe one time it's your left knee, one time it's the right ankle, the next time it's the right knee. But the treatment is virtually the same. Now, this is a slide I dread. I hate to talk about septic arthritis, and the reason for that is because if you open any textbook or kind of blog post on septic arthritis, there's always going to be an asterisk and bolded statement that says there is no single exam finding or lab finding or synovial fluid finding or historical feature that can help you to rule out septic arthritis. So a patient doesn't have a fever, they could have septic arthritis. Patient can range their knee, they could have septic arthritis. They can have a low synovial fluid white count and still have septic arthritis. That's the scary thing. So I'm not going to spend a lot of time talking about the nuances of the test characteristics. You could probably spend 12 hours doing that. What I do want to do is empower you to advocate for your patients with ortho consultants if something just isn't sitting right with you. Maybe the patient has diabetes or a prosthetic knee, and the pain they have now is different from their usual gouty attacks, so their range of motion just still isn't getting better with NSAIDs. Even if you have a low synovial white count, even if you don't have a white count on your peripheral lab work, you must advocate for these patients because there's a really high morbidity and mortality for a missed septic joint, and these patients do need to go to the OR for a washout. One reason for a septic joint is a missed open knee. So an open knee occurs when there's been a laceration that's deep enough that it's penetrated into the knee joint itself. And I work at a trauma center, so I see a lot of patients who come in with trauma and with knee trauma, and usually they have a lot of dried blood on the knee. And I'm always really, I'm always on my residents to do a really good job of cleaning, because all of a sudden that dried blood turns into an abrasion, and then you clean a little bit further and it's a laceration, and then all of a sudden you realize you can't see the full extent of the laceration, and when you talk to the patient they say, oh yeah, I hit my knee on a screwdriver, I was stabbed with a steak knife, and now you're concerned about the depth of this injury and you have to rule out violation of the joint. So how do you do that? Well, if you've gotten an x-ray of the knee and you see air within the knee joint itself, you're done. But most of the times that's not the case. It's a lot more subtle than that. So what we used to do is we used to challenge these joints. We used to give the knees big saline loads where we'd stick a needle in the knee joint, we'd infuse it with sort of 150 cc's or so of fluid and see if any of that fluid leaked out that laceration that would suggest a connection between the two. But the problem with that is that it's incredibly painful, and everything that you put in you have to take out, and oftentimes you're not successful in getting all of that 150 cc's out, and now you've left the patient in more pain. So the simpler approach now, I think we're finding that CTs are quite effective in ruling out open joints, and not only that, but you can evaluate for other occult pathology like a tibial plateau fracture. So I pretty much exclusively CT these. Patellofemoral syndrome, we're back into these non-emergent disease processes. Patellofemoral syndrome is one of them. So the patella runs up and down this groove in the femur, and usually you have no problem at all, but as that happens over time, you have loss of cartilage underneath the patella to the point where eventually you'll have bone on bone, where the patella is just riding right on the femur. And these patients are going to complain of pain mostly when they're in the flexed position, and what they will tell you is every single time I go up and down stairs or I sit for a long time, maybe cross-country flight, that's when I feel the most pain. And when you do their exam and you put your fingers over the patella while they're extending and flexing the knee, you may actually feel crepitus, and that would cinch the diagnosis. The management, though, is supportive. The bursa of the knee, those, we didn't talk about this when we talked about the anatomy, but there are many bursae of the knee, and they sort of act to reduce friction within the knee itself. Most of the time they're there, we have no idea, and there's no issue with them. But sometimes, due to repeated trauma, you can develop a bursitis that can be either inflammatory or infectious. So let's look at this picture. This is an inflammatory traumatic bursitis. So this is someone that's been working on their knees a bunch, and then through microtrauma and repeated trauma has developed inflammation of their bursa. We know that this is inflammatory mostly because it's flesh-colored. If you ask the patient, it's probably not all that painful. And for the most part, this is supportive. I really don't even tend to aspirate these unless there's really a lot of limitation in their range of motion or in their ability to bear weight. And when you aspirate them, you get this really nice straw-colored fluid. I put an ACE wrap on, and then they go home. If instead the knee is warm, that bursa is red, it's erythematous, it's warm, they maybe have a fever, and when I aspirate I get cloudy fluid, then that's likely a septic bursitis, but that patient can still go home just with oral antibiotics. And you can see here that this is differentiated from a joint effusion by the fact that this swelling is really encapsulated by the bursa itself, right? In a knee effusion, this swelling is circumferential. Here it's clearly captured by the bursa. Let's talk about tendon ruptures of the knee. So these occur when someone lands in sort of a hyperflex position. I always think about this with long jumpers. Like those people are just waiting to have their patellar and quad tendons rupture. And so we remember that this whole structure, the quad tendon, the patella, and the patellar tendon are important for extension of the knee. So when you have injury here, we always have to assess for whether the extensor mechanism is intact. And you do this, it's a very simple test by having the patient scooch over to the edge of the bed. They have their legs dangle, and I just ask them, can you lift your leg or not? And that tells me the diagnosis. When you're looking on x-ray, if you have injury to the quad tendon, then the patella is going to be pulled inferiorly by that patellar tendon because the quad tendon is no longer in place. You may have something called a patella baja, or a patella that looks lower than it typically would. And the opposite will happen if there's a patellar tendon injury, where now this patella will be pulled upward by the quad tendon, where you may see a patella alta. But I will warn you that in some of these cases, the patella looks to be in its normal anatomical position, so make sure that you're assessing that extensor mechanism. These also go out in a knee immobilizer. This diagnosis, the diagnosis of Baker's cyst, is usually one that I'm making on accident. I can't tell you how many times I've had a patient come in with a big swollen calf, and I've sent them over to ultrasound to rule out a DVT, and instead they come back with the diagnosis of a ruptured Baker's cyst. So what is a Baker's cyst? Baker's cyst results from some overproduction of synovial fluid that is now outpouched posterior to the knee and develops into this cyst of synovial fluid that sits just posterior to the knee. For the most part, when it's unruptured, patients will just complain of a little bit of fullness, but occasionally if it ruptures, obviously the fluid's going to go with gravity and it sort of runs down and creates this big swollen calf. The diagnosis, luckily, of both a DVT and a ruptured Baker's cyst is made by ultrasound, and then you can diagnose, and then you can decide anticoagulation versus just sending home with supportive care. I'm not going to spend time talking about Achilles tendon injuries or plantaris tendon injuries because those will come later in the ankle lecture, but I did want to spend a little time talking about advanced imaging of the knee. I'm sure all of us have seen a patient who's come in with a little slip from their primary care physician who said, you know, you need an outpatient MRI of the knee, and they've come in and they said, you know what, I just can't wait. I need to get it done here today. So who needs to get advanced imaging in the ED? I think that for the most part, there's almost no indication to get an MRI in the ED, but there are a few distinct indications for a CT. The first of which is that person who has a direct blow to the knee, who has a knee fusion and can't bear weight, where I'm looking for an occult tibial plateau fracture. The second is that patient in whom I am suspecting either a dislocated or relocated dislocated knee. Remember, that's that person with a high mechanism injury, maybe bidirectional laxity. They said their knee was out of place and back in place. They have that concavity when you're holding their legs up. That person needs a CT angio of their leg. And the last one is to evaluate for the open knee in those who have lacerations close to the knee where you can't fully evaluate the extent and depth of the laceration. This is a quick summary of the approach to the swollen knee. I'm going to let you review this on your own time because it's quite small. But what I do want to leave you with is, although the knee is prone to injury and x-rays aren't that helpful and we don't get CTs and MRIs all that often, I would actually let you know that I think that in most cases, the history and exam alone can give you the diagnosis of this knee complaint. And it can be quite cursory when I'm talking to people about orthopedic complaints where, oh, you've been having this pain for 3 days, oh, you had it after an injury, okay, let me move on to your exam. But in these cases, I spend a little bit more time because just by asking, what were you doing when this started? Were you running and then decelerated and turned? Or is this hurting when you're going up and down stairs? Did you injure this in hyperflexion? Do you work on your hands or knees? And then by doing the exam, getting the clothes off, looking for subtle effusions, for bidirectional laxity, holding their legs up, feeling for crepitus as the patella moves through the groove. In all cases, you're going to get the diagnosis with history exam alone. So this is really an opportunity to practice the art of medicine, and hopefully that's the positive note you can take from this. Thank you.
Something. Oh, there we go. All right. Oh boy. This, hopefully, is not going to be awful. Because we know that COVID is awful, and I don't even want to mention the C word, okay? But I'm going to try to get through this talk without talking about COVID at all. We'll see. We're going to talk about colds and flu and other things that you can get, Because it's not all about COVID. COVID is so selfish. It's trying to be the star every single day. Don't you know that there's still acute bronchitis, pneumonia, and other issues that we need to look for? It's not just about you, COVID. So patients come in all the time. They complain of headache, fever, insomnia, cough, wheezing, fever, everything that they're like a Pepto-Bismol commercial. They complain of toe pain and flu-like symptoms, chest pain, flu-like symptoms, leg pain, flu-like symptoms, and I need a work note. So yeah, we've considered coronavirus. You're going to get your attention, but screw you. I'm going to find the other diagnosis today. So the thing to think about, in all seriousness, did the patient get a vaccine? Where are they in the vaccination schedule? And is it possible that maybe you should just get the test anyway? Sure. Get the test, ask the history, and listen, if it's not COVID or something else, you know it's going to be the murder hornets. They're going to get us one of these days. Love Dr. Evil. He's always sending us sharks with frickin' laser beams on his head. All right. So what could it be? I used to love watching Ren and Stimpy. You'd be like, what is it, man? Some days these patients come in, you just don't know what is wrong with them. It could be anything. Is it an upper respiratory infection? Is it acute bronchitis? Is it the flu? Or is it something else? Is it meningitis? Is it pneumonia? Is it something terrible? Is it the C word? You know what? This is what I like to do when I go into the emergency department. It's a one-to-one shift. I get in there. It's really busy. Everyone's like, oh, God, thank God you're here. There's 30 people in the waiting room. What are we going to do? Please go out there and help me. All right, I'm going out. I'm going to start slicing and dicing patients, okay? I wish I could actually do that and then get them out. But I use a mnemonic called SLIT. And this stands for looking at people basically and deciding who's sick and who's not sick. So first I think the S, subjective. What are these patients telling me? What are their symptoms? L, I listen to their lungs. Do they sound better than my lungs that day? I, do they look ill? Do they look terrible? Again, do they look healthier than I do? Because it's been a long 2 years. And timing, how long is it going on? So this is a very important question to ask all your patients, even for just our last talk about the knee. How long has this been going on for? Because the timing is going to be really important for your diagnosis. So let's start with upper respiratory illness. Yes, they still exist. Just your common cold, a viral illness, an upper respiratory tract infection, exactly what the name stands for, from the neck up, the throat, the ears, the sinuses. They sometimes, have muscle aches, but they don't typically have this conundrum of issues, vomiting and diarrhea and fever. If they do have a fever, it's very short-lived, and the majority of their symptoms are only 4 to 7 days. They don't look particularly ill. When you put your stethoscope on them, you listen to their lungs, they don't particularly sound bad, and really what they want is a couple days off from work so they can rest. And you should not be stingy with the work note. I don't know why it's so hard to get people work notes. Just give it to them. What do you care? Give them the note. Makes them feel better, gives them a purpose, helps them get some rest that they need. What you need to tell these patients is not that they need an antibiotic or a medication. We're going to go over some alternative medical treatments towards the end of this lecture, and it's not going to be about ivermectin, just so you know. Basically, if they worsen their symptoms or they seem to be sicker, then they should come back. But really on day 3 or 4, they should wake up feeling a lot better. Again, supportive, rest, nutrition, hydration, all those things Diane reminded us about, right? You guys have been sick. You know what it's like. You just need a day off to recuperate. Now, there is some literature that supports the use of probiotics and sleep together. There is some literature that supports decongestants and antihistamines, but maybe some literature to support zinc, vitamin C, and echinacea. We'll get to that in part 2 of the lecture. What it does not include are antibiotics. They cause more harm than good, and that is evidence-based. So let's talk about acute bronchitis, one of the top 10 reasons that people come to the ER. You're going to see these patients, on average, in the wintertime, at least 2 or 3 patients a shift. If you don't, consider yourself actually unlucky, because this is a good, easy diagnosis to make. Most of the time, these patients, they're having symptoms for quite a while. And again, about the timing. So subjectively, these patients are telling you that they have a cough and it hurts, their chest hurts. They don't feel comfortable. They're achy. They don't know what to do. This is going on forever. So usually they're telling you it's a while they're having their symptoms. On average, these patients do end up getting some prescriptions, but typically antibiotics aren't one of them either. Don't tell these patients that they're going to get better in a couple days, because they aren't. They're going to feel bad for 2 to 3 weeks. So basically here, you can take a look at the lungs. They're all junky and swollen and inflamed. Some other symptoms that patients can have, totally variable. dyspnea, wheezing, the chest pain from the coughing, hoarseness, malaise. Of course, you're putting in your differential diagnosis, all these other terrible things that it could be, but when it's acute bronchitis, it's acute bronchitis. You can make that diagnosis. And do you get a chest x-ray? Everybody always wants to know, should I get a chest x-ray? Sure, get the chest x-ray. One chest x-ray is not a big deal. Do you absolutely have to have it to make your diagnosis? No, you don't. If the patient is super tachycardic, febrile, looks sick, well, maybe they have an underlying pneumonia. You got to look for that. And sure, there is a COVID-related bronchitis. Oh, I said the C word. I'm so sorry. But those with suspected pneumonia, certainly, and your sicker patients, COPD patients, cancer, TB, immunocompromised, yes, go ahead and do the progressive workup. But be aware of the vital signs. Go back to that eye and the slit pneumonic. Do they look ill? Again, not prescribing antibiotics for these patients. Despite the evidence, they're still given. Patients beg for them. You are in charge. You are the boss. You are the one making the decisions. Yes, some shared decision-making comes into play, but at the end of the day, patients are there for your medical knowledge. You don't go to the plumber tells you what to do, and then you say, you know what, I'm just going to do that myself. I don't know, maybe some of you do, but all the plumbing problems, I send to somebody else. Sometimes these patients will get an MDI or albuterol. That can do some good, especially for the smokers. And to be honest with you, I give that to my smokers who say, you know what, I am too sick to smoke. Because you know the smokers will smoke through it. They'll be like, I was just too sick to smoke. Speaking of smoking, these e-cigarette vaping-associated lung injuries, they were pretty hot for a little while a couple years ago. They got a lot of attention. These young, typically male patients between the ages of 18 and 25 would come in with severe cough, fever, tachycardia, and bilateral infiltrates. They were sick as a dog. They looked bad. And subjectively, they were telling me, I was fine yesterday. Today, I'm a mess. You do other tests on them, they're negative for the flu, they're negative for COVID, but you see these bilateral infiltrates. Some of these cases people thought maybe was an early start to COVID. Hard to know. Maybe there was some crossover. But these young patients were getting super sick. It turned out that this is from e-cigarette use. All of these patients that were looked at in this study were using vaping products. And they thought that possibly, if it wasn't the rat poison or the baking powder or whatever else was in the vaporizing stuff, it was the vitamin E. Because when you inhale vitamin E, it can cause serious breakdown of the lungs and irritation of the tissues. Turns out inhaling vitamin E is not a good idea, just so you know. But these patients, they don't know what they're getting when they're vaping. And just also remind patients that vaping is not a substitute for trying to quit smoking. It's actually worse in some cases. So there were a bunch of cases that were reported in almost all the states. The symptoms, as I mentioned, were these bilateral infiltrates, and the treatment was high-dose steroids. Those were effective. Patients got better faster with those. And sometimes these patients went on to get more tests, but typically, I saw a couple of these when I worked in rural medicine, and they were very sick, and they were admitted to the hospital. You might still see one. Consider it if your patient is a heavy vapor. Let's move on to the flu. So, there is a new influenza vaccine, the Fluzone High Dose, and it's more powerful, more protective for people over the age of 65. So the studies are okay, they're all right studies. So these are definitely new vaccines that are on the horizon, and I like when we get new vaccines. I'm a fan. The CDC also can give the nasal spray out, and this is that live attenuated influenza vaccine, ages 2 to 8. So the American Academy of Pediatrics is not really sure which one they feel is better. So it's still an option for these kids, either one. But you're not giving the nasal inhalation to pregnant women, children under 2, or adults over 50. You have some better options. And remember, any kid, any little kid, typically we give the flu shot 6 months, 12 months. You want to have to give them 2 shots. The flu shot, the very first time you get it, is 2 shots. If you're really nerdy and like to look at statistics, the CDC has some really cool weekly, monthly, and seasonally published informational charts. They look at the whole world, they look at your state. You just go to cdc.gov and look at the flu view. Cute name, huh? Now, there's a lot of people that get more sick with the flu. We know they tend to have more complications. And it's so interesting that obese patients across the board have so many other problems. They have problems with COVID. They have problems with the flu. They have problems with all your comorbidities. So when you have a patient with a BMI that's higher than 40, put them on your radar because they're going to have complications. Statistically, they're not going to do better. Of course, our transplant patients, of course, our sickle cell patients, of course, our cystic fibrosis patients. So again, if we're slitting these patients, they look ill. They're telling you that they feel like crap. They have a fever, sore throat, they have the whole picture, everything. It is just the end of the world for them. They feel like garbage. So how do you make the diagnosis? Well, you can make a clinical diagnosis, but if you really want to get the test to do the result, you can do a PCR rapid molecular assay, you can get viral cultures, and typically you can get a pretty good result if you use a good test. Some of the tests out there aren't very sensitive. Some of them can be more specific than others. So make sure you know which one you have and the statistical information behind them. What does the CDC say to do? Well, CDC says if the test is positive for the flu, if the symptoms have been ongoing for less than 48 hours and there are no other contraindications to give a treatment of antivirals, then you're giving antivirals. Now, this is tough, right? So you have a national organizational guideline that is telling you something that you should do. Even if you don't want to do it, you kind of feel pressured to do it, right? This is where good documentation comes into play. You really want to put in a good history, physical, conversation that you had with the patient and why you did or did not give this antiviral, because giving antivirals is not without consequence as well, which we'll talk about in a moment. But here are the antivirals. There are 3 and actually now a 4th recommended. They're FDA approved. You have the Tamiflu, you have the Relenza, and the Rapavad. So basically, you have an oral medication, you have an inhaled medication, and you have an IV medication. They got you covered. And there's some specific guidelines in which you would use these in various cases. Then there's a baloxavir marboval. We just come up with the greatest names. It's like, I love the commercial for this too. That's like, do not use if you're allergic to baloxavir marboval. Well, yeah, I mean, am I really going to use a med that I'm allergic to? Well, I guess, whatever. So they have to put that disclaimer. So this is that Xofluza. Single oral pill costs anywhere between $30 and $150. And it's given for uncomplicated influenza patients if they're greater than 12 years old. And you do a dosing of 40 to 80 milligrams per kilogram. 40 to 80 milligrams, or 80 based on their weight. It's a weight-based med. Well, what are some side effects of antivirals? They can be bad. They can be detrimental to some of these people. It would take off a week from work if they have this. In fact, there was a study that looked at some neuropsychiatric issues in some patients in Japan adolescents. I think that they were probably just listening to too much hard rock. I sound like my mother there, but man, come on, guys, we gotta get excited about these talks today. We're gonna keep you awake because if you go home from Vegas and you haven't had a good time, you know what? We gotta find a way for you guys to have a good time today. Antiviral contraindications. Who are you not giving these to? Anyone that's confused, suicidal, delirious. And again, if they have any allergies to antivirals, you certainly want to give them, as we talked about. And I guess, again, doing the shared decision making, definitely something that you can chart and discuss with. Please adhere to the age guidelines as well. The bottom line, as my friend, dear friend, Ken Milne would say, be skeptical of the antivirals. It's possible that the antivirals shorten the symptoms, but it doesn't really reduce the number of hospitalizations, death, or other real complications. The jury's still out on that. The prophylactic effect seems to be minimal, so you don't want to prescribe this to the family members who have no symptoms or aren't sick. Make sure you check online to see where you can find it for cheaper too. All right, so now that you've found all this information, you feel like maybe you're stuck in a rock and a hard place because it's like, well, this guideline says I got to do this, and I don't know, I want to do that. Well, let's go through some real hard facts here. Let's do some fact checking. Who knows who this chick is? Her face look familiar to any of you? This is the Redskins cheerleader who said that when she got the flu vaccine, it made her walk backwards, like MJ, which is a great slot machine, by the way. If you come across it, turn up the volume really loud, put in $100. I can't loan you that money, though. Fake news. The flu shot or nasal spray causes the flu. This is false. It does not, period. End of conversation. The flu shot causes body aches and low-grade temperature. Possibly, but when they looked at a study, a double-blind study, randomized, they showed no difference in the side effects of the people that got the injection of sterile water in their arm, salt water, versus the people that got the flu. They both had body aches and side effects. Can the flu shot cause Guillain-Barré syndrome? Sure, it's possible. I have actually seen it one time. We think it was related in a pediatric case. This is so rare, though, super rare. So this should not be your everyday thought, but we forget about GBS sometimes, and it's a fascinating workup. Having seen it from the ER and then worked with the patients into the PICU and the pediatric units, it takes them a very long time to recover, and some of them don't live. Children who have not been vaccinated before have only needed one shot, and we already talked about that you need two. The American Academy of Pediatrics does recommend two. And the flu shot works right away, right? No, false. It takes about 2 weeks to be protected from the flu. What if you have an egg allergy? You can't get the flu shot then. That is garbage. Total and utter garbage. I'm debunking it right now. If someone tells you that, it is simply not true. What about the rate of anaphylaxis? After all vaccines, it's about 1.31 in a million. Pretty small. More myth busting. Does milk consumption during colds make it worse? Meh. I don't know. If grandma wants to give the kid a cup of milk, sure. But the color of the sputum, it could be green, orange, black, brown, purple, or sparkly. The only color I care to investigate further is blood red. And actually, Diane, if she were here, she gave me the statistic earlier. You swallow about 1 liter or 1 quart of snot a day. True. Delicious. Hey, look, here's my drawer at home with all my over-the-counter, so we're going to end talking about alternative treatments. I'll tell you, it's looking grim. Okay? So here's my drawer at home. I got some saran wrap, I got some scissors, maybe some staplers, some condoms, some codeine. Yeah, it's a party at my house every day. All right, so over-the-counter medications of cold and flu, it's like a mixed bag, baby, right? We got tons of things we can give. Here's our list. Everything we can choose from. Go into the drugstore, the pharmacy, and the aisle is just packed with this shit. It's ridiculous. It is such a waste of money. But we do it, and people do it, and they keep buying it, and they keep subscribing to it. So let's talk about the things that work. Sudafed is actually a pretty good drug. What is it, Walter Wright? Who is the guy from Breaking Bad? Am I right? So we're not going to make meth labs here, but I will tell you, this stuff can get you going. If I really want to have a good shift and I'm feeling stuffy, I take 2, sometimes 3 tabs, and I am clear. I'm ready to go. In fact, I took 5 this morning, in case you couldn't tell. So it may be more useful in patients that have a lot of ear infections because it helps with the drainage. And the studies sometimes can be mixed on the nasal form, but Sinex sometimes has been shown to do better. So the spray isn't that bad. If you're going to use this, I would say just caution patients that it does make them feel a little speedy. All right, so what else can I put up my nose? We can put a lot of things up our nose. We got some nasal decongestants, including neosynephrine and oxymetallazine. So we've got Afrin as well. They're both great for relieving temporary nasal congestion. Kind of tighten things up in there. The problem is that you can get this rebound rhinitis, this rhinitis medicamentosa. We need to caution the use of this in children as well. So just if you're going to prescribe this, don't do it for more than 3 days because will get horrible rebound. And when I say rebound, I've had it, and it literally drips out like a faucet from your nose. Hey, look, actual footage of me from this morning. Can't get you guys with that joke. All right, so again, you're warning about rebound rhinitis. More things you can put up your nose. Look, you can put an onion up your nose for all I care. It's probably not going to work, but there's some other things that might work. Flonase has shown to have some use in people who have long-term issues, especially those with asthma or colds. So if a patient says that they've had relief from Flonase before, give them the prescription. I've used it. It's good. It can cause epistaxis, so just caution people that it can cause a dry nose. Chromium sodium, this is fantastic. I prescribe this to kids all the time. The literature supports mast cell stabilizers. If you haven't had these before, I highly suggest giving them to your pediatric patients, especially those with underlying allergies. And sometimes even if they just have an allergy attack, it's great, not just for colds. What else can help you go to sleep? Well, you have Alka-Seltzer, NyQuil, and other antihistamines. What I want to say about Alka-Seltzer and NyQuil specifically, those are just combination snake oils in a box. The only effective thing in there is probably maybe the aspirin or the Benadryl. Those things might help you a little bit. But I will tell you, there's no reason to buy a mixed product. it's not like a mixed drink where you have it on Long Island and like 2 or 3 of those make you go to La La Land. This is just like, again, super expensive snake oil stuff that we talk about. Have them just take a Benadryl. Have them just take the aspirin. Have them just take the Tylenol. You do not need a combination liquid med. But, you know, NyQuil will help you sleep, like I said, because of its underlying polypharmacy, kind of just get you there. But again, antihistamines may help with sleep just by themselves because they help dry out the nose. What about these other natural paths? What do they think we can do with zinc? Well, the current studies suggest that possibly zinc lozenges, if they're used within the first 24 hours of the onset of a cold, it may shorten the duration of the overall illness. Now, they're suggesting 100 milligrams per day. This can cause serious stomach upset. It is very dangerous in patients if they take too much. Now, the Zicam can actually cause anosmia, which is the loss of smell and sometimes taste. And if you're curious, February is National Anosmia Day, so get on your donation list now. Echinacea, again, taken at the first onset of the symptoms, but how good are patients at taking things at the first onset? They're seeing you unless they're like, I've had 1 hour of a runny nose. Has anybody had that patient? I just love it. Makes me laugh so much. I'm like, oh my gosh, call the code team. So they looked at a review of the echinacea. It can cause a lot of problems as well. You know, in California, everything can cause cancer. So when I'm there, I look at everything from, you know, a pair of shoes to an apple in the grocery store may cause cancer, right? Everything can cause cancer. So that was one of the big things with echinacea, though. So just something to think about. What about vitamin C? Does that do anything for us? Possibly. I don't hate vitamin C. I don't love it. We're in kind of an interesting relationship right now. But what I would say is that those who are extremely healthy and do high doses of vitamin C, they might kick a cold. They might get better faster. The problem is if you do really high doses of vitamin C, you could develop kidney stones. So they suggest taking 200 milligrams of vitamin C in this one particular study, and that could help both adults and children. If you're getting that from your food, though, do you really need to take a supplement? I actually read a very interesting study this morning that said that vegetarians were 73% less likely to develop harmful effects from COVID. Vegetarians. They're still not cool to hang out with, so I don't care. So Vicks essential oil and rubs. Grandma knows that Vicks is the only way to cure you. Just put a little rub on that chest. A little lavender, y'all smell good. Freaking $23 for lavender. This is nuts. It's nuts what we do. But I own about 5 bottles of lavender. And all else fails, you could put onions in your socks, right? Who's ever done that? People have been doing that for centuries, and that might still be something that you're going to do. So let's end this with antitussives. Dextromethorphan. Did I say it right this year, Rick? I always end up saying dextromethorphan wrong. This can come in a tablet, syrup, spray, lozenge form, and it can be addicting. It can be used recreationally to get high. I've had those kids come in. And there are some studies that showed that the effectiveness of it was similar to the placebo. And I don't know, you know, I think it's a 50-50. I think it helps some people. I think it helps, you know, maybe some kids. We'll talk about Delsum in a second. But if they're really coughing a lot, the benzonatate, the Tessalon pearls, they can do the trick. Just be careful. You don't want to go too much on the dosing with these. 100 milligram capsules are enough, a max at 3 times a day. Albuterol and other inhalers can cause side effects. They can be expensive. But codeine, shit. My dad used to give me a shot of tequila and a shot of codeine when I was 13, and I did great. Children and antitussives. We don't give codeine to kids. I notice how I said 13, not 12, right? It's okay for me after 12. It's okay to have it after 12. Honestly, my kid loved honey and pineapple. She would be, even when she wasn't sick, she'd be like, I have a cough. I need honey. She's 7 now, and she still asks me for it. There are some great studies that look at this that are actually super effective. Really, you're not going to prescribe anything to kids. Parents, like, the question I ask to the parents is the cough bothering you more than it's bothering the kid? Most likely. So again, just a review of some of the studies in JAMA, as well as the American Academy of Pediatrics. There's a Cochrane database review. I'll let you do your own search on that, but can be useful. So suggest it. Expectorants. There are only 2 FDA approved. You have your Mucinex and your Mucovist. These are medications that you take to basically loosen everything up and get some coughs out. Move it up towards the pharynx and so you can spit it out. I swear the guy in the room next to me must be taking this because every second I hear, Jesus. Here's a nice little infographic that can help you figure out where things are working and what they do. I love infographics and memes. What about some concerns, some medical legal stuff? I always like to put that somewhere in here because you need to be worried about decongestants and hypertension. People with high blood pressure can have some serious side effects from things like pseudoephedrine, ephedrine, phenylephrine, and oxymetallazine. Okay, so keep that on your mind. Perfect storm would be sending that patient home who has a blood pressure of like 180 over 100, who isn't on their hypertensive meds, and you give them all of the above. They just blow up. Head pops off. So don't do that. Prolonged QT syndrome definitely can occur with our macrolides, so our azithromycin, and there can be some side effects with acute narrow-angle glaucoma and antihistamines. There is some good literature on that. And of course, we've talked about cautioning polypharmacy, and of course, antibiotics. They are not needed for almost everything I spoke about today. But what if it's not just the cold? It's not just the flu. What could it be? It could be a ton of other things, right? It could be. And that should always be on your thought list. But remember, you're listening to what the patient says. You're listening to their lungs. Do they look ill? And how long has this been going on for? And do they want a work note? Medical legal, again, you should really make sure that you check the vital signs at time of discharge. They're vital. Make sure that they're not still persistently tachycardic at 130. Something else is going on. Strict return precautions if they get sicker, that is. And then also, talk to them about the medications that you're giving them. Motrin and Tylenol go a long way. Combining Motrin and Tylenol together, actually, according to the studies, can have actually better pain relief than opioids. Of course, these people aren't getting opioids, but sometimes, again, the coating can be effective. So here's just a summary of what's effective for the common colds and what might be useful. I don't see anything on here. Oh, yes, the onion's definitely ineffective, but ivermectin is not on my list. So here's some case studies. We have 2 minutes left. Let's run through them. Okay, I like this one. So there's a 29-year-old male, otherwise healthy, right? Get this patient a lot. His history of a tonsillectomy removal as a child, no allergies, no medications. He's got a cough, body aches, but no fever. His exam is normal. He's got a runny nose. And what really brought him in was to see you is he's got a lot of skin irritation under his nose. I mean, he's pissed. He's always in the mask. He's also maybe a little bit worried about COVID. So what's your workup and treatment for this guy? What's your workup and treatment? You don't need to do any testing for this guy. Maybe a COVID test if he asks for it, but you don't have to. And then reassurance and strict return precautions. Young, otherwise healthy. The other thing I might add are, fluids, rest, a work note. Consider over-the-counter nasal sprays. Maybe this would be a good Flonase candidate, or maybe 2 or 3 days of Afrin. That might help this guy. And then I love a little Gold Bond lotion under the nose. It doesn't smell like anything. It burns just a little when you first put it on, and then it really intensely moisturizes that area. Vaseline also just fine to stop the irritation from the fluid coming out of the nose. Next case, 3-year-old. Immunizations are up to date, brought in by the mom. She's not eating. She vomited once, fever for 2 days, temperature of 102. Her brother's sick with the same. Just got sick today, this kid. The patient is coughing and lethargic. This patient is not looking great. But you know what? You go to tickle her and she's laughing. She responds to you. Heart rate's 140 temp on your reassessment is 99, and the SATs are 99%. So what do you do for this? Yes, I would do an influenza test and a COVID test. But she turns out to be positive for flu, negative for COVID. So you note her vital signs. You want to give her some fluids. You want to give her some Tylenol. You want to keep doing some reassessments. Watch her for a little bit. You may or may not consider doing an x-ray on her. But once the vital signs improve after some fluids, might want to give a little Zofran, PO Challenger, sure. And then what I really like is calling this patient back in the morning. If they improve while you're in your department, call them on back tomorrow. Takes 3 seconds. See how they're doing. I'll leave the last case for you guys to review because I want us to stay on time today. And when all else fails and all the diagnoses, you haven't been able to figure it out, it could always be the man flu. I'm going to get a lot of hate mail on that one. I know it. But it's a real diagnosis. All right, who's up next? Chip? Thank you, everyone.
Oh, this is a different clicker. So which?
The other one's up there if you
Okay, so this is just advancing this faster. Right, all right, perfect. Alrighty, so just making sure. Okay, no mic issue this time. Perfect. So once again, I'm Chip. Like I said, emergency medicine PA and working in Missouri. So we have tons of people who smoke, and then we have lots of kids who always come in with respiratory issues, especially this time of year. You know, as you may be seeing in your part of the country as well, where you're practicing at. We even have croup and RSV that feels like it's been going on even through the summer and now into the fall. So all these things kind of tie in a little bit together, but we're going to talk about specifically in this section about asthma and COPD, and this is something that can be, you know, quite the broad spectrum, right? You can have these kind of simple exacerbations all the way up to life-threatening. With asthma, just remember, this is something that's just like COPD. We're talking about like a chronic inflammation that's going on, where there's going to be different degrees of responsiveness. Some people are going to need to use inhalers daily. You may have some that's more exercise-induced. But usually, symptoms of more severe episodes are going to include like cough, shortness of breath, wheezing, and chest tightness. One thing to ask about parents, especially when they're new to this and they're new to reactive airway, is when they talk about their wheezing, I like to clarify with parents when I'm like, clearly this kid's not wheezing. Are they talking about the child's congested? Because, you know, some parents tie congestion with wheezing together, and so that can really help out. If you have parents who are talking about, well, they've been wheezing all the time, and you look at this kid's perfectly fine, like they're just snotty nose congestion. That's something that I like to clarify because that happens more often than you might give credit to. But again, in general, we're talking about when you see asthma, you can see the coughing, you see the shortness of breath, you see the wheezing, you see the chest tightness with it. Early on with asthma exacerbations, you know, the big thing we see bronchospasm, and then we get this like a little bit of cholinergic response, which we'll talk about how the treatment ties in with this. But over hours to even days of symptoms, you're going to start getting more and more airway inflammation, hyperresonance, you start getting airway edema, you can get mucus plugging. I mean, it gets really nasty, and this is where, if left untreated, it can be more and more complicating, take longer to recover, and there's more complications with it. So really early recognition and intervention is going to be key here. So what we want to do is we want to reverse the bronchospasm and reverse the inflammation. And we also want to, in the future, to help reduce the exacerbations that can occur, is to modulate that immune response. So again, we're trying to help calm down how the lungs are in some ways more hyperacute to irritations, whether that's because of allergens, or if it's sometimes the situation of where they're at. Maybe there's smoke in the home, there's mold, there's stuff like that. Or of course, again, when we see kids with viral or adults with viral respiratory infections, and they have that as a trigger. Those are all very common reasons to see asthma exacerbations or COPD exacerbations. So again, intervention, we're talking about giving them a bronchodilator, we're talking about giving them steroids. And one thing we want to do, though, is really kind of figure out, and you can do this, you can eyeball them very quickly and see, is this someone who I need to be worried about? Is this someone where we're going to need to get an IV, we're going to need to get some labs, we're going to need to maybe do some imaging, stuff like that? Or is this someone who I can treat and treat by maybe giving them just a simple steroid, maybe a breathing treatment in the department, prescription for home, something like that? Some questions to ask and things to look at as far as to assess the severity and where we're at is, how long has this been going on for? Are they using any treatments on home already? Do they already have an inhaler? Maybe their inhaler recently ran out, and that's why they're here now. Do they maybe are supposed to be taking steroids at home, daily inhaled steroids, or something else that's meant to, again, help calm down that chronic issue with the inflammation that's been going on? Also, have they ever had to be hospitalized for asthma in the past? And very importantly is intubation, especially when they get severe. I like to ask them, like, hey, have you been intubated before? If it's an older adult, I like to ask them too, what goals are, stuff like that, in case they do have a long history of intubations, because, is this the kind of therapy that they want if we get down that pathway? Now, one important thing to remember is that we really, with asthma and COPD exacerbations, intubation is very, very far down the pathway. I mean, it's a true failure at that point of everything else that we've tried. It's something that we want to really spare, because we don't really fix anything when we intubate someone. All we did was we put some plastic there and we're helping breathe for them, but the underlying inflammatory process that's going on does not change just because you intubated them. So if they're fatiguing out, then that might be where you have to go eventually, but we really want to avoid that. But knowing that they have a history of previous intubations can give us a clue of how well they've compensated with more severe asthma exacerbations in the past. Also, do they have other illnesses that might complicate things? If they have diabetes, for example, again, you're going to want to give them steroids, but maybe you're more cautious about it. Maybe you make sure to emphasize a little bit more, like I do. I like to check what their baseline blood sugars are. Do they check them regularly? Are they taking medications for it? And I like to document that in there about we had this discussion, because every now and then you'll get patients who they don't, the steroids did a great job taking care of their asthma, but now they come in with blood sugars of 1,000 because they are such a brittle diabetic, and now they've gone to the other end because, oh, by the way, they didn't take their medicines, they haven't monitored their blood sugar in months. So this is just kind of outlining, again, risk factors for death from asthma. It talks about like the repeat hospitalizations, the intubations before, stuff like that, ICU stays. When you start having these add up, this is more and more of a point where you might think to yourself, okay, if I've got someone who I'm pounding treatments back to back and they're pretty sick there, this can be more clues as far as someone to take more seriously, as far as maybe they do need to stay in the hospital. Differential diagnosis for this is huge. Again, we've talked about some of the possible triggers for asthma, and that can also play a role both in children and adults. Now, how you examine, obviously, you're going to use your stethoscope, your wheeze detector, to kind of listen for those things. If you have someone who is having difficulty with speaking in full sentences, maybe they're only saying a couple of words at a time, something that I think is more traditional to document is like, speaks in 2 to 3 word sentences, for example. Something that you could do, and this is something that seems to be maybe recommended a little bit more, is when you have these people who are short of breath like this, is ask them to count as high as they can and see how high they can count in one breath. So if they can count to 4, okay, maybe they can get about 4 words, versus some people might talk really short sentences anyway. By having them count, you can get that same kind of idea. Also, again, when you're listening to their chest, do you hear any wheezes? Is there decreased airway movements? There's this prolonged expiratory phase. A silent chest should have you concerned. If you're like me, you're already hard of hearing, you might not always be able to tell, but usually you can see that they're working, they're trying to breathe hard, but still no air is moving, and that should be a big red flag right there. Are they retracting? Do they have accessory muscle use? Are they diaphoretic? These are all things that are clues that this is a more severe asthma exacerbation, or again, as we're going to talk about with COPD, a COPD exacerbation will do the same things. Cyanosis is rare, but again, is a big clue that if you start seeing this, be cautious with them. And then mental status, are they getting combative because maybe they aren't oxygenating as well as they should? Are they becoming somnolent for the same reason? These are signs of impending respiratory failure, and again, things that we have to clue in on early. Especially when we're talking about young kids, this can be hard. So whenever possible, get a pulse oximeter on them as quickly as possible. One thing to do is, especially when we're talking about like these little finger devices here, they're not bad. In fact, when we, with COVID, I feel bad for mentioning COVID-19 because we've already talked about that a little bit. But I like to make sure that they have pulse oximeters at home. Same thing with people with asthma and COPD. I ask them to have a pulse oximeter at home, but I warn them that sometimes it's not going to read that accurately, especially if they have poor perfusion distally and stuff like that. But when we're in the emergency department or urgent care, a lot of times we have ones where we can get a pleth on, and I want to be able to see that there's a good waveform and get an accurate oxygen saturation that way. Because you might have a child whose oxygen saturations are reading 86%, but the wave is terrible. But once you get them calmed down and relaxed and you can get a good wave, you might see it's 92%. Okay, still not great, but a lot better than the 86% I saw a minute ago. ABGs are rarely needed, but sometimes you might want to consider it if they have a really low peak flow. Now, how many of you right now with your asthma or COPD patients are you measuring peak flows in the emergency department or urgent care? Show of hands. Okay, actually more than I thought, because I was expecting like no hands or maybe like one or two. So that's great for the ones that do. For most of us, I couldn't get a peak flow if I wanted to, and that's probably how many of you are functioning as well. If you can't get the peak flow, it can be helpful. It can also be helpful to see how quickly they're responding to care, stuff like that. So if you can get one, great. If you can't, again, use your best judgment as far as seeing how well they're responding to treatments and what they're like compared to their reported baseline and so on. A chest x-ray, it can be helpful if you hear some rowels or maybe even some rhonchi. They have fevers, unequal breath sounds. The unequal breath sounds, we're thinking about pneumothorax. Keep in mind that a chest x-ray is not going to be perfect. It's not always going to detect pneumonia. In fact, ultrasound is actually a really great option, especially in kids or pregnant females or just anyone. If I have a dyspneic patient, I like to use ultrasound because I can get answers in real time. I can get it quickly. I can see are there lots of B lines, which would be signs of edema? Do I see subpleural consolidations, which would have me concerned for pneumonia? And it's actually more accurate than a chest x-ray. So it's something to consider. If you have the ability to use bedside ultrasound, amazingly helpful here. If you don't, a chest x-ray can still help you out. But again, not every COPD, not every asthma exacerbation needs a chest x-ray, especially these more straightforward, uncomplicated upper respiratory infection that now has a little bit of wheezing component. They don't look bad to you. You probably really don't need a chest x-ray there. Labs, same thing, rarely useful unless you're looking for very specific things. Again, maybe you're doing a flu swab or you're doing a COVID-19 swab or something along those lines. Now, we talked again about peak flows. If you have them, great. You can kind of see the severity here. But otherwise, you can talk about what's their ability. Are they short of breath with activity, or are they short of breath even at rest? This can give you an idea of where these patients fall, but keep in mind, again, you might be able to reverse someone very quickly with a single breathing treatment, and they might be able to go home with some steroids. Obviously, oxygen if they're hypoxic or when they're in significant distress. A lot of times when you're giving them the breathing treatments, they're going to get some oxygen to go with it. When they are more severe, though, we're going to get IV access. We're going to monitor them. A lot of times we're going to do back-to-back breathing treatments, if not just continuous nebulization. The other things that we can consider about is once we're starting to have to do breathing treatments with frequency, that this is someone where we need to consider hospitalization or even ICU admission, depending on the level of care that they need. When it comes to breathing treatments, now that we've talked about this a little bit, so beta agonists, the short-acting beta agonists, the SABAs, SABAs, albuterol is the most common that we're talking about, and we're talking about usually giving albuterol as like 2.5, maybe 5 milligrams if you're going to give them a little bit more. And this is something that you might be doing as a single treatment. You might be kind of spacing out, just seeing how they're doing, with the idea that this is an intermittent. So about a 20-minute treatment every 1 to 4 hours. If you're talking about someone that you're sending home, though, I'd like to mention, okay, do this every 4 to 6 hours or however often you need to. But if you find that you're using this every hour or two, you need to come back, because obviously you're not getting better. Things are getting worse, and I'd rather you come in sooner versus waiting too long, and now we're in extremis and we have more problems. So that's one of the reasons that you can say, hey, I want you to do this every 4 to 6 hours at home. If you find that you're using it more often, especially if you're having to use it every couple of hours, you need to come back so we can reassess you. And with that in mind, so some people worry about, well, how much albuterol can I give? Can I give someone too much? realistically not, especially if you're giving the nebulizer, if you stick in a room for any length of time after respiratory therapy or nursing or whoever is doing your breathing treatment, you're going to notice, especially with kids, the smoke's going everywhere. Like you're just hoping a certain amount of it actually gets down into the lungs. So a lot of times, even in the little, the infants, I'm still giving a 2.5 milligram as the dosing, because I know realistically not as much of it's going to get down, and it's not necessarily going to cause any harm, maybe some tachycardia, but they're already excited, so that I'm not as worried about. If you can, you can have them use their inhalers. In many ways, inhalers and nebulizers are very much on par. Realistically, in the emergency department, it's easier to give someone a nebulizer, walk away for a few minutes, do other things, get IV access, stuff like that, than trying to coach them how to use an inhaler. So that's one reason why we may use a nebulizer instead. But they are very much on par. So if you want to teach parents or the individual, if they're old enough, like, hey, you can take multiple puffs of your inhaler and accomplish the same goal, that's again another option. There's a synergistic effect with ipratropium bromide, which is cholinergic, and so when we're talking about like the anticholinergic effects that we're seeing with asthma exacerbations, I'm sorry, I flipped that in my head. So when we get the cholinergic effects with asthma exacerbations, we need anticholinergic. So ipratropium bromide is the one that we usually go to there. That's 0.5 milligrams. Again, as the nebulization, and then we're doing that, up to 3 doses. This is something that we can use back to back like that, or we kind of space them out. Usually we mix it in. At my particular location, a lot of places I've worked at, where we'll mix it straight in with the albuterol, and if we're going to do repeat treatments, we do them at the same time, and we call them ANAs, or duo-neb treatments is another way that you'll see them. But the ipratropium bromide with the albuterol can really provide some additional relief, especially when you have the parents at home who've been taking care of their child with asthma. They say, well, we've done the albuterol treatments, we've tried the breathing treatments, it's not helping. It's amazing the difference after a single ipratropium bromide with the albuterol, how much better these kids can get quickly, and then you can get them home. Other beta agonists, so levalbuterol can be used. That's Zopanex is the brand name for it. Rarely does it seem to make a huge difference. Some people may just be less tolerant to albuterol because it causes too much tachycardia for them, or just makes them feel more jittery. So the levalbuterol might be a little helpful there. We tend to see that maybe used a little bit more in children for the same reason, but evidence is kind of limited there. Epinephrine, this is good when you're getting into more severe asthma exacerbations, and so this would be something that we're usually going to give as like a sub-Q injection, very similar to how we would do it if it was like anaphylaxis. So we're using that same 1 in 1,000, 0.3 to 0.5 milligrams, or if you're talking about a ped, 0.01 milligrams per kilogram up to 0.3 milligrams. And you can repeat that again as every 20 minutes up to 3 doses in children and adults. Another one that I feel like is in many ways like the forgotten child is terbutaline. And if you are, if you take EMS patients, you might notice that more of your asthma, COPD exacerbation patients right now, have you noticed like an increase in terbutaline use? Okay, there's a reason why, and like I said, I still work in EMS. One of the reasons why is because it contaminates the ambulance when you have these COVID patients and you're doing these breathing treatments. So many ambulance districts have actually nixed giving any breathing treatments in the back of the ambulance because it takes down that ambulance for an extended period of time. So instead, we're noticing an increase in using terbutaline, so that way we can still get the beta agonist effects on board. And it still helps. It's still something going on. So if you notice that you're seeing more people getting terbutaline recently, it's most likely because of the pandemic and because of changes in recommendations or protocols or guidelines for that EMS district. So steroids. This is the one thing that personally for me, if you can take away from asthma and COPD, steroids. Give them steroids. Even I kind of joke about, even if you have the kid who is just here with, hey, we ran out of our inhaler, like if they're here for any degree of asthma exacerbation, give them the steroids now, because I have seen way too many times where my colleagues, or whether they're in the emergency department or they came from a clinic or stuff like that, they just said, well, here's some albuterol, and they sent them home, and now they're back with a bigger flare-up because we didn't get that inflammatory process properly calmed down with steroids. So give them steroids. Be ready to give that. Find what steroid works best that you prefer. There's different ways of dosing, stuff like that. Generally, when we're talking about like prednisone, we're talking about 40 milligrams per kilogram, or 40 milligrams per day when we're talking about like adults. Tapers usually aren't necessary. If you have patients where either they're young or you don't really think compliance-wise, maybe they're homeless, or maybe there's someone that you just really are not sure if they're going to keep up with their medicine, or they just tell you, hey, you can prescribe me whatever, but I'm either not going to get it filled or I'm going to forget to take it, even if it's a once daily medicine. Dexamethasone, Decadron, is a fantastic option. You could do, if you're doing the tablets, a lot of times they come in 4 milligram tablets, and so we'll do 12 milligrams, and there's some good data for URIs and pharyngitis and stuff like that, and doing 12 milligrams. Now, if you have the kids and you're doing the IV-IM version in PO form, they usually come in 10 milligram vials, so you can do up to 10 milligrams. A lot of times you can do the 0.6 just like you would for croup. So 0.6 milligrams per kilogram up to 10 milligrams, give them that one time. Mix it in some juice or acetaminophen, ibuprofen, something, because it tastes awful by itself, but it works great. And that gives you 3 to 5 days of coverage there, which is usually all that you need it for. If you want to have a little extra protection, you could always send a single dose to the pharmacy of like another 12 milligrams of dexamethasone to the pharmacy if you wanted to. The reason why we do the IV-IM instead of the regular like PO dexamethasone is because the regular PO dexamethasone, it's not nearly as concentrated, so they have to drink a whole bunch of it. But if you do the IV-IM and switch it to PO, they tolerate that really well because you're talking about 1 cc. Inhaled steroids are also beneficial. So when we're talking about our steroids, they can be, in some cases, expensive. There are some that are less expensive with it. There are low, medium, and high dose inhaled steroids. The one thing that we talk about with that is like budesonide can be one example, but just pick a steroid that you feel comfortable with. And the nice thing with budesonide is it's inhaled, but you can also get oral versions of it too. Magnesium, this is another one of those that we save for more severe cases of asthma exacerbations. So we're talking about giving 2 grams over, once again, 20 minutes. If you notice, there's a 20-minute theme that kind of comes up with this. Be careful about giving magnesium too quickly. It can cause hypotension. Also be careful with certain patient populations that might not tolerate magnesium as well. So myasthenia gravis, for example, you can really mess someone up if you give them magnesium. It has a relatively short half-life, but it's one of those things that can really can turn the tide in some cases with people who are otherwise quite sick. There are some medications that we want to avoid, and so one of the ones that you might think about, like antibiotics, again, just like we're talking about with the viral URI type stuff, it's not really going to be helpful unless you see bacterial pneumonia, or you get the case of maybe someone who maybe the strep might have been the cause or something like that, and you have a positive strep test, something like that, then maybe that's when you go ahead and treat it. But aggressive hydration or sedating these kids or giving mucolytics, they're probably not really going to help, and in some cases there are some risks of harms with some of these. Ultimately, most people are going to be able to go home with asthma and COPD exacerbations. We want to make sure that they're getting as close to their baseline as possible. Again, if you have the peak flow, you can check it that way. But ultimately, we want to make sure that they have a rescue medication to use at home, so they have a albuterol inhaler at home to use along with the steroids that we're giving them. This is going back to what we were talking about. There are different forms of steroids. The main thing is just pick one that you feel comfortable with. Make sure you give them albuterol. If they're a child, make sure they have a spacer with it too. It helps it make it more effective than just giving them the inhaler by itself. If you have respiratory therapy at your location, that makes life a lot easier because they can also teach it. So COPD, a lot of this is going to tie over between the COPD and the asthma side. So COPD, you're thinking about chronic bronchitis and emphysema. Again, this is a similar issue with the airways as far as we're losing some of the elasticity. It's a lot of chronic inflammation, can lead to fibrosis. So there's different things we want to ask about. So risk factors for why they could have been sick. How does this compare to previous exacerbations? They ever have to get intubated, just like our asthma people? We want to ask all these and like identify those comorbidities and stuff like that. They're usually going to have some degree, because again, this is chronic obstructive pulmonary disease. They're going to have some degree of symptoms all the time, and they're going to say, "Well, I always cough because it's my smoking." Okay, well you've got COPD there, but how does this compare? Oh, I can't, like Martha was talking about earlier. I can't even smoke. It's so bad right now. So that's something that we want to look at there. Do they have other things? Fevers. Okay, maybe they have some pneumonia going on with this. Do they have chest pain? ACS can kind of be tricky sometimes. You're going to get people who come in saying they have a COPD exacerbation, they end up having a STEMI. So be cautious with some of these people, because they can really kind of trip you up on occasion. EKGs are quick and easy to get if you have any concerns about it. Look at their vital signs. Same is true with asthma, especially in kids. All the time I see a respiratory rate of like 20, 24, and the kid is breathing 60 times a minute. Make sure you're counting the respiratory rate yourself, because you'll be surprised at how often it can be. Again, listen, do they have bronchi? Do they have wheezing? How's their breathing? Do they have a prolonged expiratory phase? Do they have signs of edema? Do they have significant pedal edema that's pitting? These are types of things that we want to be able to look at. Classically, we talk about our blue bloaters and our pink puffers, so chronic bronchitis and emphysema respectively. This is kind of a way to help see, like with the blue bloaters, they have right-sided heart failure with it, versus those without. That's your kind of your pink puffer, more emphysematous type individual. Chest x-rays can be helpful. Again, not everyone's always necessarily going to need a chest x-ray, but if you have concerns for CHF exacerbation, pneumothorax, pneumonia, those kind of things, it's helpful. Like I said, I use lung ultrasound with much of the same purpose. We talked about EKG for the same thing. We want to assess for ACS or other things that might be going on with it. Pulse oximetry, always, cannot emphasize that enough. Maybe a VBG or an ABG. The main reason why you're getting an ABG or VBG here is because we're looking at the pH and the CO2. If we have a significantly high CO2 and we have an acidic pH, then maybe this is acute CO2 retention, and maybe in that case they might benefit from some bilevel. Bilevel, we're also talking about BiPAP. BiPAP is actually kind of more the brand, but this is outlining the gold therapy. This is something to kind of use more of a reference later on, and this is something that's easy to pull up that kind of walks through based on how severe their COPD is, what they should be getting for treatment. And then, of course, a long list of medications. There's all sorts of drugs out there for COPD and asthma. And there are different types of inhalers and mists and stuff like that. Just make sure that, again, it's like the other drugs we're talking about. If you do find yourself, and hopefully not very often, but if you do find yourself like maybe prescribing a new medication, pick one that you're really comfortable with, that you've got to look into more, and try and stick with that one as much as possible than trying to come up with different ones all the time. If there's someone who, this has been long-standing, they might have an old prescription of something that they've used before, but a lot of these different inhalers for COPD work differently, and so one thing that I have done is I carry the demos of some of the most common ones, and I show them how to do it themselves. So that way they understand, okay, this is how it works. So if you're going to go home with this new prescription, this is what it looks like. This is how you do it correctly. With COPD exacerbations, if we have a baseline pulse ox, that's really helpful. If we don't, we want to try and think, okay, if they're relatively new with this, or if it's unknown, they're not known to our system, or I can't find any records within the last few years. If they have a lower oxygen saturation, we want to titrate them up to 88, 92%, but also, seriously consider about keeping them, because if we don't have a comparison, we don't know how severe it is. Again, we're going to do the albuterol, the ipratropium, the steroids with it, antibiotics in the right situations, but non-invasive inhalation, so that bilevel might be something that you have to do. Again, think about it if they have acute CO2 retention. the settings might vary a little bit. So you might start out with like an IPAP of 8 and EPAP of 5. So 8/5 is usually the way we describe that. And again, antibiotics, it gets tricky. So when are you going to do it? When are you not? Obviously, if it's someone who's going to need mechanical ventilation, okay, they're on the sicker end. We want to be cautious with that. They have signs of pneumonia, or they have something else that would be suggestive of, you know, a true risk of bacterial infection. When you do choose antibiotics, there are a couple of different options. So trimethoprim sulfamethoxazole, that's Bactrim or Septra, you know, that's one option. There are others as well, but avoid, when you can, fluoroquinolones, just because we talked about they do carry a significant side effect profile. Hospitalization, I have a lower threshold with hospitalization in these patients, again, especially if it's a significant alteration from baseline and they have a known long history of this, especially if they've been into our department recently over the last few days. These bounce backs can get really bad really quick. Otherwise, you want to make sure that we have some way of ensuring follow-up with them. If they don't have primary care, try and get them with someone. There's usually someone in your community, hopefully, that you can set something up with. And if not, have them come back to you, just to have some way of having someone who can reassess and make sure that they're doing it correctly. Also make sure that they're using their inhaler correctly. Like we talked about, so many bounce backs I see, they've had no training in how to use their inhaler at all. So otherwise, we'll move on to the next one.
All right, I'm back, and we're shifting gears back to MSK, and this time we're going to talk about the hand and the wrist. And I actually get kind of excited to see hand and wrist complaints. I'm excited that the exam is going to be external, that it's going to be focused, and a very focal exam, very different from dizziness or generalized weakness. But I also approach these patients with a healthy dose of caution, because I know that missed hand and wrist injuries can really lead to significant long-term morbidity in the form of grip weakness or chronic hand pain or loss of work. So I am quite cautious with these patients. Today we're going to go over the wrist anatomy and approach the exam, and I'm going to spend a little bit more time doing this than I did with the knee because it is so complex. So let's start with the actual anatomy of the hand. When we're talking about describing the fingers, I like to avoid numbers and instead focus on naming the fingers. So the problem with numbers is this the first finger? Is this the second finger? Is the thumb a finger? I just stay away from that by calling this the thumb, index finger, middle finger, ring finger, and small finger. Same with the sides of the fingers and the sides of the wrist. Is this medial in this position, medial in this position? I don't know. It can get quite confusing. So instead, anything closer to the small finger is ulnar. Anything closer to the pinky, to the thumb is radial. So this is the radial aspect of the index finger, the ulnar aspect of the index finger, the ulnar aspect of the wrist, and the radial aspect of the wrist. Back of the hand, dorsal. Front of the hand is palmar or volar. And then when we're talking about the joints of the hand, we have all those interphalangeal joints. And these four fingers, we have two of them, the DIP, the dorsal IP joint, and the PIP, the proximal IP joint. And the thumb, you only have one, so it's just the IP joint. And at the base of all the fingers, you have your MCPs. So when we think about the approach to the exam of the hand, the first thing that comes to mind are these three main nerves, the ulnar, the median, and the radial. And for every one of these nerves, we have to do both a sensory exam and a motor exam to ensure that both components are intact for every single nerve. So how do we assess sensation for each of these nerves? I think the easiest thing to do is to pick a very distal point in the distribution of that nerve and see if sensation is intact there. And if it's intact there, you kind of presume that the rest of the nerve is intact. So for the radial nerve, where I feel is over on the dorsal aspect at the anatomical snuff box. For the median nerve, the volar aspect of the index finger. For the ulnar nerve, the volar aspect of the small finger. And my little pearl here is that I don't ask, can you feel this and can you feel this? I specifically ask, does this feel normal? Because patients might say, yeah, I can feel that, but you're not going to pick up some of these subtleties and loss of sensation. So radial, median, ulnar. When we talk about the motor innervation of the hand, the median nerve is thought of as the tea drinking nerve. And why is that? And I don't think anyone drinks tea this way, but for those that drink high tea, it's responsible for pincer, wrist flexion, elbow flexion, and pronation. I don't know, I don't drink tea this way, but it's the tea drinking nerve. When you test this, most people are going to do this okay sign, and it's really important that when you're having patients make this sign, the IP joints are flexed. This is an abnormal median nerve. This is the correct median nerve exam, and then you're kind of going to pull and have them resist. For thoroughness sake, I also have them touch the thumb to the small finger. For the ulnar nerve, there's two ways to really assess this. This is testing the intrinsic muscles of the hand. You can either have them cross their fingers, or you can have them spread their fingers very wide, like jazz fingers, and then sort of resist you pushing the fingers together. And the last one is the radial nerve, which is responsible for most of the extensors of the hand and wrist. And so again, an easy thing to do is just have them stop traffic. If they're having a lot of wrist pain because they have maybe a radial fracture, then you can also just do a thumbs up instead. One note about the radial nerve is when the radial nerve is injured, it can result in a wrist drop, and this is an important stroke mimic. I work at a stroke center. I'm often called to examine patients and determine is this a code stroke or not, and I can't tell you how many times I've been called to assess a patient who maybe fell asleep and took a nap on a sofa or over a chair, and while they did that, their radial nerve was compressed by the chair, and they woke up, and all of a sudden now they have hand weakness. And so EMS rushes them in. I get called to assess a code stroke, and when you go to examine them, actually their grip strength's intact, and they're able to flex, they're just simply not able to extend at the wrist. So just be cautious of this when you're thinking about strokes. Let's move into the tendons of the hand. So on the dorsal aspect of your hand, you have all the extensor tendons. And my note here is that if you can feel your hand, you note that there's really not a lot of padding on that dorsal side, right? It's just this thin skin, and then right under there are the extensor tendons, so they're really at risk for injury. On the palmar side, we do have a lot of padding, but unfortunately this flexor tendon system is a lot more complex, more complicated, and what makes it worse is that for every single digit, there are 2 flexor tendons. So we have to be really, really thoughtful in our exam so we don't miss injuries to one or the other. So there's 2 flexor tendons. There's a flexor digitorum profundus, profundus meaning deep. It runs all the way down to the DIP and is involved with flexion at the DIP. Then there's the flexor digitorum superficialis, FDS, and that is responsible for flexion at the PIP. So when you're examining the flexors for every single finger, you have to examine each one of these flexors independently, and the way you do that, and hopefully maybe we can all do this together, we're going to examine the ring finger. So if I want to assess the FTP, that flexor digitorum profundus, or flexion at the DIP, I need to take the FDS out of the picture. So the way you do this is you clench your PIP and you hold this very stiffly, don't let them bend there, and just ask them to bend the finger. And you can see that they bend at the DIP, correct? So assessing the FDS is a little bit more challenging and not as intuitive. And for this one now, what you're going to do is you're going to take all the other fingers out of the picture. So I'm going to hold down the small finger, hold down the middle finger, hold down the index finger, and now I'm going to ask them to bend their finger. So for all of you doing this, can any of you bend at the DIP? None of you, right? And so because of that, now we know we've effectively taken the FDP out of the picture and we're just assessing the FDS. So that's the way I assess flexor tendons on every single one of the fingers. This is a quick review again of those 3 nerves. So is this normal radial? Is this normal median? Is this normal ulnar? And then for the radial nerve, sort of stopping the bus or doing a thumbs up, median nerve is flexed IP joints and touching also the small finger, and the ulnar nerve, those intrinsic muscles, either crossing or jazz fingers. So let's move into actual pathology. The first thing we're going to talk about are the tuft fractures. These are very common injuries. This is a fracture of the distal part of the distal phalanx. This happens when you close your finger in a door, you drop something really heavy on your finger, and luckily these do just fine with supportive care. There's really not a whole lot to do here, and I will tell you that some of these are open fractures, right? When you drop something heavy on your finger, you can sustain a laceration as well. This is not the kind where you're calling ortho and you're like, you need to take them to the OR for a washout and IV antibiotics. It's even controversial whether these patients even need oral antibiotics. So use your best judgment. Maybe if they have diabetes or is a really dirty crush injury, you can send them with that. But for the most part, they can go home and they will heal just fine. Moving a little bit more proximal in the hand, now we're talking about injuries at the DIP joint, and this is called a mallet finger. I personally, this doesn't help me to remember the mechanism, so I refer to it by its other name, the baseball finger. And what happens is you put your hand out to catch a baseball or a basketball that's thrown at high speed, you mistime things, and then that basketball or baseball hits your finger really, really hard, and you hyperflex at the DIP, and when that happens, that extensor tendon snaps. As it snaps, it may pull off a little portion of bone, so you may see an avulsion fracture on an x-ray, but you may not. And the patient will come in and they'll have an inability to extend at the DIP, and if you miss this injury, they can end up with this swan neck deformity that you can see here in the second photo here. Luckily, the treatment is quite simple, and what happens is they need to be splinted in hyperextension at that DIP, and what's important is when you're splinting them, don't immobilize the PIP as well. Don't keep this in hyperextension because the PIP can get really stiff really quickly. Just immobilize the DIP in hyperextension, and then when the patient leaves, you're telling them, you need to keep this on for 6 weeks. I don't care if you're taking a shower, I don't care if you're playing chess, or if you're going in the hot tub or making a drink, keep it on, because the moment you take it off, the clock starts again, and you need to do this for 6 weeks in a row. And it's really only those ones with really large interarticular fractures that are going to need orthopedic intervention, otherwise good splinting is sufficient. So when we were talking about those tough fractures, a lot of those are associated with subungual hematomas, and that means blood accumulating in that very tight space between the nail and the nail bed. And there's not a whole lot of space there, so any blood that accumulates there actually causes quite a bit of pain. Expressing and draining these is really, really satisfying. It's one of those things like abscesses where you can make a patient feel a lot better. And the way you can do this is, or there are multiple ways. If you have electrical cautery in your hospital, great, that's what I use. It's the simplest way to do it. You put the cautery over the area of maximal hematoma, let it sit there, heat up, and over time it bores a hole, and then the blood sort of starts spurting out, and you can express all of it, and the patient can go home. If you don't have that, then the alternative is to take an 18 gauge and make a hole yourself. Again, not putting too much pressure, but just twisting back and forth until a hole develops. This is not usually painful, so I don't preemptively do a digital block, so I think that's more painful than any of the procedures we're going to do with either electrical cautery or with the 18 gauge. Along the lines of these fingertips, I think I'm looking around and there's probably some people here that have been practicing for over 10 years, 10, 20 years or so, and those of you who have, remember a time when every time that you suspected a nail bed injury, you would have to take off the entire nail. You'd have to do this really complex laceration repair of the nail bed where you weren't sure if you were actually even repairing it correctly or not. Then you'd have to put a nail back on. And what we're learning actually when it comes to nail bed injuries is that less is more. If the nail is sort of in its typical anatomical location, I leave it. I don't do anything with it, and the patient will do just fine. If it happens to be that the nail is quite avulsed or it's transected and a nail bed repair is indicated, then I take off whatever nail is left, and then either I repair with absorbable sutures or more likely, because it's easier, I use Dermabond. And then the important thing is when you're sending these patients out, you have to splint open that area underneath the cuticle where the new nail is going to regrow. If you don't, that can adhese down and really impair the regrowth of that nail. So when you're splinting, you either can use their own nail if it's intact, or you can use the wrapping of suture material, but put something in there, and then tell them not to expect a new nail overnight. It's going to take about 4 to 6 months, probably closer to 6 months for that nail to regrow. Trigger finger is a non-emergent diagnosis that you're never going to miss in the ER. Patients are going to come in, they're going to say, Doc, my finger keeps getting caught in this flex position and I have to wrestle it back to extension. It happens over and over again. And what happens here is there's some sort of scarring or a knot that develops along the flexor tendon sheath that just prevents you from doing that nice smooth motion of extension and flexion. More commonly, this affects the ring finger, or now recently we're seeing it in the thumb, and that's presumed to be because of texting. I don't remember, you remember those devices where you had to press a button 5 times just to get to the letter that you wanted. So the thumb is another one that you'll see this in. Really, the treatment is supportive, and you can let patients know that if it doesn't get better on their own, they can go see an orthopedic doctor for potentially a steroid injection of the tendon sheath. So now we're moving into the realm of infections. And the first one we're going to talk about is the paronychia. And for any of you that are nail biters or hangnail developers like I am, you've probably experienced lots of these in your lifetime. I certainly have. And so these are infections around the nail itself involving the nail fold. If there is erythema only and no pus, these do fine with just warm water soaks alone. I send them right out and tell them to soak their finger in water. If, however, you start to see pus develop, these do need to be drained, but this is different from your typical IND. I'm not cutting through the skin over the area of maximal purulence. Instead, what I'm going to do is do a digital nerve block, get that finger nice and numb, and then you'll kind of slide either a scalpel or an 18 gauge along the nail and just pry open that nail fold. You're not cutting anything, you're prying it open, and as soon as you do, pus will just come running out. And I'm always shocked by how many cc's of pus are hiding underneath there when superficially it doesn't look like there's all that much. Once you've done that, that's pretty much the treatment. So they really don't need oral antibiotics. Again, use your best judgment. If someone's immunocompromised or they have diabetes or poorly controlled diabetes, you can consider sending them out with some oral antibiotics. Felon, on the other hand, this is an infection of the pulp of the finger, the pad of the finger, and this needs a good IND and needs good IND and breaking up of the infection because there's a lot of septations in that part of the finger where infections can go to hide. So IND, oral antibiotics, home. What you don't want to cut into is this. So at quick glance, it looks like this patient has a couple, pustules or so on the pad of their finger, but no, this is a herpetic infection. And you may wonder, who gets herpes of their finger? And it's those people that are making a lot of contact between their fingers and their mouth. So that's kids, and that's health professionals specifically in the dental industry. So I don't think I have to remind you, but wear your gloves when you're examining someone's mouth. These, if you cut into them erroneously thinking they're a bacterial infection, you can actually do more harm by causing a herpetic myositis. So instead, what you want to do is make the clinical diagnosis and send them out with oral antivirals. Now, while those 3 patients can all go home with the treatment that we've decided, this patient is an emergency. And this is an emergency that needs to be seen by orthopedic surgeon, flexor tenosynovitis. So what is happening here? There's been some laceration or puncture wound along the volar aspect of that finger that has gone deep enough such that bacteria has entered into the flexor tendon sheath. And once it gets there, it sort of runs up and down that superhighway of a flexor tendon sheath and spreads through the finger rapidly. It can actually start to spread into the deep spaces of the hand. So when we think about this diagnosis, we think about Knavel signs. You can memorize them, but they're all very, very intuitive. So you have an infection of the entire flexor tendon sheath. That finger is going to be swollen all throughout, and they're going to have tenderness along the tendon sheath. That makes sense. The next is that tendon is really angry and inflamed. It's not going to want to be stretched at all. So it's going to hold itself, and they're going to hold their finger in flexions so that they can avoid stretching that inflamed tendon. When you extend it, you're going to cause pain to them. So those are the 4 Knavel signs. If you have suspicion of this is not a send them out with oral antibiotics and have them see a hand surgeon the next day. This is I need the orthopedic surgeon to come and see this patient today within the next couple hours. And what they'll do, it's always really gruesome to me, is they really fillet open that entire finger and explore the infection and usually admit them for IV antibiotics. Okay, so now we're more in the fracture side of hand pathology. And the first one, and the common one that we see, is the boxer's fracture. So this is a fracture of the neck of any of the metacarpals. We think of this a lot, though, when talking about the small finger. And this is a misnomer, right? True boxers aren't leading with their small finger. They're leading more with their index finger. So this is an amateur boxer's fracture. This is more seen in patients whose team is lost and they've punched the wall angrily or something like that. So when you see this fracture of the neck, often they're angulated. And just know that there is some degree of acceptable angulation depending on the finger that's affected. So for your small finger, that's 40 degrees, the ring finger 30 degrees, middle finger 20 degrees, and the index finger is 10 degrees. If they're a lot more angulated than that, then sometimes I'll try to reduce them in the ED, but for the most part, if there's just a little bit of angulation, that's well tolerated and they can be seen by an orthopedic surgeon. What is not allowed and not acceptable is malrotation. And so what is malrotation? If all of you take your hand and you fold over all your fingers, you can see that they sort of line up in parallel and all point to the thenar eminence, right? That's a normal, all the fingers are normally rotated. Now in malrotations, when you ask patients to do that, say it's the small finger, maybe that small finger just sticks out straight instead of folding over and pointing to the thenar eminence, or maybe it folds under the rest of the fingers abnormally, so they're not in parallel. And if you suspect that, then actually this patient will need to have their hand manipulated by an orthopedic surgeon when they're seen in clinic. One little note of caution, always look for contact with oral flora, with a human mouth, because if there's any break in skin caused by human teeth, you need to give them antibiotics and need very close follow-up because the human mouth is filthy and fight bites happen so quickly. Metacarpal fractures involving the rest of the metacarpal are very similar. I look for a degree of angulation and look for malrotation, and that's essentially, they're otherwise treated the same. So we talked about the swan neck deformity that involved an extensor tendon injury, a missed extensor tendon tendon injury at the DIP. Now we're going to talk about a deformity that occurs when there's a missed extensor tendon injury at the PIP. So what happens at the PIP with the extensor tendon is it splits into 3 parts. There's the central part, the central slip, runs right down the dorsal aspect of the finger. That is responsible for extension at the DIP. Then there are 2 lateral bands, each running on the 2 sides of the finger, the radial side and the ulnar side, and those are responsible for extension at the DIP. So when there is either penetrating or blunt trauma to the dorsal aspect of that PIP, you can potentially injure the central slip. But when you do if you do a very cursory exam, the extension might still be intact because you still have those lateral bands there. They're going to come in, you're going to do a cursory exam, you're going to send them home, and then weeks later, they're going to develop this deformity because over time, those lateral bands are going to tighten, and now there's nothing keeping that PIP in extension, so the PIP will be flexed and the DIP will be extended by those lateral bands. So you don't want to miss this injury, and the way to assess a central slip is to do a modified Elson's test. This is something, again, I would write down and look up because I think it's best seen visually and I'm too far away from all of you, but I do this on all my patients who have trauma to the dorsal aspect of the PIP, and I document that in my note. Talking about fractures of the thumb, obviously the thumb is very important. Luckily, these fractures are rare because the thumb can tolerate quite a bit of range of motion. Proximal thumb fractures come in 2 main varieties, Rolando's and Bennett's, one more severe than the other. I think of Bennett benign, so Bennett is the less severe form, but really these are going to be immobilized and sent out and most often will need operative intervention. Now, what if you have a thumb injury, but the x-ray is normal? Another structure to consider being injured is the ulnar collateral ligament. So on the ulnar aspect of the MCP of the thumb, you have the UCL, this ulnar collateral ligament. And if you're skiing, and your pole gets stuck on something, and all of a sudden there's this tremendous backwards force right here at that ulnar collateral ligament, you can have injury to that ligament. Sometimes it pulls off a chunk of bone, and then you have an avulsion fracture, and the diagnosis is clear. But otherwise, you have to do a specific test of laxity of that ligament to make the diagnosis. So the way I do that is I stabilize the other thumb on the radial aspect of that MCP, and then pull the thumb again, stretching the ulnar aspect of the MCP, and I have to compare it to the other side because otherwise everyone's thumb feels loose to me. So if I suspect that, then I'm going to immobilize them and send them out to an orthopedic surgeon. Carpal tunnel syndrome, we see a lot, is an emergent diagnosis, but this typically occurs when patients complain of pain and paresthesias in that median nerve distribution because the median nerve is compressed. They classically will complain that this pain is worse at night. Why is that? It's not like the anatomy is changing, the bones are moving or anything. And what happens is during the day, you're keeping your hands in sort of a neutral position, but at night when you're subconscious, I see someone doing it, you're sort of, sleeping like this, and then all of a sudden now you're sleeping in positions where there's increased compression of the nerve, and that's why you have pain that's worse at night. Really, the treatment is supportive. You can see if they want to try to buy some of those wrist splints at CVS, but ultimately if the symptoms are severe or progress to weakness, then they may need a tunnel release by an orthopedic surgeon. Okay, so now we're down in the wrist, and I'm going to advise you to have a healthy dose of caution when examining wrists and to really try to do everything possible not to put the diagnosis of wrist sprain in your chart, or at least not to do that without considering these next 4 diagnoses, these wrist sprain mimics. So the first of these is the scaphoid fracture, and we all pay a lot of attention to this fracture, and one of the reasons is that the blood flow to the scaphoid is very strange. It comes and it enters in the distal portion of the scaphoid and then runs proximally. So if you have a fracture across the waist of that scaphoid, the distal portion is going to be fine. It's still going to get its blood flow, but that proximal portion is going to undergo avascular necrosis, and the patient's going to be left with chronic debilitating pain. So the issue with this is that if you see the fracture in x-ray, you're done. That's great, but many of these hide and are radio-occult on their first visit. So if we have a high enough suspicion, we need to mobilize them and have them seen again in 7 to 10 days for a repeat x-ray and exam. But how do you decide if you have a high enough suspicion? There's a couple exam maneuvers you can do. So I feel over the anatomical snuff box for tenderness, and specifically I do this in ulnar deviation to really expose that scaphoid bone. You can also jam the thumb, axial load the thumb, and that's sort of jamming the thumb into the fracture itself. If you turn over your hand, supinate your hand, you can feel just proximal to the thenar eminence. There's a bony prominence. That's the scaphoid tubercle. So you can feel for tenderness there. And then 2 other ones I'm going to add that are not covered here are resisted supination. So I have the patient hold their arm in pronation, motion, I grip firmly, and then I ask them to try to supinate, and if that causes pain, I'm concerned. And the last one, which is kind of surprising but has a quite high likelihood ratio, is the clamp sign. And what it is if I ask you, where's your pain, and you're not pointing here, you're not saying it's around here, but you actually approach your hand and you describe your pain like this, in a clamp motion, that's actually really concerning for a scaphoid fracture. So if I see one of these, again, I'm going to immobilize them and send them out, knowing, unfortunately, that a good proportion of the ones I send out are going to be immobilized unnecessarily and miss work days unnecessarily, but you just don't want to miss this diagnosis. All right, let us move on to the scapholunate dissociation, which is another wrist brain mimic. And this is not a fracture, this is a ligamentous injury. So there is a ligament that connects the scaphoid and the lunate bones. If it's injured, it can cause widening in that space between the two bones. It looks like a gap between front teeth, and many famous people have been associated with this fracture, like David Letterman. But sometimes it's not obvious on your x-ray. And so if you really have high suspicion for this, you might need to send the patient back for a specific view called a clenched fist view. And what happens there is you have the patient go over and get the x-ray while they're clenching their fist, and that clenching puts stress on that space there on the ligament. It can make the widening more apparent. So what makes you have more suspicion for this injury? If you take a look here, I want everyone to try to find Lister's tubercle. So if you have your hand here in pronation, you can feel a clear bony prominence of the ulnar styloid and feel the prominence of the radial styloid. And then as you sort of feel along the dorsal aspect of that wrist, there's only one other prominence between the two. It's a little bit more distal to them. And that prominence is the scaphoid, is the Lister's tubercle. And if you move just distal to that, you fall into a little pit. That little pit there is right where you're going to palpate to assess for tenderness at the scapholunate ligament. And later I can try to show this on you individually if that wasn't clear. The last one to consider, oops, sorry, I want to go back here. The last wrist mimic to consider are the lunate and perilunate dislocations. When I'm looking at a lateral x-ray of the wrist, there's only a few things I'm looking at. And one of them is this. I want to see that on top of the radius is that moon-shaped lunate, and on top of the moon-shaped lunate is the cup capitate. It has to go radius, lunate, capitate. So if you look here on the right, you can see here, okay, great, we have a radius. And then what's happened to this moon? It's totally fallen off, right? This is a lunate dislocation. Then on the left side, you have the radius, and you have the lunate is still sitting there on top, but this capitate has fallen off and dislocated dorsally. And so these are not a splint and send out and see orthopedic. These need to be reduced in the ER, and they also need a really good pre and post reduction neuro exam because that median nerve is hanging out there right in that area just waiting to get injured. All right, we're almost done with this lecture. One of the things I want to emphasize to you is you can do a really good job making one of these diagnoses, avoiding, these wrist-brain mimics. But if you do a bad job splinting, you can actually make their symptoms worse, increase stiffness, and take a non-operative injury and make it operative. So you don't want to splint them like this, straight across like a board. What you'd rather do is splint them in a position of function. And how that's described is the position you take if you were holding like a beer can or a wine glass or something, a little bit of gentle extension at the wrist, and then all the rest of the MCP and IP joints are a little bit flexed. You can always pull up this diagram to reference the angles, but just make sure you're not splinting them straight in stiffness and undoing all the hard work you did to make the diagnosis. The very last topic is digital nerve blocks. These are incredibly fun and easy and effective. There's two main approaches. One is dorsally and one is volarly. I'm going to first talk about the dorsal approach. So we have the digital nerves both on the radial side and the ulnar side of all of our fingers. And on the dorsal approach, you're injecting at the base of the finger and you're infiltrating around the digital nerve on either side. It's two injections. Inject, infiltrate, inject, infiltrate, go back, chart, wait like 10, 15 minutes, come back and the finger's numb. I am a convert and exclusively do this other approach, this Palmar approach, and the reason being it's a single injection. People hate to have needles coming at their fingers. They get really squeamish. I would feel similarly. So I do this instead. There's two different approaches. You can either inject at the distal palmar crease. You can see where that line runs across your palm. Or what I do to keep things simple is I inject right where the finger meets the palm, right in that crease there. You're going in at a 45-degree angle, hitting the flexor tendon sheath, putting in 2 cc's of fluid, and that sort of diffuses down the flexor tendon sheath and bathes the digital nerves, and I've never had a problem with that at all, and it's a single injection. Regardless of whatever approach you decide to take, I would say important principles are don't go through infected skin. So if you see erythema, try a different approach to numbing that finger. And the other one, and this is really particularly true for the dorsal approach, is when you're injecting on the two sides, don't go back and forth trying to find your trajectory, because you can actually transect or do damage to the nerve itself. You just want to go in once, put in your CCs, let it infiltrate. If you feel like maybe you're in the wrong spot, you can rub around and see if you can move that anesthetic around a little bit, but don't go back and forth in a sawing motion. And that's it. That's the hand and the wrist. Oh, and it's break.
Good afternoon. Pediatrics. It's about the kids who come in who are sick with God knows what. So the definition of a fever is 100.4 rectally, 38 degrees centigrade. And once you discover a kid has a fever, you're going down the infectious disease pathway. Afebrile, you tend not to go down there, not 100%, but fever, absolutely going down that pathway. One of the issues that come up is many parents, especially new parents, are very reluctant to take the kid's temperature in the butt, which is how you're going to define the 104, 100.4 rectally. So there's this idea about fever phobia and the idea that I got to measure quickly, but I don't know how to do it. Maybe I'll get one of these guns that they sell in the drugstores, and there's, what if I put it in the axilla? Maybe that'll work too, because I've seen people do that. And the idea basically is to kind of get them to cool their jets about the severity of these kinds of things and realize that it's not a big deal. And you might have to help them to teach them, maybe the family doctors would, how to do a rectal temp in an infant. But all these other things are much less reliable, particularly axillary temperatures. I mean, if you get a fever on an axillary temperature, great. If you don't get a fever on an axillary temperature, it doesn't mean the child doesn't have a fever. So there's all sorts of these attempts to find out how to have fever and how to do it. But there's a lot of inexact methods, and we should probably try to stick with the gold standards where we can. The fact of the matter, too, is that kid will come in and parents will say, the child had a fever at home, I think, because I'm not so sure how to use that thermometer thing, but I think they had a fever at home. Or the child felt warm, I think that was a fever, so I gave them some Tylenol. So there's always this issue of the child's afebrile now. Was there a fever before? And that's particularly important in infants who are 1, 2, 3 months of age, because if they have a fever at home and nothing in the ER, we have to act as if they had a fever at home. So the general rule is if they thought the patient had a fever at home, we're going to treat them as if they have a fever, even though they don't have a fever in the emergency department. And yes, giving the antipyretics just muddles the matter all the more. Practices that reinforce fever phobia is, hey, listen, let's give alternating Tylenol, acetaminophen, and ibuprofen. The American Academy of Pediatrics says specifically, don't do that. First of all, it suggests that fever is really a serious kind of condition that we have to treat it aggressively with 2 medicines and a complex pathway of alternating. And it also gives us the opportunity to get screwed up on the doses and what was the last dose, and so there's some opportunities for dosing errors to occur there. So I would ask that you not do that because of the message that it's thought to send. Febrile convulsions tend to run in kids who are prone to febrile convulsions. Febrile convulsions run in families. I mentioned before, like 2% of them may result in epilepsy, but most of the families where febrile convulsions are frequent, they don't come in with a lot of anxiety because, my cousin had it and then my uncles had it and those kinds of things when they were kids. So we don't worry too much about febrile convulsions, particularly when they're running around after it's over. Usually they come in, they are just fine. They're not seizing when you see them. If they are, that's probably not a fine child at all. So the primary idea of giving antipyretics is to make the child feel more comfortable. In fact, the idea of having fever, some people suggest that this is a normal biologic process which is involved with destroying bacteria from the iron metabolism and some other kinds of things that are thought to help destroy bacteria, so that it is, and that reducing fever is a not a good thing to do. And you've heard people say sweat it out kind of thing. I don't know that you would have a person necessarily do that. You know, if it's 101 fever, it's probably no big deal. But the idea is, if it's 103, 104, make the child comfortable. By far, the most common cause of fever is a virus. Even if it's 104, by far the most common cause of that fever is a virus. But as the fever goes higher and higher, 104, the proximity of bacteria being a cause goes up disproportionately. So it's more likely at 104 that it's still a virus, but the likelihood of a bacterial infection is a little bit more than it was down here when it was 102. Here's a newspaper clipping from the American Academy of Pediatrics talking about this fever phobia business. And one of the things that is important is maintaining fluids when these kids got a fever and letting mom and dad know how important that is. Remember, I think it was a day or two ago, the 22-pound kid is a 1-year-old. A 22-pound kid is 10 kilos. The maintenance dose of fluids for a 10-kilo kid is 100 ml per kilo. So remember, that little kid who is sick needs to drink a quart of water or a quart of any liquid. If you put that into perspective, what if you had a 210-pound guy? How much water would he have to drink to be compatible with a 1-year-old? He'd have to drink 10 liters of water. 10 liters of water for an adult male of that size would be inconceivable. So you can see how easily kids get behind on their fluids when they get, and when they have a fever, they're more metabolically active, they burn up and need more water in the process. The idea of do fevers cause brain injury, you know, that may be a kind of an underlying question on the part of the parents kind of thing, and maybe you can preemptively say, you know, I know Johnny's got a 104 fever, but this really hasn't been shown at all to cause brain injury, so he'll be fine. Obviously, we're looking for abnormal behavioral lethargy. You know, in pediatrics, the easy pediatrics is the obviously sick kid. The hard pediatrics is the apparently well child. It's very common in the United States, and we are often chastised in the medical literature because we start IVs on kids who have mild to moderate dehydration. And AAP says, please don't do that. Please use the sippy diet with some ondansetron. It shows the parents that you can do this at home, so that, and you can start early on it, and that it will generally work. And you have them do that in the department. So don't have a nurse do that. You have the parent do that, 5 mLs every 5 minutes kind of thing. And gradually they'll see that it's working, and they're taking in a fair amount of fluid in the process. Starting an IV is painful, makes the child fearful of coming to the emergency department, creates the impression that there's something seriously wrong, and drives up the costs. I mean, that $1 bag of saline soon to be magically turns into a $100 bag of saline. So, given the fact that an IV has been put in more or less needlessly, do any of you use IV acetaminophen? Anybody? 1, 2, 3. A fair number, actually. Let me show you a few graphs on this. This is a study looking at IV and PO acetaminophen. Basically, it said that IV acetaminophen works a little bit faster than PO, a little bit faster. And the conclusion is at the bottom. A single dose of IV acetaminophen is as safe and as effective in reducing endotoxin-induced fever as PO. Safe and as effective. Well, that doesn't say it's superior. It says is as safe and as effective. Here's the graphs, and this is a trick that they do in science all the time. If you notice the differences in the temperature on the left side of the graph, they're very, very small, so that it distorts the plot so that one drug looks highly superior to the other, when in fact the real difference in temperature is insignificant, and certainly clinically insignificant. So this is a trick, which is commonly seen, and it's called, it's not cheating, it's just kind of like a trick to make you think that it's more effective than it is. When you look at the small incremental changes in the temperature that they're using on the vertical axis. This is also showing that, in fact, IV, the blue line, is a little bit faster. But is that clinically important? There's always this distinction between statistically important and clinically important. Things that could be statistically important may not be clinically important at all. So, plus that stuff costs $35 a gram, and it may be even more now. Obviously, immunizations is what it's all about, and it has changed the face of the approach to children who have fevers. Look at a few cases of meningococcal meningitis. Hardly 400 in the United States in 1 year. In the past, it was the quest for pneumococcal sepsis. That was the cause of fever that everybody was concerned about. And what we used to ultimately did was we would see a source unknown fever kid and think, did this kid have pneumococcal sepsis or not? He would get, or she would get blood culture drawn, shot of ceftriaxone. If the blood culture is positive, then they would get further evaluation. If not, the ceftriaxone wasn't considered a big deal. So we had a 55-gallon drum of this stuff in the department with a Lorlac on it, and all these kids were leaving the department with shots of ceftriaxone. Subsequently, when children got vaccinated against pneumococci and all of the nasty strains of it, then basically that approach went away because pneumococcal sepsis, which was the most common cause of bacteremia in those days, was cured not by the doctors but by the immunologists. Those are the ones who have made the biggest impact in infectious diseases, is by far the immunologists. This is just a graph of what has happened with pneumococcal bacteria. The 13 polyvalent vaccine being given, it is gone from night to, it's remarkable. And this was done by the immunologists. Finding the source of fever is treatable in this little kitty. By far the most common cause of bacterial fevers in children is in the urine. And so the idea is we're going to focus there, but we're going to look at the child in total. We're going to look in the mouth, and we're going to look in the ears, and we're going to listen to the lungs, and we're going to feel the belly, and what's the skin feel like? Are there any ecchymoses or rash here or there? Joints are moving, everything fine. You did that physical exam in 2 minutes, and everything was looked at. Now, there is a protocol for children under the age of 3 months who have a fever that is actually, the American Academy of Pediatrics just released guidelines for the treatment of the first 3 months of fever in infants. Brand new, so you might want to look up that article. So the age of the kid is the primary driver. Once they get 3 to 36 months, which the majority of kids are, then we think that we can be more effectively clinically examine them. When they're 1 month old, are you comfortable that this child is acting normally or not? And I'm not so sure. So in those cases, they basically say, do it all. 2 month old, is there some way for us to determine low risk versus high risk kids in that age who appear well? And that's what people spend a lot of time on in terms of the Rochester criteria, the Philadelphia criteria, et cetera, trying to ascertain who's low risk, who's high risk. And it's all about avoiding lumbar punctures, actually. That's what it comes down to. But then again, that's not an unreasonable thing to do because I'm concerned about our ability to do lumbar punctures as more and more people never really see bacterial meningitis because it's been so effectively dealt with. It's still out there, but not to the frequency that it was before. So how many people have gotten comfortable with doing lumbar punctures is a question. So we're going to skip the kids less than 3 months. We're going to move on to the older kids. This is from the American Academy of Family Practice, and it's a chart which I think is blown up in your book that you may want to look at in terms of a pathway. But I want to focus on something very specific because urine is where it's at. And so the kid is basically thought to have a urine infection, yes or no. Why do we call UTIs in kids UTIs? Why don't we call them pyelonephritis? You ever hear of kids having pyelonephritis? We know the difference. Bladder infections are called bladder infections, cystitis, and upper tract infections are called pyelonephritis. Well, lower tract infections don't cause fever. Upper tract infections cause fever. So why don't we, you never hear the word pyelonephritis in kids. It's called UTI. And I believe that when we say UTI, we're thinking of lower tract infections because lower tract infections are much, much more common, and we see them probably, 10 times before we see one pyelo. But in any case, I think that we should be more comfortable starting using the correct term here so that it makes it clear that this is a more serious entity that we're dealing with, not a bladder infection. In 2011, and affirmed in 2016, the American Academy of Pediatrics came out with some stuff regarding UTIs. They say the overall prevalence of a UTI in a source unknown child is 5%. 1 in 20. 1 in 20 of the kids that you see, source unknown, they think are going to be pyelonephritis. Although they never use the term. Everybody's using the term UTI. It's an easy thing to abbreviate, but I also think it denigrates the significance of this disorder. So if the overall prevalence is 5%, we may be able to even risk stratify. In that 5%, like, which is the likelihood? Is it 2% in this group or 4% in that group kind of thing? And AAP has come out with some guidelines in that. We'll look at it in a second. If the kid looks sick, then basically the idea is you get a urine culture, you get a blood culture, and then you treat. So it's not a big deal. And how do you get a urine culture? You do a cath urine or suprapubic aspiration. That's the only options. No bag urine. Bag urine is just not acceptable. The contamination rate is up to 88%. So no. So a culture is a cath. Now, how do you get a urine out of a? See, there's also the idea of a screening urinalysis. If screening urinalysis is negative, then you don't have to go any further, kind of thing. So how do you do get a urine out of a 1-month-old or a 2-month-old, or even an older child who doesn't really pee on command, kind of thing? I've dubbed this the chicken technique. You hold the kid underneath the arms like a chicken. You're familiar with that? Chicken. Then this is a 4-person technique. Well, you'll need to shut the emergency department down while I do this. Number 1, we have the chicken holder. Number 2, we have the chicken rubber. You rub over the lumbar area in a slow. In the northern hemisphere, it's clockwise. In the southern hemisphere, it's counterclockwise. That's number 2. Number 3, you have a little woodpecker-like person on the front tapping the bladder at a rate of 100 per minute. That's the woodpecker job. And number 4 is the catcher. And look what happened in this one case. 69 of 80 kids peed within 5 minutes of doing this. And it's kind of neat because, if you dip a urine, and that urine is negative for nitrates and negative for leukocyte esterase, and the kid hasn't peed in a half hour or an hour, then it's highly unlikely that this child has a urine infection. Nitrate test is the most important by far. It is the most sensitive and specific of sign of infection in terms of a chemical test. Leukocyte esterase comes along probably a little bit later, but nitrates is where it's at. False negative nitrates is from dilute urine, so the kid just peed, and now you're looking at the urine that has been generated in the last half hour, so it hasn't had a chance for the nitrates, the bacteria to change the nitrates to nitrites. So that's one source of a falsely negative nitrate test. And you don't have to get a sterile urine to do a dipstick. You can wring out a diaper. You can wring out a diaper And if there's any fluid there, you stick a dipstick in it. If it's negative, it's negative. It doesn't get worse or better by being in a diaper. But if it's positive, then you have to pursue the getting urine in the through a catheter or a suprapubic tap. But this is called a screening test. Screening is negative. The child is well appearing. Don't need to do anything further. 3, 4, 5, 6 a month older. Certainly a older kid. This works. The younger the kid is, the more likely this technique is to work. The older the kids, it works less frequently. Risk factors for girls. So the AAP came up with risk factors for girls and risk factors for boys, of which you're not going to remember any of them. I'll show you a app that is better than this in terms of who needs to get what. Further assessment of whether a kid's low risk or not. Let's see. Well, yeah, we already did. See, I don't want to do number one. I don't want to cast these little girls or these little boys. I don't want to do that. I'd like them to get a urine, whether it's a wrung out diaper. I don't care where it is. Get a urine and stick the dipstick in. That's a screening test. If the screening test is positive, then you have to do the cast. But you see some places where they're casting every little kid that comes into the emergency department because they're looking for some fevers. Well, you may want to do that in a 1-month-old where the risk may be substantially higher. But even in these hospitals, which are pediatric emergency departments, they're casting kids like crazy. And I see no reason to do that. Screen it. The screening is positive, then go. Screening, the nitrate test, high sensitivity, high specificity. This is what you ought to get. It's called UTI Calc. It's from the University of Pittsburgh. It was part of a project that was looking at the risk factors, and they basically said, wow, well, we can put this together in a really simple computer program. They did it, they validated it. It's better than the AAP recommendations. UTI Calc decreased testing by 8% and decreased cases of missed UTIs. The establishment of a UTI needs both bacteria and pyuria. You need to have pus and you need to have bacteria growing. And depending, some people have a different threshold. Some people say 10,000 colony counts from a suprapubic tap versus 50,000 colonies from a cast urine. And you also have the use of the antibiogram in your hospital to determine, if we find something, what's going to be the therapy. Look at this. Initial treatment is equally efficacious orally or parenterally. There's always this attempt to, okay, get that ceftriaxone shot again, find it, we'll use it again. And when in fact all of these antibiotics we're giving are concentrated in urine. So don't need to give parenteral therapy for a UTI, otherwise known as pyelonephritis, in a febrile child. If you are going to give a shot, ceftriaxone is a drug of choice because it lasts 24 hours. If you are going to give a pill, the only once-a-day pill that they advise is Cefixime. Cefixime is expensive. Even with the good RX coupon, it's relatively expensive. That's once a day. Trimethoprim sulfamethoxazole is cheaper than Cefixime, but I'm surprised that it is as expensive as it is. And there's a bunch of other drugs that you can use twice a day, but it seems like these are the most common that you're going to pick. And Bactrim is going to be at the top. Twice a day dosing from the parent to the child should not be considered to be overwhelming in terms of its difficulty. Now the idea here is you miss this kidney infection, you miss this pyelonephritis, now the kid's going to be on dialysis because the kidneys are going to get scarred up and the like. And the fact of the matter, that's really just not true. Here's a review of 10 studies looking at this question specifically, and they looked at all their own data, and basically, even in data that was kind of like so-so, they put it on the side of, yes, it's causing kidney failure. And basically, it's concluded that it would be rare to have that happen. And the other thing is usually after one infection, people do an ultrasound to see whether there's normal collecting of urine, and if there's no abnormality on an ultrasound, they usually kind of stop and say, with normal kidneys, that UTI is not going to cause any problem in the future. Oh, did I skip one here? Yeah, let's go to pneumonia now. This is based on the IDSA and Pediatric Infectious Disease Society guidelines that came out in 2011. They're going to be reviewed, but I think, honestly, if anything, they're not going to substantially change them. Obviously, when to admit, they're going to be pretty straightforward. One of the things that we may not consider is, what's the home situation like? If they're going to be able to watch a child, that they seem reasonable, that they have a car, all of those, telephone, all of those kinds of things. And then the rest is how sick does the child look, which is a clinical assessment. Testing, they don't like you to do blood cultures in people who are basically non-toxin, fully vaccinated. Strong recommendation that you not do any blood cultures. Sputum gram stain and culture, maybe, if they're admitted kind of thing, maybe. Urine antigens for strep pneumonia and others, strongly not recommended. More testing. They like flu tests. And if it's around flu season, they say, give the test, and if it's positive, then treat it, even if it's beyond 2 days, which is really hard to support by the evidence, but it's also hard to argue with these guys because these are guys are the authorities. Antibiotics not generally needed or advised in cases of the flu. And that's the nice thing. If it's flu positive, generally you get one infection, and co-infection with a bacteria is going to be uncommon, and that'll get picked up probably on a subsequent visit. You can do testing for mycoplasma if you want. Mycoplasma, this is those things called atypicals. Why are they atypical? I read these different reasons why they are atypical. First of all, they don't gram stain. They have cell walls, but they don't gram stain because the amount of stuff that stains is so small in their cell walls that they don't take up the stain. That's one. Number two is I saw that the X-ray of a case of atypical pneumonia doesn't look like the classic case of a pneumococcal type of pneumonia. So they say the signs of the presentation is atypical. And there was a third one, but the fact of the matter is that there's no solid. I thought the reason was related to the cell wall business, and I'll stick with that one. Don't bother doing accelerate CRP, procalcitonin to try to determine whether it's bacterial or viral. Everybody says you will be misled by doing that. Sure, we'd like a test to determine the etiology, but it's not going to be that easy test. And here is the real, unbelievable statement. Chest X-rays are not necessary for the confirmation of suspected community-acquired pneumonia in those treated as outpatients. You don't need to do a chest X-ray. This is what they said. It's wow. Next thing, bronchitis just went away. You don't need to use the term bronchitis anymore. Now you can say it's probably a little pneumonia that you got there. Oh, pneumonia, that's pretty serious. Amazing. How are you going to distinguish now between a little bronchitis and some viral pneumonia, or I don't know. This is a little to help you distinguish between the typicals and the atypicals, and that's why they call them atypicals, because they're not typical. Typicals on the right. You know, that's pneumococcal pneumonia kind of thing. You've got lobes involved. You have sudden onset. You have fever. You have pleurotic pain. Maybe a little bloody sputum. On the other side, that's what we call walking pneumonia, except for Legionnaire's disease, which can be nasty. It's walking pneumonia. These are some pictures. Normal chest X-ray on the left. Top left is a lobar pneumonia. Bottom are normal middle is pneumonia. But if you look in the middle one, right upper lobe pneumonia, that's the pneumonia that you get from aspiration or TB. It's not typically a pneumococcal. And then the third one on the right is a little of both. These are all viral pneumonias, and in one case, the pneumonia seems so bad that on the top right picture, turn the heart around. I mean, it looks to me like the heart's turned around. But these are all examples of viral pneumonias. Pneumonia key points, treat as outpatient. Antibiotics are not routinely, catch this, even if you say this kid has pneumonia, they say no antibiotics if they're under school age, because they're so likely to be viral. Preschool kids get no antibiotics. Wow. Drug of choice, if you give antibiotics, is 90 milligrams per kilogram of amoxicillin. Macrolides, if you think it's an atypical walking pneumonia kind of thing. Early treatment for the influenza pneumonias. Inpatients, we won't talk about inpatients right here. Here's the charts from the AAP that I think have been blown up in your book that are readable there. So I thought I would include those. And then this is a algorithm for 3 to 36 months that deals primarily with UTIs and pneumonia, which are the two most common things that you're going to be dealing with in terms of bacterial infections in the kids of those age. Okay, we'll stop here. Who's up?
Back.
Oh my God. Well, you can't go any further. You're all the way down at the bottom now.
Yeah. Do you have the, oh yeah, but hold on, let me grab the other one really quickly. Thanks. Okay. Yeah. Now I finally figured this one out. All right, I'm back, and it's the final MSK lecture of the day and actually of the conference. And we're finally down at the bottom of the body at the ankle and the foot. So reviewing the ankle anatomy, I'm not going to go into nearly as much depth as I did with the hand. It's just not necessary. So really you have your talar bone, your talus. On top of that, the tibia and the fibula. On the lateral aspect, there are some stabilizing ligaments. And on the medial aspect, there are some stabilizing ligaments. And that's kind of as far as we need to go there. Let's talk about ankle x-rays, because we actually get a bonus view with ankle x-rays. So you get your standard AP view, you get a lateral view, and you get a mortise view. So let's talk about that. With the AP view, you can see here, this is the AP, you have the tibia, you have the fibula, but there's a lot of overlap between those two bones, and it sort of obscures the lateral aspect of that tibia. I can't quite tell what's happening there. And more importantly, the clear space above the talus, that joint space, is not completely seen. You can see that some of it is covered up by the fibula. On the lateral x-ray, it's great, yeah, right? You can see the calcaneus, you can see the talar dome, you can see the posterior malleolus, but I'm still left quite wanting for a good view of that clear space above the talus. So for that reason, you get a mortise view. And what happens there is the patient's sent over to x-ray and the tech says, can you invert your ankle slightly in 15 degrees? And when they do that, what happens now is all of a sudden the overlap between the tibia and the fibula is less, and now you can finally see this clear space well. And it's important to get a good look at this clear space because even widening as small as 1 millimeter could indicate that that ankle is unstable. Now I want to make a quick note here. If we took all of you in this room and sent you over to x-ray and did x-rays of your ankle, even though none of you have ankle pain, or maybe some of you do, 1 in 10 of you would have this x-ray. And it's not because 1 in 10 of you have a fracture, an avulsion fracture of the posterior talus. It's because there's a very common os that hangs out there just posterior to the talus, and it's a really common cause of inappropriate orthopedic referrals. You don't want to stick this patient in a posterior leg splint and send them to an orthopedic office. So just know about this os, and also, in fact, just know that there are many ossification centers in the foot. So if you're ever feeling like, this is strange, the x-ray is showing this fracture fragment that looks kind of ossified and it's not where the patient's tender, pull up this diagram and make sure that you're not inappropriately immobilizing a patient who just has an os. So we're going to talk about ankle sprains. How many of you in this room have sprained your ankle or know someone who sprained their ankle? feel like everyone should probably be raising your hand right now, right? So ankle sprains are very common. They're much more common than ankle fractures. And typically we think of these more often happening in inversion than eversion. So in inversion, you're putting strain on the lateral ligaments. The lucky thing is that there's 3 distinct ligaments. I don't think it's important that you remember or recognize the names of any of them, but there's 3 distinct ligaments. So if you injure one, or even if you injure 2, there's another one that's still helping to sort of keep that ankle stable. And so for the most part, these are treated with supportive management, RICE or Pricer. Just know that the R in both of those, that's not rest, that's restricted activity. So I encourage early mobilization. I encourage them to move their ankle around to sort of spell the alphabet while they're sitting on the couch, and I don't want them to sit there and not move the ankle at all. So this auto group is back and helping us to figure out who needs an ankle x-ray, right? Everybody comes in with ankle pain after an injury. Do all of them need x-rays? No. And so who needs an x-ray? It's anybody that can't bear weight after the injury and in your ER again, right? This is the same as the knee rules. Anyone with tenderness in the distal most 6 centimeters of either the tibia or the fibula, anyone with tenderness at the navicular head or at the base of the metatarsal. Of the 5th metatarsal. So if you have any of those, you need to get an x-ray of the ankle or of the foot. So now we're moving to the medial aspect of the ankle, the part that gets injured in inversion. And you might wonder, why do we never see these? I think it's really the rarity of ankle sprains. And that's because in contrast to the lateral side where you have those 3 distinct ligaments, the medial side has this really big, strong, thick deltoid ligament that is the confluence of many other ligaments. It's so strong, it's very difficult to injure this. So if you actually have someone who has a deltoid ligament injury, you need to be looking for other concomitant injuries like a medial malleolar fracture. If they truly have an injury where they've taken out their entire deltoid ligament, they likely will need operative repair as an outpatient. Ankle fractures we mentioned are much less common than sprains. I'm not going to spend a lot of time talking about them because you could probably talk about them for 3 hours. There's so many different varieties. They range from anywhere from a non-displaced distal fibular fracture, which is basically treated like an ankle sprain and they can walk right out of your ED, to the very displaced, dislocated, sublux, trimalleolar fractures that need operative intervention and reduction in a much more timely way. So generally, the more unstable the fracture is or the fracture dislocation is, the sooner they'll need their operative intervention. So while we were talking about that deltoid ligament, I wanted to focus on other things you need to look for besides an associated medial malleolar fracture, and the other thing is the Maisonneuve fracture. So there was a guy named Maisonneuve who was sort of messing around in cadaver lab one day and realized that if you really externally rotated the ankle, you could cause fractures of the proximal fibula, really far away from where he was manipulating. Why is that? It's because of the syndesmosis, right? This connective tissue that runs all up and down between the tibia and the fibula. So it allows that any forces that are directed at the ankle can be transmitted superiorly and then cause fractures more proximally. You really think of these, or should think of these, when people come in with a medial malleolar or deltoid injury, and you have to look at the proximal fibula to see if there's been sort of an exit injury. The reason why these are missed and why there are so many bounce backs and M&Ms for this is patients are so focused on their ankle pain and they're not weight bearing that they don't even realize that they also have pain proximally. So it's incumbent upon us always to examine the joint above and below, but especially when you have injuries to the medial ankle. And these are obviously very different management. In one case they can go out, in the other case they'll need full surgery. So let's talk about kids. I hate looking at pediatric x-rays. I find them so challenging. A lot of these orthopedic injuries involve the growth plate, and so there's been a classification system called the Salter-Harris classification system, which ranges from 1 to 5, 5 being the most severe. The way I remember these is simply by using the Salter mnemonic. There's not a lot of mnemonics that are helpful. This is one that's helpful to me. And so for a grade 1, there is S, there's been slippage at the growth plate. There may actually not even be a lot of radiographic findings. Grade 2, there is a fracture above the growth plate, which is less severe than grade 3, in which there's a fracture lower than the growth plate. And why that's more severe is now that's intra-articular, right? Grade 4, I use through instead of to, use whatever T you need to remember it, but that's going now through the growth plate and is also intra-articular, and grade 5 is the worst kind, where it's rammed or crushed, and there's a lot of really prognostic of badness for this kid's future growth. So if you can see here in this image, right, we have the growth plate and then the fracture is lower than the growth plate, so this is a Salter-Harris 3 fracture. We're going to spend the next couple slides talking about fractures of the fifth metacarpal, and that's because this is the most commonly injured fractured bone in the foot, but also that there are multiple different kinds of fifth metatarsal fracture, all of which are different, all of which are separated by a couple millimeters and have very different management strategies. So the first of these is the zone 1 fracture, and this is a fracture of the very most proximal part of that fifth metatarsal. This is an avulsion fracture, and this happens in dancers that go up on their feet, then they have an inversion injury, and the peroneus tendon, it inserts at the base of the fifth metatarsal, and sort of as it gets pulled, it wrenches off a little fragment of that bone. These do really well. You can literally put these patients in a hard sole shoe and send them right out, and they will do fine on their own. That's contrasted with the next one, a zone 2 fracture, a little bit more distal. This is the Jones fracture. You do not want to miss this. You don't want to mistake this for a zone 1 fracture. And here the difference is there's a transverse fracture, and that transverse fracture is going into the articulation between the base of the fourth and the fifth metatarsals. See here, there's that sort of that centimeter or so where they articulate. You do not want, a fracture that goes into that articulation should be considered a Jones fracture, and these are non-weight bearing and can actually have really poor healing, develop non-union as a result of the way the vascularity is, and often or sometimes may require surgery. So very different from the weight-bearing zone 1 fractures. While we're talking about fracture mimics, here's unfortunately another confusing radiographic finding, and that's the apophysis of the fifth metatarsal. Usually you're going to see these in adolescents. Sometimes you can see them in adults if it hasn't fused. How are you going to distinguish between an apophysis and a fracture? The first is that likely they won't be tender there. This is just an incidental radiographic finding. The second is that if you remember those zone 1, zone 2 fractures, those were transverse fractures, right? Here you can see the lucency here, right where the apophysis is actually longitudinal, so that's vertical. So that's the second way you can distinguish between the two. Now as we're moving even more distally into the metatarsal, we're in now zone 3, and we're talking about stress fractures. Who gets stress fractures? It's those people that are sort of casual runners, casual joggers, and all of a sudden they get in their mind that, you know, I'm going to do an Ironman or a marathon, and they're upping the frequency, they're upping the intensity of their training, or someone who traditionally plays sports on one surface and then moves to clay or turf, and all of a sudden you've changed something about your training. And what's going to happen is it's going to be an insidious onset. They're going to come into urgent care, into your ER, and they're going to say, I'm having pain on my metatarsal. You're going to get an x-ray and it's negative. Then they're going to go home, they're still going to have pain, they're going to come back a week later, and their x-ray will still be negative. Maybe by the third visit you may see some cortical irregularity, or you may see nothing at all. Unfortunately, x-rays are just not that good at diagnosing stress fractures. So if I have the right history, if I have tenderness at the metatarsal and this kind of more distal part of the metatarsal, I treat them as though it's a stress fracture, meaning limiting their activity and sending them out to a P&D for potential orthopedic referral if things are not getting better for maybe advanced imaging. Okay, we're in a series now of can't miss diagnoses, and the first of these is the Lisfranc injury. And so I'm going to preface this first with a quick description of Lisfranc anatomy. There's the Lisfranc joint and the Lisfranc ligament, two different things. The Lisfranc joint is the articulation between the forefoot, that most distal part of the foot, and the midfoot, right where the metatarsals meet the cuneiform and cuboid bones. That entire joint is made of a bunch of ligaments. It's really responsible for creating the arch of the foot, but there's one ligament in particular that's important, and that's the Lisfranc ligament. That connects the second metatarsal to the medial cuneiform. And Lisfranc actually was a gynecologist. It doesn't make any sense to me, but he was a gynecologist. He was a gynecologist in the Napoleonic Army, and what he was starting to see is that soldiers riding on horseback were falling off. As they were falling, they were getting their foot twisted in the stirrup, and they were ending up with these really awful midfoot injuries to the point where some of them actually needed their forefoot amputated. And what he found when he was doing these surgeries, I don't know why he was doing these surgeries, is that if you cut that Lisfranc ligament, it resulted in almost the entire foot disarticulating and made the surgery much, much easier. So we know how important that ligament is for the stability of the foot. So how are you going to make this diagnosis? If you get an x-ray and you see this, if you see widening between that first and second metatarsal, between the medial and middle cuneiform, great, your diagnosis is made. You might even see a flex sign, which is a little avulsion fracture in that little spot. But you may have a normal x-ray, and so you need to have a high enough suspicion to pursue advanced imaging. What's going to heighten your suspicion? specifically a twisting mechanism with pain localized to that midfoot with swelling. That should make you concerned. Also, I'm going to have you look at the bottom of the foot. If you see ecchymosis in the midfoot on the plantar aspect, that's really concerning for a Lisfranc injury. And the last thing you can do is a sort of a twisting test where you grab the hind foot, you grab the forefoot, grab the heel and the toes, and twist the foot and see if that elicits pain. But basically, if you have enough concern because of this, they're really pointing to pain at the midfoot, I send them back first over for x-rays, and I have them get weight-bearing x-rays. Here, they're standing, and they're not lying in the gurney, they're standing, and they're shooting the x-ray, and by putting weight down, that's putting stress on that ligament, and it can make the widening more apparent. Now, if they come back, and I still don't see anything, and I'm still like, there really is something going on here, this patient can't walk, I then send them for a CT, and the CT then will give you a definitive answer, yes or no. Depending on the degree of displacement, the ortho will either operate on that immediately, or this can be managed with supportive care, so it's really important not to miss this diagnosis. While we're on the topic of can't miss diagnoses, here's another diagnosis where if you suspect it and the x-ray is negative, you need to get a CT, and that's your calcaneal fracture. Typically happens in people who are jumping or falling from height, landing on their heel. For some reason, is always showing up in the ER at 3 a.m. or so, and the history is a little bit murky. But they come in and they're complaining of this heel pain, and the first thing that goes through my mind is, if you have enough, of an axial load to injure your heel, I better be thinking about concurrent injuries, specifically of the lumbar spine, hips, and knees. So I do a good lumbar spine, knee, and hip exam. Then, when I'm assessing the heel itself, I'm going to get an x-ray, but instead of just getting a normal x-ray, I will actually almost always get this additional Harris view, a calcaneal view, and you can much more clearly see the outline of the calcaneus and see fractures that would be hiding in there. Other thing you can look at is Bowler's angle, and if this Bowler's angle is less than 20 to 25 degrees, even if you don't see a lucency that suggests a fracture, you probably should have high enough suspicion to pursue advanced imaging. But again, if you get this x-ray, you get a Harris view, and you still don't see it, and the patient can't bear weight, and they have the right mechanism, then you're going to get a CT, and I'm always shocked by how apparent the fracture is on CT that we couldn't at all see on x-ray. So if you find these, then the management is, if the fracture is really distracted, it looks like almost like that calcaneus was cut in two, these actually often are admitted by orthopedics, and they're admitted for skin and compartment checks. It feels strange to think of compartment syndrome of the heel, but it happens, and it happens in 1/10 of these cases because there just isn't a lot of room in the heel to accommodate this swelling. If it's not all that distracted, this person can go out for outpatient orthopedic evaluation. Instead of just slapping that posterior leg splint on, I'm putting massive amounts of padding on the heel before putting that splint, because remember, they need room to swell, so you don't want a splint riding right up on the heel and causing skin breakdown and threatening the integrity of that skin. Toe fractures really just don't matter all that much. I remember when I was younger and I was playing soccer, I fractured my toe, and my mom made a huge fuss about it, and she made me this multi-dimensional splint made out of like 5 popsicle sticks and duct tape, and it turned out not only was that bulky and uncomfortable, but completely unnecessary, because for the most part, we don't need to do anything with these. Frankly, these patients often don't need to come to the ER. If they're really non-displaced, they can just buddy tape them to the adjacent toe, send them right out weight bearing. If they really are quite displaced or dislocated, I will do a digital block and try to reduce them there. And then if they are intra-articular or open or involving the great toe, then that's someone I might actually send out for orthopedic follow-up. Plantar fasciitis, again, is not really an emergent diagnosis, but is one we see a lot. That plantar fascia on the bottom of our foot takes a beating. I mean, we're putting stress on this every day of our lives. Patients will classically complain of pain along the bottom aspect of their foot. It's worse when they take the first couple steps and then sort of improves. The thing really to tell them is that it's tincture of time. There's really nothing proven to help this. I sometimes will say, okay, you can try stretches and try getting inserts and try freezing a water bottle and rubbing your foot over it for some relief, but really you just got to wait this out, unfortunately. Okay, so now we are going to talk about the tendon ruptures, and we think of tendon ruptures especially in people who are on fluoroquinolones or on steroids, but the other population you can't forget about is our weekend warriors. And a weekend warrior is someone that sits at their desk all 5 days of the week. They don't move at all. They don't get their heart rate going. And then all of a sudden on the weekend, they think, yeah, you know what? I think I can play soccer. I think I can play an adult rec league, and I can show up 30 seconds before the start of the game and not stretch, and I'll be fine. And this is exactly my husband when he ruptured his. He was running on the field, and all of a sudden he said it felt like someone kicked him in the back of the ankle. And simultaneously, he heard a pop that he thought was as loud as a gunshot, and he turned around, and there was no one there at all. So he knew immediately something was wrong. Luckily, he was playing on one of these rec leagues that was made all up of EM positions. So we went over there, and we felt, and there was an obvious defect, and we turned him on his stomach, on his shins, and we did the Thompson's test, which typically, if you're going to squeeze someone's calf, their foot should automatically plantar flex, and we squeezed his calf, and nothing moved. So we knew he had an Achilles tendon injury. If you are in the ER, this is an opportunity for you to actually use your ultrasound. I'm certainly not good at ultrasound at all, but this one is very easy. If you look at a normal Achilles, you see these beautiful parallel striations, and then if you compare, it's very easy when there's been any sort of disruption, even partial, to those striations when looking with ultrasound. I just sort of hold it in longitudinal view, and that's good because partial tears can be a little sneaky. Maybe they will have an intact Thompson's test. So with the right mechanism and an abnormal ultrasound, I'll still refer them for orthopedic follow-up. When I send them out, I sent them out splinted in equinus. This is in plantar flexion, and that's so that the two ends of the tendon can be closer together so they can start to form an aponeurosis, particularly if the patient's going to opt for a non-op intervention, and then also so that those two ends of the tendon don't start to shrivel up back into the calf. Gastroc tears, same mechanism, much less severe. This time they won't have heel pain, they won't have a positive Thompson test, they're going to have pain a little bit higher up on the calf, and this one just is not as serious and really can be managed with supportive care alone. Okay, so if you're seeing a tib fib fracture, this patient likely underwent a good amount of trauma, and the problem with these fractures is that, remember, like the dorsal aspect of the hand, the skin on your shin is very, very thin, and so it's very easy for these fractures to turn into open fractures. So like my lacerations around joints, I do a really good job of scrubbing, make sure that none of the abrasions on the shin are actually a result of an open fracture. Almost always these patients are getting admitted either because they have an open fracture or they need surgery because these bones are really out of place, or also for compartment checks and concern for compartment syndrome. So let's talk about compartment syndrome. The lower leg is an area known for compartment syndrome, and what happens there is that there are several compartments in the leg, and for one reason or another, whether it's a fracture or a crush injury or a snake bite, the pressure in one of those compartments gets higher and higher and higher, and as it gets higher, it starts to press down and compress the arteries and the nerves running through that compartment. And so we're classically taught to look for compartment syndrome with these 5 Ps, right? Pain, sensory findings like paresthesia, motor finding like paralysis, pallor, pulselessness. I hope you're never in a situation where you're making this diagnosis because you have all of the 5 Ps. Rather, we need to catch this early. And how are we going to do that? We're going to focus on the first P. So there's 2 ways to do that. First is that we've all seen patients with fractures, right? And if you give them usually a Norco or a single dose of an IV opiate or maybe a dose and then another 4 hours, another dose, you can control their pain. We really can. If you have the patient who's just chewing through pain medication, IV pain medication, and you're just sort of doing it and doing it and doing it, get off that hamster wheel and sit back and think, am I missing a compartment syndrome? This should go right up to the top of your list. The second is pain with passive stretch. So if they have a tib fib fracture that's kind of proximal, and I'm down near the foot and I'm looking for cap refill on their pulse, and I sort of, accidentally or on purpose wiggle the great toe a little bit, and all of a sudden they scream in pain, and their pain is actually up near their tib fib, this should be concerning to you because it's suggesting that even a little bit of passive stretch of that compartment is causing pain because the pressure is too high there. So if you suspect this, you need to actually get an invasive measurement of the pressure of that compartment, usually using a device like this, a Stryker device. If you know how to do it, great. If not, call an orthopedic surgeon to come in and do it. In the meantime, do everything you can to lower that compartment pressure. Get the extremity elevated. If there's any sort of circumferential dressings or a splint, get that off so that that's not compressing the compartment. And then ultimately, orthopedics will need to come and take this patient for a fasciotomy to save the limb. And I'm going to close out this lecture with a quick discussion of a learning point you can hopefully take from my own mistake. I had a patient that came in and, they were they were like GCS3, they were hypotensive, hypothermic, they'd been down for 3 days. I was concerned for mixed edema coma, and they had all these electrolyte derangements, and I took care of their airway, and I took care of their blood pressure. I gave antibiotics, I just fixed all the derangements. I really thought I did an amazing job with this patient, and then I sent them up to the ICU. And I went back 3 days later just to follow up and see how he was doing, and then I saw an operative note, and that never feels good. So I went and I looked, and it turns out that the patient had been down on their upper extremity for a prolonged period of time and had developed a compartment syndrome of their upper extremity, had to go for fasciotomy, had a really bad outcome of that upper extremity. So what I want to say and leave you with is that it's one thing to think of this diagnosis in patients that are alert and able to talk about pain out of proportion, but it's really incumbent upon us, particularly when patients are intoxicated or unresponsive or have depressed mental status for one reason or another, to actually do that full neurovascular exam of all of the extremities, check pulses, check sensation, check compartments, and make sure they're nice and soft, because you don't want to end up with a patient like I did. So that's my last remark. Thank you, everybody. And feel free to put questions on Slido or email me directly.
All right. Oh, there we go. Do you want to tell what's going on? We're going to have Q&A.
So we're going to do the standard Q&A, and that's going to be followed by a podcast presentation where we're doing with Martha and Mike Sharma. Their two-view podcast is going to be recorded right now. So if you want to stay, great. And if you don't, it's strictly optional. That's Martha.
Hi.
What's going on? Where's Martha?
I don't know. She got held up.
Is she not over there? Is she? Is Martha over there? Martha runs this. Well, I guess we have to read these questions.
Want me to read them?
Yeah, let's start. Will there be an Advanced EM boot camp course this year?
A live one.
We have tentative dates, but nothing absolute for that. You can always get the one most recently recorded one on the self-study version. We do have boot camp dates for this course in the July and December again.
Feel free to raise your hand and ask questions too if there's anything.
Can you read the next question?
Yeah. Will the additional information after our final lecture be on the live stream? Also, do we need to be present to be entered to win the advanced course?
Yes, you have to be here. Come on. Hang out for a little bit with us. It'll be a good time, I promise, okay? Really good stuff. We're talking about a lot of different stuff we didn't talk about during the course proper and kind of elaborating on some questions that we did not answer here. So yes, please do stick around. It'll be fun, we promise, and it won't be very long either. So I got to date my wife at the Venetian later on, so we're not going to run long, I promise.
And will everything be on the live stream after the final lecture? The additional information after the final lecture will be on the live stream?
Yeah, so we still have, like, don't tell anyone, we still have stuff from the July original boot camp on ccmelive.org. So, like, there's stuff from back then, too. So this will stick around at least for the next few days. And then the podcast stuff will always be at our podcast website. That's 2view.fireside.fm. We'll put links to that in Slido tomorrow. We'll talk about it. It'll be in the, we have a bunch of other video casts from us in the ccmelive.org. So if you're ever trying to figure out how to get back to these things, ccmelive.org. It's not .com, it's .org. Okay.
And I can take this next one because this is from the
was
procedural
yours, yeah.
analgesia. Can you explain the finger nerve block? This was the question. Can you explain finger nerve block? So yes, we've got nerves that run on either side of the fingers. And so really what I recommend doing is just pulling up a picture of the where the nerves run in any area you're about to block. So if it's the toes or the fingers, whatever you're going to do, just take a quick picture. Just take a quick look at a picture of where the nerves are so you know what you're trying to hit. But there's a couple different approaches. What you want to do is pull up a little bit of lidocaine, and you only need a few cc's. I like to start a little bit further back, so down in the central area. You're going to direct your 27 gauge needle toward the nerve, so into the skin, under the skin, directed towards the nerve on the side, on the lateral side of the finger. Inject a little bit, maybe a cc or two. Pull back without actually removing the needle from the skin, and direct it towards the other side, the nerve on the other side, and inject a cc or two. And you should get really good analgesia with that. You can also do it on the palm of the hand. So depending on kind of, how effective that is. It takes a couple seconds to get down towards the tip of the finger. For example, if you're removing a nail and you need it at the tip of the finger. Of course, take precautions. First you're going to clean the area. You're going to talk to them about, if they have any contraindications. But that's the general procedure to go along the side there. Does anyone have any other tips about how they do their finger blocks?
Go ahead.
Yeah, I'm going.
Repeat the question.
Oh, sorry. The question, I think I heard it correctly, is about how deep are you going? Are you just going right under the skin, or are you going a little bit deeper? On the volar side. So I am going a little bit deeper. It's not just under the skin. So for example, when you're going to do an abscess and you make a wheel, when you make a little wheel and then you go deeper, you're going deeper than the wheel. Okay, so you are going deeper. You're trying to get towards where the nerves are along the edges of the finger there. So in and down deeper than you would for a wheel. Like, you should not see the skin making a wheel. It should be deeper than that. Now you will see the side of the finger kind of fill up with a little bit of your anesthetic. It'll get a bit fat on the edges there, but it's quite a bit deeper than if you were making a wheel. Okay.
I think a key too there is, this is different than local anesthesia, doing a nerve block. Local anesthesia with lidocaine, a minute, and you're pretty much good. I like giving my finger blocks like 10 or 15 minutes. Like, I really do take some time, let it get in there. I can kind of like do discharge paperwork in the meantime, right? And then I come back into the procedure, lop back my computer, hit print, and that's a good use of that 10 to 15 minutes, other than just looking at each other awkwardly across the room,
They'll be able to tell you too. They'll say, oh, I can definitely feel it here. I don't quite feel it at the tip yet. And you'll keep checking. You'll come back with a sharp, just a little bit of a sharp tip and kind of test them. And they'll say, that hurts. And eventually they'll get to the point where it's like, well, I can feel that, but it doesn't hurt. It just feels like pressure. And that's when you're good.
And you can always block them again, like farther down the finger. I wouldn't do it in the exact same place, because you can kind of get some, like, a little bit extra swelling there, too much swelling in one area here. There's also this cool trick that I learned a long time ago. I don't do it as much anymore, and I kind of want to get back into it. Has anyone ever heard of this modified transthecal technique. I think it's just such an elegant way to do a digital block. I don't do it enough. So this is a thing where you are actually injecting lidocaine into the tendon sheath on the palmar side here, okay? And that sounds kind of crazy, but hear me out. What's nice is that it's one injection, okay? And you go at the crease at the base of the finger, and what I do is I have them go palm side up, and I put the needle straight down in slowly until I kind of bump against the bone, okay? And I'll even maybe feel kind of a little bit of a tension and then a give as I go through the tendon sheath, bump the bone, and then I withdraw a little bit. Then I'm putting pressure proximal to that, okay? So like almost on kind of like the metacarpal head here. What happens is you're going to squirt lidocaine into the tendon sheath, and it can either go distally or proximally. I don't want it going proximally, so I'm putting pressure over the metacarpal head, and I gently start to push in about 2 cc's of lidocaine. And we've heard about how much these digital blocks burn. Like the other kind of 2- and 4-sided digital blocks burn. This feels different because you're not injecting it into the skin, you're doing it into the sheath. People feel a lot of pressure, and it can be kind of unsettling, the amount of pressure, so you kind of coach them, hey, it's going to feel like your finger's about to fly off and hit the other side of the room here, okay? It's not going to happen, I promise. And you go ahead and gently do that, and you just hold pressure proximally. I like to do it for 30 seconds or so, and then I walk away again 10, 15 minutes. The idea there is that the lidocaine goes down the tendon sheath, and the tendon sheath is like a leaky garden hose, right? So what happens is the lidocaine kind of like diffuses out of the tendon sheath and starts to hit all the nerves there out of just one injection. And there's been kind of like trials, which one is more comfortable, which one works better, what have you. A lot of like the trials prefer that version. And I can go into more stories later on about how we actually ran our own trial in Afghanistan with 20 of my medics. I won't probably say any more about that right now, but we tried it and it works pretty good. I like that practice sometimes too. I talk too much about that.
I guess the common denominator here is it's one stick now, not 2.
Yeah, that is a nice way to do just one stick and then it's over. And it's not burning, it's a lot of pressure. Some folks are wigged out about the pressure, or the burning, rather.
Can somebody read the
Yeah. So the next one just says, I recommend putting the podcast on the schedule next time because they would have liked to come, but they bought tickets to a show. So that's good advice.
Thank
Definitely.
You. Yeah, it was kind of a last second thing, and we changed schedule. We are going to plan this better for sure. Thank you. I appreciate that.
And the next question is, what would be the ketamine dose intramuscular for pain control? So that's a good question, and I'd love to hear your thoughts, but remember subdissociative dosing for pain control of IV ketamine is about 0.15 to 0.3 mgs per kg, and what I do for intramuscular is I always double my IV dose. So for example, if I'm going to do dissociative dosing or even intubation dosing, you're moving towards 1 to 2 mgs per kg IV, or for intubation, 2 mgs per kg IV. And IM dosing would be double that, so usually 4. And so if you're going to do intramuscular for pain control, you're moving towards like 1 mg per kg. What about you guys? Is that about what you would do?
I would be a little more cautious just because I've seen more cases, especially when you're talking about like more elderly patients where sometimes maybe you had hard IV access or stuff like that. So you're trying to just give them something quick for pain control. I've noticed this, again, more from the EMS side of speaking with things where sometimes people get into that like K-hole where they get into a little more than the low dose pain control threshold, and they get into this like partial dissociative state. And grandma riding in that zone is not very fun for anyone. So probably one to avoid there with that. So just go low and slow if you do that way. The other thing I do is I do intranasal ketamine instead, because it's quicker and easier for me to do repeat dosing of it, and I feel like I'm not taking something that is harder to take back. But ultimately, when you can do the IV, when you're doing low-dose ketamine, because it is a little more forgiving, you can give it slowly. Something else I don't know if we talked about so much when we were talking about ketamine earlier is especially when you're talking about these like low dose for pain control, infuse it very slowly. So, and when I'm talking about that, I'm talking about like 10, 15 minutes. So like put this on a pump if you can, or just a really slow drip. Like if you have a 100 cc bag, or better yet, a 250 cc bag, and just let that slowly drip in. And what I do in the emergency department is I give the patient or their family member a call light. I say as soon as they start feeling funky and it's no longer helping them, they start feeling a little bit weird, please hit that call light. Either myself or someone else will come in, we'll turn that off right away. And they might start getting into some of these little effects where they start feeling a little out of it. And usually within about 5 minutes, if not before then, they're right back out of that, but their pain is still controlled. And that will save you a lot of the headaches that can come with giving it too quickly.
And that's IV, just to clarify.
Yes, yes,
that's
IV.
The IV. But
Not
that I
a
love
slow
the
dose.
drip. That's really nice.
And the intranasal ketamine is also going to be a higher dose than what you would for IV. So sometimes 2, maybe up to 4, but I like to just double, just because it's a little bit easier and more forgiving. So again, if you just double what you would have been that IV dose, and a lot of times I'm doing actually like 0.1, 0.2 milligrams per kilogram to start with, and then kind of work my way up. But we also have such a ketamine shortage at my hospital. We have 20 milligram pushes that we have our pharmacy make up, so that way we can do that low dose ketamine without having to drop a whole syringe.
Is the ketamine shortage your fault?
Actually, it started that way, yes.
One more thing.
Oh, yeah.
Great manual out there by one of our kind of like friends of CCME is Sergey Motov, Dr. Sergey Motov. He's at Pain Free ED on Twitter. But the EMRA Guides series, he has a guide out there that is all about acute management of pain. It is in my everyday carry in the ER, because there's just so many of these little dosing things and little pearls on how to dose, how to administer. I don't have room for it up here. And so I like having a smart book just for that, because I hate screwing that up to where either the patient's still in a lot of pain or they're in the K-hole and now I got to pull them out of it very slowly. It just takes time. So like I like having an extra resource just for that. Just like I have an extra resource just for antibiotics. I've got a little smart book for that too. I think pain control nowadays, we have so many modalities that do a lot of cool things, but that comes with more knowledge required to use them right. So I like having a little resource for that. Yeah, so it's if you go to like EMRA, EMRA, right, EM Residents Association, there's a bunch of little pocket books here, and I can't call up the exact name here, but if you look for pain, the pain book, and Motov, M-O-T-O-V, is one of either the co-author or the author or one of the names on the cover. That's the one I'm talking about here. Super good. So what the question being asked over here, if I can kind of like condense, reformat, and put back out here, is like, it's almost the curse of too much information. We have Tintinalli's, we have this book, we have that book, we have whatever. How do I put it together in some sort of a framework so that when I have a patient in front of me, I can make quick decisions smartly and go forward, instead of having this paralysis of analysis of like, I have all these resources and maybe hard to consult all these things here, what do I do? I have, for me personally, I just have a couple of favorites. Like I have a couple of drugs I feel very comfortable with, and I kind of lean on those. And the other ones I have, I don't really use as much, you know? How about you guys? So then if I just know really well a couple of drugs, and they work for most every situation, I don't have to worry about the rest of them as much. How do you guys deal with all the options we now have for pain control?
Yeah, this is kind of my approach for when I was starting off, and again, I think pharmacology is something that it's kind of like lacking in our education, and you don't get it until you're actually seeing patients, and then you're suddenly expected to know it, and you're supposed to know every drug and every dosing. And so when I was first kind of gathering that, I used Notes on my phone. You know, the actual application Notes. It's on your cell phone. So I would start to make little lists for myself about drugs that I would use or procedures. So I have a little note on ketamine, pain dosing, intubation dosing, procedural sedation. Just boom, I can pull it up, there she is. Same thing for intranasal Versed or intranasal fentanyl, things I know that I'm going to use in kids and kid dosing. I would keep that right there so I could easily pull it up. Some of my colleagues would use Evernote, that's another app that you can pull up, and also Google Docs is great because again, you can just, it's always there, you can edit it, and you can pull it right up on your phone. So that, I always have my phone with me, and I would pull up those little notes and just make them as I go along. If I started to encounter things that I was using more often or that I would always forget, I made a note about it so I could quickly access it. What about you guys?
Are you asking just about pharmacology, or are you talking about kind of all different references for like? So this is actually part of the reason why I started my own blog and podcast, was because there were certain topics that I wanted to like try and remember. So kind of like the Salim Razai, same deal with like Rebellium, why he started that was because of that. Not everyone can just start up a blog and podcast though. So other ways to do that is actually find trusted resources like this. I mean, you've got the huge benefit here of you have a binder that you're going to go home with that has this information, but even that can sometimes be hard to filter. Sometimes there are other online resources like I know for certain things that I'm looking for that I go to X website or X resource. And for me, this is just my personal preference. I don't get money from any of these people, but Up to Date is a good one for kind of if I just want a quick reminder. Now, keep in mind, a lot of these are a professional opinion or they're not always the strongest of evidence, but they are still a great guide. And something that I can get like a quick, if it's more of just, hey, I want some good general outlines of it. If I'm worried about critical care, like I use more of like an MCRIT. For my medications, I like using Hippocrates. I have the paid version of Hippocrates, and it's nice because it talks about, like it'll even have based on complaint and situations. So if I'm trying to remember the different antibiotics I can use for pneumonia because someone's allergic to 5 different antibiotics that I normally use, I've got an alternative instead. So those are the types of things that I would use, but everyone's a little bit different. Some people want textbooks. I'm terrible with textbooks. As Mike knows, I have literally one book with me on shift, and that's the one that's the Resuscitation Crisis Manual, because I keep that one on me because it's bullet point. Like I can immediately pull up and run through what has to be done immediately with the patient to reverse the complications in the serious situation. But that's the only physical book I keep on me because everything else is online. It's either on my phone or it's on the computer that I can pull up within seconds. But some people love their textbooks, and that's awesome. Tintinalli's or any of the others out there are also great references, like Mike's talking about.
I have to put in a plug for MRAP. Now, I was a big user of MRAP as a resident, and that I do some work for them, so I have to tell you that. But they have an online textbook called Corpendium, and they're working on making that better all the time. And if you have a subscription to MRAP, which many of us do, then you can just access it. And this is specifically for EM providers, clinicians. So this is going to be all the quick access things you need to know working in the emergency department, and it's kind of like up to date, but more for ER providers. So it's a great resource. They have a pharmacology section and kind of answer all of this. So I would say at least check it out and see if you like it. The next question is, what is contraindication of antiviral and suicide?
I think Martha answered that on the Slido, that there were certain antivirals that did increase suicidality, and that's something to look for. That's not super common, frankly. I don't think I've ever felt urged to remember I got to counsel them that if I give them this drug, you might feel compelled to commit suicide.
I do warn people with Tamiflu specifically, and I would give the generic, but I'm terrible about pronouncing that one. But that it does seem to have, and this is just more out of personal experience with it too, it does seem to have more frequently some psychogenic effects that occur with it, not necessarily suicidality, but it can even just make people more anxious and stuff like that. The other thing is I've now seen this twice, people who do not have previous history of seizures, who were adults that developed seizures after taking Tamiflu. And one person, he was actually one of our physicians, he was our medical director, and developed epilepsy and quit practicing emergency medicine. But it all started after he developed influenza and took that medication for the first time. So just another rare thing that can occur.
That's terrifying.
Just one more reason not to use oseltamivir.
Seriously.
Thank you. Also Tamiflu.
Let's jump down to the question at the bottom here. Any restrictions for fluticasone, which is brand name Flonase, if we're talking the intranasal spray here, can they continually use it for runny nose or nasal congestion? So yeah, fluticasone is more appropriate for chronic use, okay? And that can be, like my daughter, my 10-year-old daughter has used the little kiddo fluticasone for a long, long time because her allergies just smoke her in Dallas. It's pretty bad in Dallas for allergies. What's cool about fluticasone as well, and I apologize, it probably was covered in the talk, but if someone gets that rhinitis medicamentosa, which I just love saying, that's why I said it just now, but if they use Afrin too much or phenylephrine too much, you get that rebound congestion, the worst congestion of their life. Fluticasone is a way that you can treat that. Instead of just saying, hey, deal with it, fluticasone is a treatment for that kind of medication-induced rhinitis.
Sorry, I'm a little bit late. I had a bumble date with a guy named Jimmy Chu. No, I am.
Chu, if
I'm
you're
sorry.
nasty.
I was giving CPR to someone on the strip. Also a lie. Okay.
Go ahead.
So to rephrase the question so everyone can hear it, basically, especially with lower extremity injuries, does it, for someone where it might be more beneficial to get the MRI, but you can't get it because you're in a resource-limited setting, which I very much feel for that. Do you have to have the MRI, which means to transfer out to somewhere, or can you do a CT in lieu of it, or a CTA? So one of the classic ones is like a tibial plateau fracture, which the CT is most of the time, especially if you have a newer generation CT scanner, a lot of these like occult fractures that we worry about, you can still pick up. I'm not sure what generation CT you're working with, and that can play a role there too. But if you're working with a relatively newer generation CT, you can still pick up most of these fractures. I can't think of a single fracture that you might not pick up consistently. I know the sensitivity is probably going to be a little less than MRI, of course, but I don't think anything that's going to be necessarily like emergent surgery can't wait till ortho follow-up, assuming that you can get reasonable ortho follow-up. Can you guys think of anything?
I couldn't think of anything either. I think, just always err on the side of caution. Like if you're worried about a Liz Frank, you're going to make them non-weight bearing, and you're going to, make sure that they follow up. So if you can't get that confirmatory test, you're going to splint them.
I feel like that's generally, unless there's some suggestion of neurovascular compromise, if you're not sure, non-weight bearing, crutches, and close outpatient follow. I feel like that's usually appropriate.
Yeah.
Right?
Just when in doubt, splint and follow up. That's usually.
Yeah, and don't use that extra.
And don't use it. Yep.
Why is that not refreshing?
And then also, if you start to have neurovascular compromise, you're coming right back immediately. I still remember hopefully they're not watching this. It was, I was overhearing parents of kids at a school that my kids go to, and the mom was talking about her kid who had gotten broken something, right? And, got splinted. The kid started to complain about uncontrollable pain, worsening pain and weakness and tingling in the hand or whatever, right? And the mom said, oh, well, I just kind of like didn't do anything. And the next day I took them into the ER, and immediately they had to take the splint off and put it back on. Can you believe they can't even splint my kid right in the ER? And I just had to bite my tongue almost clean off my face to be like, your child was telling you what was needed. He had uncontrollable pain. He started to get neurovascular compromise here. And instead of you bringing him back right away, which I'm almost positive they were told, they kind of blew it off, and the kid kind of suffered a little bit. So it's kind of funny how people kind of twist things in their minds as to what I think they might have heard to save their own ego. So in that situation as well, the whole reason I say that is that clear, just like talking to the patient, the second you feel XYZ, you have to come back, not later, immediately. I'm also writing this in your discharge paperwork that you're signing, so that later on, if there's a problem, like it's not unclear that we talked about this,
Okay. What is your best approach to digital block?
Done, check.
Yeah,
We
did that
answered
one.
that.
You did that. Okay. Just making sure you're awake.
Go ahead.
Have we done the next?
Next one.
Yeah, we done? Okay.
How about the MDM? Do we answer that
Okay.
one yet?
Is there a specific format for writing the MDM section of the chart?
So I included some links in Slido specifically on that. So I interviewed a gentleman by the name of Mike Weinstock with EM Bounce Backs. So he is, if you're not familiar with the EM Bounce Back series, it's definitely one to check out because Mike Weinstock basically takes a bunch of real cases and goes through what was right, what was wrong, what happened, and it's incredibly helpful. It's not necessarily going to be in of itself how you write an MDM. That's what the podcast was more for, was talking about like some tips and pearls with that. And then we had a separate podcast interview with Kevin Clower, who's a medical legal expert. And it was also like 10 documentation pearls, which included MDMs. I think everyone writes their MDMs maybe just slightly different. Some people use it, especially I notice people who use scribes, they tend to almost like, I don't want to say rewrite their narrative, but they tend to give a little more detail of like, let me reintroduce this patient. Me, because I'm doing it all myself and I know exactly how my HPI is and I like my HPI the way I set it up, mine is, okay, these are the things I was thinking of. These are the things that I was not concerned about. I make sure that I list like, I try and think of at least 3 really bad things that could be going on and explain that I was not, I'm not concerned about that, or I've effectively ruled it out because I've done, testing. And then I talk about what I think is most likely what's going on, but also that, the proper management for this, the, warning signs and symptoms that I want them to come back for, and also make sure to document, like, if we gave medications that have known side effects, about that. So I try and make sure to document, like, we had a good thorough discussion, this patient is appropriate for a safe discharge home, and they understand and acknowledge this plan as well. So like that's kind of my version of an MDM usually. If you're working main ED, or if you're taking care of someone who you're in and out of this room multiple times during one stay with them, I actually use with Epic, it's the ED course, but there's kind of a similar thing in a lot of charting systems. Is I almost use that as an MDM because your thought process changes over time. You have a positive D dimer that came back that you weren't expecting it to be positive for, and now you're going down this pulmonary embolism pathway, and it can sometimes look good later on. Like I said, my parents and my wife's an attorney, and they like to point out that one thing is that they like to see that because it explains why my mindset shifted later. And hey, why didn't you deal with this 2 hours ago? Well, I was not thinking about this 2 hours ago. Or this patient suddenly decided to start crashing on me, and I didn't have anything in my initial assessment to lead toward this. Or maybe now they think 2 hours later about, oh yeah, I had this going on. So it can sometimes really help you out. and it can really kind of illustrate what's been going on in almost a real-time fashion. So I don't know if anyone else does that either, but that's something I do when I'm in and out of the room quite a bit.
Sounds reasonable. I think you also ought to put down whether you've made any phone call consultations with anybody. You've spoke with the family physician that'll see the patient tomorrow, something to that effect, so that those consults get put into this package. Also, I think that these things are best done at the end of the visit, where you can synthesize the whole thing into a logical picture which is consistent with your discharge diagnosis.
Remember when we were in school and learning SOAP notes and S-bars and things like that? I think it's really important, like you said at the end of the note, say this is a 25-year-old male that was here for chest pain. The differential diagnosis included but was not limited to. A workup was completed with the following labs. The troponin was negative. The heart score was this. I considered doing chest x-ray, PERC negative. I had a thorough discussion with the patient about the plan and the discharge information. I made a phone call to the follow-up physician who will see him in 2 days. And then that's like a really nice summary at the end.
That's a great MDM.
You like that?
See, I differ a little bit, but I think it's probably more because my EMR is formatted differently here. I don't like to repeat much because I don't like spending much time charting. I spend too much time already charting. And so if I know I clearly talked about PCARN or heart somewhere else in the chart, I clearly mentioned that I noted abnormal vital signs earlier in the chart, I clearly did something else in the chart, I don't like to bring it up again in the MDM. Just the more you duplicate stuff, I don't think there's any value added necessarily. I think that there are some things you want to highlight as far as like, if you have all these kind of disparate facts sprinkled throughout the chart, and then you want to highlight why you're not concerned about PE specifically or ACS specifically. You kind of synthesize that a little bit, but I don't think, especially if your EMR is formatted well, including some risk assessment stuff at the start of it, you don't have to repeat as much. It's not going to help. You won't be more medically legally defensible if you're duplicating information that's already clearly somewhere else.
You know what else is really helpful? If you're really busy and you just need to time stamp something, and you read the results of the radiology report at 8 o'clock, and then you just put 8 o'clock RADS results, and later you can go in there and copy and paste it if you want to, and just that's what I used to have scribes do for me, was just timestamp things for me, timestamp when I went in the room, timestamp when I made a decision, and then you can remember what you did. Just write a little note to yourself. Now that might be too much, and maybe not Mike's style, but it works.
No, I actually do like that a lot.
Oh, okay.
When it's a prolonged course in the ED, I do like, and Chip kind of alluded to that too, it's like what I thought when they first came in. Mm-hmm. They were obtunded, and they were, whatever, and it's like, there's a lot of diagnostic uncertainty right now. I don't know what's going on with this patient, and then later on, timestamp, like you were saying, okay, we got some stuff back, the patient remembers their name now and where they are, and I can do more of a history and why things progressed as they did. Like, why didn't you order this test earlier? Well,
so what I think you said something there really interesting. It's okay to say the diagnosis is not clear at this time, the patient is unable to talk to me, or the patient is suspected to be intoxicated, smells strongly of alcohol, or whatever it is that you want to put in there as to why you couldn't get it right away. So maybe consider those things. It's okay for you to say, you don't have to say like, I don't know what the hell this is, but we're going to do a workup. There's some of this.
There's ways to say that without saying it, right? Yeah.
Go ahead.
No, you go.
In the first medical legal talk, there is a page in there that basically breaks down the 4 elements of the medical decision making that CMS is interested in. They're interested in the number of diagnostic possibilities, the amount of data that you have accumulated to work up this patient, the seriousness of the potential disorders that you're looking at. And there's one more, but I would suggest you take a look at that page, because that's basically, this is what CMS is saying we're interested in.
And then one last thing I'd add is that if you can, when you do your MDM, try and do that before the patient leaves the department, if at all possible, because every now and then you will think of something, oh shoot, like I didn't actually consider that, and I should have considered that. And it gives you a chance to like pause and reflect and think, okay, maybe, you know what, I'm going to go back in that room, I'm going to ask this question, or say, you know what, after I thought about this a little bit more, maybe we should run this test or do something else. that has actually over the last few years has helped me a couple of times catch something that or at least reconsider something that I didn't before. So if you can, it's something that even if you can't finish the rest of your note, if you could do get that MDM started before they leave, it can sometimes really help you out there.
So this question about the EKG course coming up soon, I actually have dates for you. Hot off the press. July 27th through the 31st, we'll be having another pharmacology course. And then the main course, July 28th. Excuse me. So look, July, does this look right to you? Okay. July 27th through the 31st is pharmacology with the main course that we did here, if you have anybody you know that wants to come. December 12th through the 17th, we have another course, but maybe I don't have the dates. This doesn't look accurate. It's going to be at the Paris. Both of them are going to be at the Paris again.
I feel like the EKG course we pair with the advanced course, is that correct?
It is, but these look like we don't have the advanced course, I guess.
If you keep an eye out for when the advanced course is going to be next year, we canceled it this year because Delta was kind of surging, and I'm sure there's other things that we don't have to get into right now, but that's usually when the EKG course happens, with the advanced course. We'd love to have you back and get real nasty with EKGs as well before the main course goes on.
Yeah, keep checking the website. Okay, last couple questions.
We'll let people know.
Yes, we will let you know. The last couple questions here. Can you repeat what was said about the high temp greater than 104 being more likely to be viral, or was it bacterial?
Oh no, all the fevers are more likely to be viral, and maybe the likelihood of a bacterial infection may creep up a little bit as the temperature goes up, but the overwhelming source will be viral.
All these Q&A blogs available to reference after the course? Yes, they'll be available. We also send out the Slido questions with all the resources that we posted. And then lastly, during the pediatric UTI discussion, it was said that UTIs in peds is pyelonephritis. Could it be cystitis, or is always considered pyelo?
Well, nobody ever talks about it. I haven't seen anything about it, but you tell me what is that cystitis with 103 fever. We would never call a woman's infection cystitis if it was 103 fever. So you either have a lower tract or upper tract. It's not in the middle, so I think it's pyelonephritis. And that's why they're concerned about missing these infections or what effect they're going to have later on in terms of kidney function, et cetera, et cetera. So I don't think, frankly, there's any question that this ought to be called pyelonephritis. And I think UTI tends to kind of minimize it, as we don't think that much about the significance of a UTI. It's easily diagnosed, easily treated, easily found.
All right, so we have another question? So can you make it as a clinical decision?
For children or adults?
It is a clinical diagnosis. So the question is, can you diagnose pyelonephritis clinically? And yes, because it's systemic symptoms. So cystitis is really, as you said, lower tract, right? So you've got perhaps some burning with urination, dirty urine. But when you cross the line into pyelonephritis, what we're talking about then, nausea, vomiting, fever. So that's when you're starting to say this person has pyelo. Sure.
And then I guess because we didn't do the morning Q&A, are there any specific questions from the morning Q&A for anyone who's sticking around hoping that we're going to answer those questions?
We actually have about 15, 20 minutes in between our live event. So please come up and chat with us. We'll stick around. And if you want to watch the live broadcast, it will be live. We'll see you all tomorrow morning, bright and early.
Thanks, everybody.
Thanks, guys.
Thank you.
And it's bright and earlier, too, tomorrow morning, right? My first talk is at 7:30.
That's correct.
Just be aware of that. I think 8 o'clock was the first talk for the first couple of days here. I'm going on at 7:30 tomorrow morning, okay?
I'm taking at least 10 Sudafed tomorrow.